Good day, dear colleagues. Welcome to our 70th anniversary celebration. As we enter our septuagenarian years, let us mark this virtual annual convention with the most appropriately timed theme, Rewiring the Anesthesiologist Mind, a collaboration of experts. Let us spend the next 3 days together in this exciting re-engineering of minds, together with our roster of world-renowned speakers from here and abroad. Connect with us and join the panel discussions. We have big goals, and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Rewire your memory to develop a phenomenal recall of these reviews of fundamentals and comprehensive discoveries and updates in our trailblazing field. Rewire your attitude as we evaluate these proven solutions and appreciate the expert guidance as we look forward to promote and maintain a community of responsible anesthesiologists who can practice safe and quality anesthesia care in the pursuit of serving the interests of our members, our patients, and the nation. We are the Philippine Society of Anesthesiologists, and with our strong commitment to quality care, our sincere concern for our members, and our genuine interest for professional growth, we're ready to collaborate with the experts. We begin the countdown now. 3, 2, 1. Rewire!
Good day, dear colleagues, and welcome to the 53rd PSA Annual Convention. In celebration of our 70th anniversary as one society and one family of experts in the specialty, we welcome you to our virtual convention with the theme of Rewiring the Anesthesiologist's Mind, a collaboration of experts. Connect with us and join our planned plenary sessions with esteemed speakers and panel discussions with leaders in the field. We have one on challenges in the management of central airway obstruction, another on translating simulation to evidence-based practices and patient safety, and the last on preoperative assessment clinics. Rewiring our brains is the same as neuroplasticity that refers to our brain's ability to restructure itself when it recognizes the need for adaptation. Listen to lectures on anesthesia in some of our special populations, from pediatric patients up to the anesthesia for geriatrics. Focus on cases of pregnancy, abdominal surgery, and orthopedic ambulatory procedures. We have big goals, and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Join us as we collaborate with each other as we move forward to the succeeding years and decades of the society.
Good morning. Before we begin, let us first brief you with our reminders. For better experience of our event, please be reminded of the following. Make sure that your complete name is reflected on your Zoom upon entry into the event for attendance purposes. For better audio broadcast, you are encouraged to use a headset or headphones. For better viewing experience, please ensure a strong and stable Wi-Fi connection. Please stand by. The program will begin shortly. Thank you.
Hi, good morning, everyone. It's day one of the 53rd annual convention of the Philippine Society of Anesthesiologists. And we would like to recognize the presence of our delegates from all over the country, and of course, even those abroad who are joining us here today. I am Eduardo A. Barrenechea II, and I would like to formally welcome all of you to this morning's session, proudly presented by the Society for Neuroanesthesia of the Philippines, or SINAPS. The subspecialty of neuroanesthesiology continues to grow and develop worldwide at a rapid pace, and thus there is a constant need for us anesthesiologists to keep up with the latest trends and standards in order to provide the best possible care for our patients. As we continue to advance neuroanesthesia in our field, it's important for us to understand its value. Professor Adrian Gelb from UCSF, one of the pillars of the subspecialty, emphasizes that a neuroanesthesiologist isn't someone who only performs neurosurgical cases like craniotomy, spine surgeries, or the like. Rather, a neuroanesthesiologist is someone who is concerned about how a patient's brain, spine, and entire nervous system function and respond to the stresses of any surgery and, of course, while under any type of anesthesia. In short, that is every one of us here present today in this room. So essentially, you can be doing a simple appendectomy, CS, or just procedural sedation and still be practicing the fundamentals of neuroanesthesia. This morning, for the next 2 hours or so, we are fortunate enough to be joined by three esteemed specialists from neurosurgery, neurology, and neuroanesthesiology, and they will all share their expertise in spinal cord physiology and pathophysiology and how to manage patients who may present with problems with this specific component of the central nervous system. I know it's the first day of the convention, first session, early morning, and yet here we are, jumping right into the heavy and technical side of things. I think you'll all agree that's what makes neuroanesthesia quite amazing and interesting. So, without further ado, allow me to introduce our first speaker for this sign-up session. He is a current member of the clinical faculty of the Department of Anatomy at the University of the Philippines College of Medicine. He is also the training officer of the Neurosurgery Residency Program of the Department of Surgery in Jose R. Reyes Memorial Medical Center. His hospital affiliations include the Philippine General Hospital, Jose Reyes Memorial, as mentioned, Philippine Children's Medical Center, Asian Hospital, the Medical City, St. Luke's Global, Manila Med, Manila Doctors, the Los Santos Medical Center, Metropolitan Medical Center, and Chinese General Hospital, among others. Ladies and gentlemen, please join me in welcoming our renowned neurosurgery colleague, Dr. Kenny S. Singh.
Good day to all of you. I'd like to thank the Philippine Society of Anesthesiology for inviting me to be a speaker in this year's convention. It is truly an honor. The topic for this lecture is on neuroprotection in spinal cord injury. Okay. For the learning objectives of this lecture, we'll discuss the types and pathophysiology of spinal cord injury. We'll discuss non-pharmacologic neuroprotective therapy in the current care of SEI. We'll also briefly discuss novel neuroprotective and neuroreparative drugs and treatments for SEI, and also discuss the role of the anesthesiologist in neuroprotection for SEI. So spinal cord injury is actually one of the most debilitating of all traumatic conditions. The global incidence is approximately 10 cases in 100,000 persons. That works out to about 10,000 cases for the Philippines because we have 100 million population here. Experimental and clinical studies have indicated that two phases are involved in SEI, or spinal cord injury. Basically, that's the primary cord injury and the secondary cord injury. After spinal cord injury, approximately half of the 10,000 cases per year end up with some type of permanent neurologic deficit. And a lot of that has to do with the mechanisms of injury. We talked about primary cord injury. This is the damage that is imposed directly by the injury itself, including necrosis of cells, physical transection of axons, and vascular loss local to the injury site. That means the blood supply to the actual site of injury is not sufficient, mainly because of ruptured blood vessels, mainly because of localized vasospasm. So that's primary cord injury. And secondary damage is actually what happens after primary cord injury, which is damage that actually spreads from the site of injury. So parang lumalaki yung sunog. Secondary damage spreads from the site of primary injury and includes apoptosis and further cell death. Aside from the ones that have already been injured, the cells that surround the site of injury actually undergo cell death and demyelination. Okay, for primary injury, these are the fundamental mechanisms. You have hyperflexion, right? That you have hyperextension. All of that can cause damage to not only the spine but also the spinal cord. You have axial loading, or somebody dives into a shallow pool, for example, and the rotational injury. The end effect is usually displaced bone or ligaments, causing cord compression, leading to hemorrhage, followed by hypoxia and ischemia. Right? Secondary injury, naman, the fundamental mechanisms which sort of lead to a worsening of the primary injury is mediated by systemic and cellular factors that set in hours and days after developing SCI. So this is a continuing process that sets in sort of right after primary cord injury. So fundamental mechanisms include ischemia, which may be due to venous pooling in the extremities, which leads in turn to hypovolemia. And then of course there's local vasospasm. Oxidative stress due to free radical production, excitotoxicity because of excess glutamate release, inflammation, influx of cations, vasogenic edema due to inflammation and the loss of the blood spinal cord barrier, and apoptosis. Okay, eventually, after all that has happened, the end result is the formation of the glial scar. Okay, this is what ultimately arrests the process of the secondary injury. Right, so it starts off as a primary injury here, and then, like we said, medyo lumalaki yung sunog until the glial scar forms around the site of secondary injury and sort of arrests it. The glial scar is the result of recruitment of microglia, oligodendrocyte precursors, meningeal cells, and astrocytes. Unfortunately, the glial scar also serves as an inhibitory environment, which form physical barriers to axonal regeneration. Okay, regeneration is prevented by membrane-associated myelin inhibitors and is also prevented by the laying down of the chondroitin sulfate proteoglycans, which makes it inhospitable for axonal regeneration. So just as a review, the acute phase, meaning the primary cord injury, involves severing of the axon, death of the axon and glia at the site of injury, followed by ischemia and some swelling of the spinal cord. And then secondary cord injury sets in where you have increasing edema, neuroinflammation, excitotoxicity, and lipid peroxidation. All of that leads to cell death and demyelination. After that phase has passed, scar formation gradually starts to take place. The maturation of the scar coincides with the axon's attempt at regeneration and axon sprouting. However, because of the inhibitory environment and continued scar formation, it actually leads to the development of a cyst wherein there's actually very little or no reconnection taking place. So this is the cyst right here. You can see none of the neurons are reconnecting in that area. Neuroprotection is actually the administration of a treatment to hinder secondary damage and thus preserve functional tissue. So neuroprotection can either be non-pharmacologic or pharmacologic interventions. So this is what coincides also with the current best practice, which I got from the American Association of Neurosurgeons and Congress of Neurosurgeons. These are the biggest organizations of neurosurgeons in the United States. They came up with the guidelines for management of acute cervical spine and spinal cord injuries in 2013. And recently, the WFNS, which is the World Federation of Neurosurgical Societies, the Spine Committee in 2020 came up with guidelines for pharmacologic and regenerative cell therapy for spinal cord injury. As we all know, cervical immobilization before admission to the hospital is critical. The combination of rigid cervical collar and supporting blocks with a backboard with straps is effective in limiting cervical motion and is recommended during transport. For airway and respiration, keep in mind that 33% of cervical SEI patients require intubation within the first day, and as high as 90% require mechanical ventilation within the first 24 hours. The threshold of intubation should be low, as hypoxia can further exacerbate secondary cord injury. The paralysis of intercostal musculature is associated with a 70% decrease in forced vital capacity and maximal inspiratory force. The good news is typically SEI patients who require intubation have improved respiratory function over the next 2 weeks. There are several neck maneuvers that may be done during airway management. Letter A is how basically the neck is stabilized during transport pre-hospital care. The anterior part of the cervical collar can be removed as long as manual inline stabilization is done. The manual inline stabilization can be from the head of the bed, can also be from the side. It serves to anchor the occiput. You can see here the hand holding the back of the head, and then the arms resting on the shoulders, because it serves to anchor the occiput and the shoulder and the torso onto the spine board, thereby reducing cervical mobility. Cricoid pressure application is also safe in patients with cervical cord injury in order to help visualize more of the airway. While it is a suitable way to avoid the problem of severely decreased mouth opening, manual inline stabilization is far from perfect. Manual inline stabilization allows you to remove the anterior half of the cervical collar, which allows you to open the patient's mouth. However, Nolan et al. Found that when compared to the sniffing position, manual inline stabilization decreased laryngoscopic view in about 45% of patients. That 22% of patients only had an epiglottis view with inline stabilization. In the late 1990s, Rosenblatt and McCaury found that anesthesiologists preferred actually awake fiber optic intubation over direct laryngoscopy under general anesthesia. But with the wider availability of video laryngoscopes such as the GlideScope, video laryngoscopy in combination with manual inline stabilization is fast becoming the preferred method to secure the airway of SEI patients. Awake fiber optic intubation is excellent for elective and semi-urgent situations with cooperative patients. However, this requires a certain amount of expertise and may be complicated under emergency situations. Direct laryngoscopy is still, of course, can be used with inline stabilization, especially for emergent intubation, with the use of the elastic bougie to reliably secure the airway while minimizing the force to the cervical spine. So that's for airway and airway management. Now for hemodynamic management, ischemia of the spinal cord underlies much of the mechanism of post-traumatic SEI and is the important common denominator resulting in neurologic deficit after primary injury. Local vascular alterations are due to direct SEI and post-injury vasospasm, which both lead to loss of autoregulation of spinal cord blood flow. In patients with SEI, they are best managed in an ICU setting for the first 7 to 14 days after injury, the time frame during which they are most susceptible to significant fluctuations in cardiac and pulmonary performance. The loss of sympathetic tone is a major concern for injury in SEI above T6. This usually leads to a lack of sympathetic outflow, which causes dominant parasympathetic tone, leading to bradycardia and hypertension, which is the neurogenic shock. Spinal cord perfusion is noted to be decreased after injury, along with decreases in arterial PO2 up to 7 days. Lactate and pyruvate ratios increase immediately in the area of injury and distally, suggesting an area of expanding ischemia and hypoxia from the injury site up to 7 days later. As in all hypotensive patients, the first step in management is intravenous fluid administration. However, if after 1 to 2 liters of IV fluid, the blood pressure remains low, a vasopressor agent must be given, as these patients are susceptible to fluid overload. The recommendation of the AANS and CNS currently provide level 3 recommendations to correct hypotension as soon as possible, meaning systolic BP of less than 90, and maintain MAP at 85 to 90 millimeters mercury for the first 7 days. So that more or less translates to a systolic BP of 120 and more during following injury in order to improve cord perfusion. Although no recommendation of the specific type of pressure has been given, um, the preferred medication is actually dopamine or norepinephrine. For timing of surgical intervention, according to the surgical timing for acute spinal cord injury study, where 300 patients were enrolled with a 6-month follow-up of about 222 patients, early surgery is beneficial. Early surgery is defined as within 24 hours, and late surgery is defined as after 24 hours. Decompression prior to 24 hours after SEI can be performed safely and is associated with improved neurologic outcome defined as much as a 2-grade Asia impairment scale improvement at 6 months follow-up. For therapeutic hypothermia, its usage in SEI as a neuroprotectant still remains experimental. There has been some case reports and some small human studies reporting that localized or in the actual injured part of the cord is cooled, and systemic hypothermia, wherein the core temperature is brought down to about 34 degrees centigrade, can be beneficial in a clinical setting. However, there's considerable difference, for example, in the duration of hypothermia. The central nervous system function cannot be regained after SEI, unfortunately. And this has led to efforts aimed at developing pharmacologic treatments for SEI in order to reduce neuronal damage, prevent further damage after primary injury, and improve neurologic function. As we've talked about the fundamental mechanisms of secondary cord injury, several interventions have been proposed as neuroprotective interventions, and these are pharmacologic interventions. The most well-studied of all is the methylprednisolone. In this diagram, which we will be going back to several times, we can see that methylprednisolone has effects on several of the basic mechanisms of spinal cord injury. It is a potent corticosteroid which can do the following: reduction of membrane lipid peroxidation and post-traumatic inflammation. It can upregulate the transcription of anti-inflammatory enzymes and actually interfere with inflammatory cytokines to lessen inflammation. In preclinical models of SEI, methylprednisolone is actually protective against oxidative stress and is associated with large numbers of surviving oligodendrocytes and motor neurons. Why isn't dexamethasone used? No? Hindi naman siya bawal, but dexamethasone actually has a slower absorption rate and peak plasma concentration is reached at about 8 hours. It is not recommended when immediate effect of the drug is desirable. So there has been 3 large-scale trials for methylprednisolone. Okay, the first trial is actually NASAS-1, wherein basically there's no effect. They compared a high dose versus a low dose. There's no effect, but then they argued that maybe an even higher dose was necessary. So a higher dose, basically 2 grams as loading dose, and then 9-gram infusion for 23 hours, led to improvements in only about 62 out of 487 patients, but this was deemed clinically significant. And they found out all 62 patients received methylprednisolone within 8 hours of injury. However, the most important criticism is that these improvements were not actually tested if they had meaningful clinical significance. However, because there has been 2 trials already for methylprednisolone, and there's no conclusive evidence that the medication doesn't work, the standard practice at the time was to give methylprednisolone to all SEI patients and perform surgery if indicated. Because they found that in the subset of patients who received methylprednisolone had significant improvement within 8 hours of who received methylprednisolone within 8 hours of SEI had a significant improvement. A third part of the trial was undertaken, and this included a 24-hour methylprednisolone infusion, which patients received about 11 grams of methylprednisolone, and a 48-hour methylprednisolone infusion, wherein 20 grams were in total were given. So the important thing is that the treatment would be started within 8 hours of injury. But then in this study, they found out that there is some improvement in patients who were in the 48-hour group, along with patients in the 24-hour group. However, there has been a 2-fold increase in severe pneumonia fourfold increase in severe sepsis, and a sixfold higher incidence of death due to respiratory complications in patients uh, in the 24-hour group and 48-hour group, right? Although all of these were not statistically significant. Because of the basically negative results of the trial, the AANS and the CNS now recommend that methylprednisolone for either 24-hour or 48-hour is recommended as an option only. So it's not standard of care in the treatment of patients with acute spinal cord injury that should be undertaken only with the knowledge that the evidence suggesting harmful side effects is more consistent than any suggestion of clinical benefit. The World Federation of Neurosurgical Societies, the WFNS, recommendation is that there is no good evidence that high doses of methylprednisolone administration is beneficial. In selected young patients with acute cervical SCI, the 24-hour infusion can be administered within 8 hours as an option. Okay, so that's it for methylprednisolone. So very narrow, naging very narrow na lang yung use niya. No? So only for young patients wherein it might be worthwhile to take the risk, especially if they have a cervical cord injury, and some improvement will make a huge impact on the patient's outcome. Now we looked at other novel treatments that are still in the pipeline. You know, the next drug up is riluzole. Riluzole is an oral anti-epileptic used for amyotrophic lateral sclerosis, no, ALS, to delay ventilator dependence and increase survival. Basically, what riluzole does is that it prevents excitotoxicity by preventing glutamate buildup. Now, a phase 1 study showed 50% improvement versus 20%, 24% in placebo in about 90 days. And this has led to this positive result has led to a larger phase 3 trial, but was interrupted by the pandemic. However, interim analysis of the available data was positive and trended toward a positive result, and the study has since continued. Next is the minocycline. Minocycline is actually in the same class of antibiotics such as the tetracycline and the tigecycline. Okay, minocycline results in reduced oligodendrocyte and neuron apoptosis. So there's less cell death if you give minocycline. There's decreased size of the glial scar and reduced inflammation. The results of the phase 2 trial are, although not statistically significant, trended toward improved motor scores. And a phase 3 trial is undergoing, and the concluded results will probably be out soon. So that's minocycline. And then there's the Cefrin. Cefrin is basically something that is intraoperatively applied to the dura. So it's like a fibrin sealant that has some positive effects. But then again, the advanced stages of trials, such as the phase 3 trials, are still ongoing. Okay, so this table summarizes the results for the methylprednisolone, which essentially are all negative, and the ones that are in the pipeline, you know, have some positive effects, but are largely still ongoing phase 3 trials. Now, a lot of the other interventions have been found out to not work, such as the CSF drainage, the ganglioside, magnesium, thyrotropin releasing hormone, naloxone, nimodipine also has been found out to not work. So it's not easy really to come up with something that works, right? So that's why, aside from pharmacologic therapy, regenerative medicine has stepped in, right? Regenerative medicine is there to minimize the spread of secondary injury and to augment the function of remaining cell populations. This will facilitate regeneration of the neuronal and glial populations as well. This is the promise, right? However, there are significant challenges to stem cell therapy, right? The stem cells that are transplanted need to be able to proliferate and differentiate in an inhibitory environment, which is the glial scar. They need to be able to reconstitute local blood supply systems. You know, they need to have their, they need to like rebuild the local blood supply system, reconnect the severed axons, remyelinate the reconnected axons, and then reestablish physical synapses, which translate to clinical improvement. And then they need to also be able to secrete trophic factors to ensure their continued survival. in that inhibitory environment. Right, the best thing is to actually break down the inhibitory environment. That's why a lot of the stem cell therapy trials, very few have actually been published. If you look at the published results, most of these are not applicable, right? And almost all of them are phase 1, phase 2 trials with very small uh, numbers enrolled, right? However, the ones that are ongoing, this one, the one with the 130 enrolled patients and the 500 enrolled patients are still ongoing, and this might give us a clearer picture of the efficacy of stem cells. So still early stages, there's still no concrete recommendation that this is the actual thing that works. A combinational strategy for cell-based therapies is being undertaken in STI. Cellular transplantation may now be augmented with a combination of growth factors to ensure survival and to ensure proliferation and development, scaffolds to hopefully facilitate the reconnection, and other biomaterials that improve survival, engraftment, and differentiation. Intraspinal application of these therapies hopefully may promote the sort of holy grail of neuronal regeneration and eventual clinical improvement. Thank you for listening.
Thank you for sharing with us the latest updates on neuroprotection of the spinal cord, Dr. Singh. So as we can all see, the neuroprotection of all the components of the central nervous system is not a task that the anesthesiologist has to bear alone. Of course, our neurosurgery colleagues are always conscious of the need for optimizing the spinal cord's physiology and environment, just like us, emphasizing the need for constant communication between the members of the neurosurgical team. So it's always great seeing the perspective from the other side of the drapes. So we truly have to thank Dr. Seng for his lecture on spinal cord neuroprotection. At this point, we'd like to remind everyone to keep your questions coming by typing them in the Q&A window, and we'll try our best to sort through them and bring them up later towards the latter part of the session during the open forum. So right now, we'll move on to our next speaker. He is a full professor of the University of Santo Tomas Faculty of Medicine and Surgery. He is the past chair and head of the Neuroscience Institute of the Department of Neurology and Psychiatry at the UST Hospital. He has a PhD in neurosciences from the Kagoshima University Graduate School of Medicine in Japan. He also had clinician programs in muscle pathology at the Neuromuscular Division of the Japan National Center for Nervous and Psychiatric Disorders in Tokyo, in clinical electromyography at the Mayo Clinic in Minnesota, and in movement disorders at the Columbia University in New York. He also has visiting professorships in several institutions, such as the McKnight Brain Institute at the University of Florida, the Center for Neurological Restoration at the Cleveland Clinic, the Movement Disorder Center at Seoul National University, the King's College of London Neuroscience Department in the UK, the Palaki University Department of Neurology in the Czech Republic, and he is currently a staff member of the Movement Disorders and the Clinical Neurophysiology Units of St. Luke's Medical Center International Institute of Neurosciences. He is a fellow of both the Philippine Neurological Association and the Philippine Psychiatric Association, and he is also a member of the external advisory boards of the Neurogenetics Collaborating Centers in the University of Lübeck, Germany, and the Department of Neurology at Massachusetts General Hospital, Harvard Medical School. Colleagues, let's give a warm welcome to Professor Raymond L. Rosales.
I do thank the organizers for the kind invitation. My topic is about the management of SCI, chronic pain. These are my disclosures. Chronic pain may happen eventually from an acute pain process, like for example, herpetic neuralgia from an acute phase, a nociceptive component together with neuropathic pain components to become chronic pain. Obviously, these are known mechanisms related to inflammation and scarring and remodeling. So this is one way to look at acute pain versus chronic pain. But when you look at chronic pain, and we look at chronic central neuropathic pain, and I'm not going to delve on the chronic peripheral neuropathic pain, you can see that spinal cord injury is included in that group of patients that includes post-stroke pain and MS and traumatic brain injury. If you look at chronic pain in a Japanese cohort, and the authors here alluded to the fact that they believe this is the first nationwide survey using a questionnaire and mailed questionnaire, and they used pain detect to end up with a figure of prevalence for neuropathic pain of about 3.2, majority of whom are really in the ranges of 20 to the late old age, where you have the neuropathic pain. And interestingly, in this cohort of patients, Japanese patients, they also found that, in fact, chronic pain with neuropathic components do impact on the quality of life. For example, here in the utility score of the European Quality of Life Scale, in the Kessler scale for psychological distress, and for sleep interference, and including work days lost. You can see that those with chronic pain, neuropathic pain, will be more affected. Many of you are familiar with this triangle where you have, not triangle actually, but these circles where you have the nociceptive pain and the neuropathic pain coming together, and on top of it, the nociplastic pain, that which we now know as those where you refer to fibromyalgia and the visceral kind of pains called irritable bowel syndrome and interstitial cystitis. But anyway, spinal cord injury is a good example where it has a nociceptive component and a neuropathic component, and I'm going to dwell on that in a short while. Point, in fact, is in chronic low back pain, in CRPS, and in knee osteoarthritis, the brain's default mode network connectivity from the medial prefrontal cortex to the posterior components is actually reduced in chronic neuropathic pain, and this is due to the fact that this is related to maladaptive plasticity. And this default mode network is now tilted with increased connectivity to the pain areas in the brain where they are facilitated, for example, via increased connectivity to the insular cortex proportionate to the intensity of pain. Obviously, we have to screen our patients with neuropathic pain. It is a given, and there are many scales for screening of neuropathic pain, but I allude to Pain Detect, which is now translated to the Tagalog and the Cebuano version. This has been validated using transcultural adaptation process now in Tagalog and Cebuano, and it's published, so you can easily get it. Now here comes a patient, a 78-year-old female with a history of fall, develops spastic paraparesis, hyperreflexia, Babinski bilateral, and hypoalgesia to pinprick at the level of T10. So this was the clinical sensory level. And after 3 months, she developed moderate pain, spontaneous pains described as dysesthesias or needle prick at bilateral T10, T11, and then just below it, T12 and below, paresthesias, a feeling of vibration, including touch allodynia in the same areas. Well, of course, the patient also has bladder and bowel incontinence. So if you look at the rat approach to pain, when we look at what type of pain is it, so obviously in this case it is chronic, it's 3 months and henceforth, it is non-cancer, and it is neuropathic. But also when you look at pain, you have to look at the other biopsycho social aspects related to it as referred to here. in this kind of a patient, for example, this patient had hypoalgesia, therefore giving us a sensory level of T10, but the patient also developed dysesthesia at that sensory level 3 months henceforth, and then paresthesias by way of some feeling of vibration at T12 and below, and so therefore plus allodynia in that part. So these are all very clear descriptors of what is referred to as neuropathic pain. And of course, in a neurologic approach to disorders like this, we end up with spinal cord injury, and it is 1 or 2 levels higher than the clinical sensory level, so it should be T8 and T9, and post-spinal cord injury central neuropathic pain, SCI. And if you look at the SCI, the spinal cord injury pain, using the IASP classification, it does have, as I showed you earlier, a nociceptive component, which are usually triggered by musculoskeletal elements. And then you have the neuropathic pain component, which is either above the injury level, and in which case it could be compressive mononeuropathies or CRPS at the injury level. And so it could be a nerve root compression, including cauda equina, syrinx, spinal cord trauma, and ischemia, or below the level of the lesions of spinal cord trauma and ischemia. Interestingly, this kind of a classification can also be looked in another way by looking at the nociceptive, the neuropathic, and other kinds of pain at the level of spinal cord injury pain, below the level of the spinal cord injury pain and other neuropathic pain. And so at the level within the dermatome and 3 dermatomes below can happen. Below the level, more than 3 dermatomes below may extend to the at level region. And I discussed this already with our patient, here clearly shown the neuropathic pain components. And the reason why that this kind of an understanding should be sought is because sensory hypersensitivity, which could be tested at bedside using, for example, tests for allodynia, early evoked pain or dysesthesia below level or below level neuropathic pain, or at level, if you look at such a comparison, you will find out that early sensory hypersensitivity exemplified by dysesthesias predicted the onset of below level but not at level neuropathic pain. And this is very important in terms of stratifying patient risks for developing neuropathic pain. Individualizing treatment is very important in the management of neuropathic pain. So we have to look at the various aspects, not only in terms of the mechanism or the etiology, but we also have to be aware of environmental and genotype factors. And then thereupon we end up with individualized therapy. If you look at the nociceptive pain management of spinal cord injury, which I told you are mainly musculoskeletal based, you can see that it's mainly hinged upon exercise and acupuncture. But if you look at the neuropathic pain component, in general, we look at how it's either being through the mechanism of peripheral sensitization. These are by far the medications that can be used. And so I allude to anticonvulsants, TCAs, SNRIs, central sensitization, again, anticonvulsants. That includes now alpha-2 delta ligands, SNRIs. And then you have the opioids, and then the brain descending modulation using the opioids, again, antidepressants and anticonvulsants. It's a general way of looking at it. And if you look at spinal cord injury, central pain, central neuropathic pain, if you look at the pharmacological treatments, you can see that the data is very clear in terms of pregabalin over the other medications. And so These are actually called gabapentinoids. Gabapentin was the first one that was discovered, and then came the pregabalin for alpha 2 delta. Occupancy here, where both will work at the voltage gated presynaptic calcium channels, which are very active in neuropathic pain. The occupancy is 3 to 6 times higher for pregabalin, hence the more potent medication. And this kind of understanding is very important, because if you modulate the alpha 2 delta component of the voltage gated calcium channel, then you modulate the release or the trafficking of the vesicle, which means to say that you perhaps block the release of pain modulating vesicles containing pain modulating transmitters, for example, like substance P, for example, glutamate. And if you look at the dorsal horn, in the dorsal horn, you can see the upregulation of the ligands here for alpha 2 delta ligands of the spinal cord, dorsal horn. But if you give pregabalin, the upregulation is drastically, significantly reduced. Now, there are a number of differences between gabapentin and pregabalin as gabapentinoids. As I repeat, pregabalin is the known well systematically done study. Phil Siddall of Australia did a nice study of spinal cord injury using pregabalin. Point, in fact, is pregabalin has a more linear pharmacokinetic profile versus a nonlinear pharmacokinetic profile for gabapentin. And the effects of pregabalin given in patients with neuropathic pain previously treated with gabapentin, in the end, it's clear that there is no significant difference in the occurrence of adverse events, even if you add pregabalin in those previously on gabapentin or not. And there is no significant difference in the patient's global impression of change scores. No significant difference in the extent of pain relief, just as well. So the adverse effects of alpha 2 delta ligands, of course, they are not almighty drugs. They do induce the dry mouth, dizziness, somnolence, weight gain, and peripheral edema. Now, the antidepressants are also being used for neuropathic pain, i.e. here, central neuropathic pain that we referred to here, exemplified by the spinal cord injury patients. And you can see that TCAs, tricyclic antidepressants, as SNRIs, are good examples, and we have to respect the fact that they are also very, very effective medications for neuropathic pain, working at the descending modulation as a mechanism for neuropathic pain. Of course, they are not also almighty medications. They have some adverse events and adverse effects, just like your alpha 2 delta ligands. And for TCAs, many of these patients do have some TCAs also have anticholinergic properties. And so there are effects not only peripherally, but also centrally, and including orthostatic hypotension, palpitations. And for SNRIs, it's the other way around, where they can potentially develop hypertension. So in the pharmacological management of neuropathic pain, the first-line treatments, again, are the gabapentinoids, TCAs, and SNRIs. And if there is only partial pain relief, so you can add another first-line medication for a combination treatment. And if both that doesn't work, then you have the second-line medications, the opioids and the partial opioids, and the third-line medications. Now, the Canadian Pain Society recommendations would be interesting. It's pretty much the same, but look at their third-line agent. It's cannabinoids. And I'm not going to discuss so much on that, but just to tell you that it is their third line treatment of choice. And here the fourth line includes botulinum toxin here my resident is doing botulinum toxin treatment in a patient with spinal cord injury. So this is sort of trying to phenotype the patient. So if you have a patient with neuropathic pain and has depression, your choice would be TCAs and SNRIs. For generalized anxiety disorder, SNRI plus pregabalin, and for sleep disturbances, SNRI, pregabalin, TCAs, and opioids. And for drug interactions, obviously, if the patient has on board several medications, because pregabalin doesn't have its hepatic first pass effect, then it can be combined with many medications and less of drug interactions. What about anticonvulsant use? This time in spinal cord injury? Well, from 63 to 91% of patients suffer from neuropathic pain from spinal cord injury that adversely affect their quality of life. And the pain can be neuropathic or nociceptive, as I told you earlier. The neuropathic pain that occurs below the level of injury is most difficult to manage. And I see there are predictors there that we earlier alluded to. And the gabapentinoids are the ones being used. So, of course, there are other medications that can be used still, like your antidepressants, TCAs, and we mentioned already the gabapentinoids. Now, gabapentin and pregabalin for neuropathic pain and spinal cord injury. We use about 3,600 max for gabapentin and about 600 milligrams max for pregabalin, and they do show significant reductions in terms of pain. Gabapentin and pregabalin also improve other secondary conditions related, like sleep interference, anxiety. Now, interestingly, as I told you earlier, pregabalin works within 48 hours, so it is quite quick to reduce spinal cord injury pain. Now, there are non-pharmacologic therapies for neuropathic pain. That includes physical therapies, as alluded to here. Rehabilitation techniques are very important, but you may also consider CBTs, for example. The other non-pharmacologic therapies are massage, ultrasound. All those things can be used for spinal cord injuries just as well. Rehabilitation techniques like graded motor imagery, visual illusion, all those things can still be used and applied. Neuromodulation is not my topic, but I'm just showing here that in spinal cord injury, spinal cord stimulation could be one neuromodulation therapy. Invasive therapies, i.e. surgeries, and the other ganglion blocks will not be my topic, but these are included in the platter for the treatment of spinal cord injury. So I more concentrate on the fact that there are strategies to improve adherence to pain medications. By simply simplifying the regimen, we impart knowledge, we modify patient beliefs, we provide communication and trust, we leave the bias and evaluate adherence. When we evaluate adherence, we never ask about yes or no, have you taken your medications regularly? That's not the way. You have to ask open-ended questions about taking the medicine. And then you universalize the fact that not everyone adheres to medications, and there are, of course, you cannot be just judgmental to the patient. So you sort of normalize that and perhaps extract from the patient the fact that what are the reasons why they can't be adherent, and perhaps inculcate on them the need to know that medical decision making is explicit if they adhere to the medications, because then we are guided about outcomes. And don't ask about forgetting or missed doses. Don't ask those direct questions. Simplifying medication regimen, the pill count, doses, uh, special requirements like bedtime dosing. You have to simplify this. Maybe link them to daily activities like eating, and same time of the day is best, is a best way. We impart knowledge, we provide clear instructions, we be sure about the information that the patient can understand. At least you may potentially involve family members, and maybe some handouts to read, and concrete advice on how to cope with, of course, the reality medication costs. Now, modifying patient beliefs and behaviors is another thing, motivating interviewing techniques. So we express empathy. It's not normal to worry about medication side effects. It's normal to worry about medication side effects. That can, it's always a universal thing. So it's one way to express empathy, develop discrepancy. You obviously care about your health. How do you think not taking your pills is affecting you? So I understand that you have a lot of other things besides taking pills to worry about. And so support self-efficacy. It sounds like you have made impressive efforts to work your new medication into your daily routine. So the most important thing is to cultivate a patient-centric care environment and relationship in order to individualize lines of communication. Regarding communication, to build trust, there are some tips. So you always be an active listener. Do not open your cell phone when in front of the patient. That is a no-no. And you have to nod and smile, make eye contact, be aware of your body language, face the patient, keep arms uncrossed, remove your hands from pockets, and recognize and interpret nonverbal cues. You leave the bias, learn more about how low health literacy can affect patient outcomes, specifically ask about attitudes, beliefs, and cultural norms in regard to medication, tailor communication to patients' beliefs and level of understanding. So in summary, realistic treatment goals should be set in conjunction with the patient. So the patient is always engaged when we talk about management. In this case, spinal cord injury, as in our case, the patient has been engaged, the family has been engaged, and then the treatments of choice are usually the alpha-2 delta ligands and the TCAs, and then non-pharmacologic therapies can be used, including neuromodulation and the other surgeries that potentially can be used, which is going to be dealt with by the other speakers. So with that in mind, thank you very much for your kind attention.
Thank you very much, Professor Rosales. There are truly a lot of drugs available to us clinicians, as mentioned by Dr. Rosales, in addressing chronic pain from spinal cord injuries. And as we can see, chronic pain from the spinal cord or spinal cord injuries is truly a multidisciplinary concern involving the whole team, not just anesthesiologists, but neurologists and our neurosurgeon counterparts as well. We appreciate the talk, Dr. Rosales, as it will definitely go a long way in providing adequate pain relief in our patients who may present with spinal cord injuries and in optimizing their oftentimes debilitating conditions. So thank you very much, Professor. It's nice to see a good number of participants in our sign-up session so far. There are over 480 colleagues joining us right now in this healthy discussion on spinal cord injuries. And again, we'd like to welcome our delegates. Once again, if you have questions, feel free to place them in the Q&A box and we'll tackle them later during the open forum with our speakers. So now we move on to the final speaker of the sign-up session on the spinal cord. She is an anesthesiologist, specifically a neuroanesthesiologist, and she took up her training in both residency and fellowship in the University of the Philippines, Philippine General Hospital. She is presently the training officer of the Department of Anesthesiology at Baguio General Hospital and Medical Center, and she is also the crisis management officer at the same institution. She served as a member of the Technical Review Board Research from 2015 to 2019, also at Baguio Gen, and she is a member of the board of directors of the PSA's Baguio Benguet Mountain Province chapter. and she is newly minted as a member of the Board of Accreditors of the Philippine Board of Anesthesiology. Everyone, please join me in giving a warm welcome to our very own beloved colleague, Dr. April Lily R. Gomez.
Good day, colleagues. Thank you for logging on to listen. The lecture for the next few minutes will focus on the anesthetic considerations for patients with spinal cord injury. So let's start. These are the objectives for the lecture: to define acute and chronic spinal cord injury in their clinical presentation, to discuss their systemic effects, as well as the anesthetic management of SCI, focusing on prevention of secondary injury to the spinal cord, and to present the best practices for airway management in high spinal cord injuries. Spinal cord injury is a plague of the industrial age. According to the World Health Organization, every year around the world, between 250 to 500,000 people suffer a spinal cord injury. Majority are due to preventable causes such as road traffic crashes, falls, and violence. Available data for the incidence of traumatic SCI in Asia range from 12 to as many as 61 million cases over a 3-decade period. In comparison to traumatic SCI in Europe ranged from 10 to 29 million, and in North America, 27 to 83 million people. I tried getting a handle on those numbers. Then note the data for non-traumatic SCI, which is also staggering as they show a greater number of admissions over traumatic SCI in some countries and with higher mortality rates. Spinal cord injury patients are usually encountered by the anesthesiologist at the emergency room for airway management and at the operating room for spine surgeries or other type of surgeries. A focused history and physical examination should be performed, as well as thorough airway evaluation, of course, depending on the urgency of the procedure and the patient's level of cooperation. Two very different states that we define now as they may present similarly are neurogenic shock and spinal shock. Neurogenic, which is a distributive form of shock, manifests as hypotension, bradycardia, hypothermia, resulting from partial or full sympathetic denervation. Spinal shock is a temporary loss of spinal cord function causal to the injury, causing flaccid paralysis, anesthesia, absent bowel or bladder control, absent reflexes. The neurogenic shock is treated aggressively. Now, what are the systemic effects of spinal cord injury? The normal cardiovascular homeostasis is impaired in patients with SCI, especially with lesions above T6. Their baseline blood pressure and heart rates are usually lower. Bradyarrhythmias, AV conduction blocks, and hypotension occur following cervical lesions due to the impaired sympathetic innervation in the setting of a preserved vagus-mediated parasympathetic function. Chronic patients often have anemia, relative hypovolemia as well, and the autonomic dysfunction predisposes the patient to orthostatic hypotension. This leads to intolerance to sudden changes in position, so that even small changes into semi-Fowler's or head-up position can have profound doses, as well as prepare for blood pressure controlling drugs prior to a contemplated procedure. Now, there's impaired thermoregulation, which is present in some patients. It increases the risk for hypo or hyperthermia, which requires the use of cooling or warming devices. Patients with lesions above T6 may manifest with autonomic dysreflexia. This is an exaggerated sympathetic response to any stimuli below T6, starting with diffuse vasoconstriction below the lesion, which leads to hypertension, headache, diaphoresis, and changes in heart rate. The condition requires absolute absence of sensation at the operative site by using either a regional anesthesia technique or deep general anesthesia. Control of hypertension necessitates the use of short-acting vasodilators. Patients with chronic cervical or thoracic SCI often have reduced lung volumes across the board, as well as increased BMI due to their immobility. Some patients require assisted ventilation, so that coordination with the team managing these devices should be included when planning airway management, emergence from anesthesia, and postoperative care. Impaired coughing and difficulty in mobilizing lung secretions often lead to pulmonary infection or pneumonia. Factors that lead to pneumonia include expiratory muscle weakness resulting in ineffective cough, possible altered levels of consciousness from a concomitant head trauma or sedating medications, failure of spontaneous sighing, bronchial mucus hypersecretion, probably from impairment of the peripheral sympathetic nervous system. There's also dysphagia and aspiration. The pulmonary effects of acute spinal cord injury may manifest as breathing impairment, being the most commonly seen in complete cervical cord lesions as well as in thoracic cord lesions. The acute transverse myelitis from edema or local inflammatory response surrounding spinal nerves may lead to spinal shock, where paralysis of the respiratory muscles can lead to ventilation problems. Injury to the craniocervical area may cause bulbar dysfunction, which weakens pharyngeal and palatal muscles, leading to an aspiration and inability to protect the airway. Risk for venous thromboembolism is quite high in this group of patients, even in the acute phase. The critical period is between 72 hours and 2 weeks following the injury and remains high for the first 3 months. Low molecular weight heparin may be started as prophylaxis for these cases. Urologic symptoms frequently manifest as urinary retention and bladder distension and may require catheterization. The gastrointestinal effects of spinal cord injury include stomach dilatation and delayed gastric emptying time, which puts the patient at risk for aspiration. Glucose intolerance may also arise due to the overworked stress response of the body. Chronic SCI patients often have contractures, which may affect positioning on the operating room table. Prolonged disuse also leads to muscular spasticity, requiring additional premedications for comfortable transport of the patient. Pressure ulcers are also problematic and occurs even after a short period of immobility, so that a thorough physical examination of skin, especially over bony prominences, be performed. So we avoid contact with wet linens or any skin friction. Chronic pain medication should be accounted for when planning post-operative management. 70% of SCI patients suffer from chronic neuropathic and musculoskeletal pain, for which they take anticonvulsants like gabapentin and strong opioids. With so many things to consider, what will our anesthesia plan be? Under the mantra of good clinical judgment, our choice of anesthetic should factor in the level of spinal cord injury, the patient's remaining sensory motor function, his concomitant comorbidities, and of course, the surgical procedure. For patients with chronic SCI undergoing surgery, general anesthesia may be preferable for patients who cannot tolerate lying flat, for those who have upper extremity muscle spasms, contractures that make positioning difficult, or those with high anxiety. For patients at risk with a history of autonomic dysreflexia, or for those with lower extremity muscle spasms, either a general or regional anesthesia technique may be used. For patients without any sensation at the surgical site and who are not at risk for autonomic dysreflexia, monitored anesthesia care with or without sedation is an option. For patients with incomplete sensory loss without risk for AD or spasms, Local anesthesia or peripheral nerve block may be adequate for surgery. For patients undergoing emergency procedures with low thoracic or lumbar SCI, we may perform rapid sequence induction and intubation with direct laryngoscopy. Now, airway is a big consideration for anesthesiologists regarding its management in patients with SCI. If a tracheostomy is already in place, a cuffed tracheostomy device should be used or be replaced with a flexible cuffed endotracheal tube. Now, studies have shown that most, if not all, maneuvers or techniques cause some movement of the cervical spine. Movement is greatest at the atlantoaxial and atlanto-occipital joints. Our usual direct laryngoscopy technique may move the cervical spine by more than 30 degrees along the axis. So what is our best approach? Manual inline stabilization technique is still the gold standard in accessing the airway in a suspected cervical spine injured patient. This is really from inferred data rather than clinical trial evidence. Performing this technique worsens conditions for tracheal intubation as you would expect. It increases Cormack-Laney grades by as much as 50% compared to direct laryngoscopy in sniffing position. So while manual inline stabilization anchors the occiput and the torso anchors the lower cervical spine, it is likely that laryngoscopic forces can still be translated to the mid-cervical spine. With males, cricoid pressure is applied more vigorously to improve visualization of the glottis. Studies show that caution should be used with cricoid pressure for patients with lower cervical spine injury, as it has been shown to increase the distraction, angulation, and translation in unstable C5 to C6 models. But there is good news. With the use of video laryngoscopes or early use of bougies with direct laryngoscopy, chances of successful intubation with males are greatly improved by as much as 30%. In a study by Supan, comparing alternative intubation techniques versus MAC laryngoscopy, a handheld fiber optic intubation device reduced the risk of intubation failure at first attempt and oropharyngeal complications. Success is also improved by use of a rigid video stylet, according to a study by NAM. So what are other anesthetic considerations other than airway? Propofol, ketamine, etomidate may all be used but titrated to effect because of the patient's sensitivity to the cardiodepressant effects of our anesthetics. Succinylcholine is avoided after 48 hours as it may cause severe hyperkalemia. NMBs reversed with Siglamodex may be used as an alternative if neuromonitoring is needed intraoperatively. Standard monitoring is appropriate for most cases, and we aim for a MAP of 85 to 90, avoiding systolic blood pressure below 90 millimeters mercury, or around 20% of the patient's baseline. Crystalloids and colloids may be used during initial volume resuscitation of acute SCI or volume loading during induction. Bradycardia should be anticipated and managed with glycopyrrolate or ephedrine if there is hypotension. The use of tranexamic acid as prophylaxis for spinal surgeries have been studied and has shown to have a better outcome against bleeding or transfusion need during OR. Vasopressors for hypotension should be prepared. Comparison between dopamine and norepinephrine showed norepinephrine was able to maintain a higher spinal cord perfusion pressure over that of dopamine. So what are our considerations for after surgery? Post-operative planning, again, goes back to good clinical judgment. Patients with chronic SCI may require extended recovery room stay to allow for a BP, breathing in airway, temperature stabilization, as well as control of post-operative pain. In many cases, a multimodal approach to pain management is appropriate. This may include drugs such as gabapentin, duloxetine, medical marijuana, morphine, and other more invasive treatments. If ongoing vasodilator infusion is required, the patient should be transferred to the intensive care unit. Now, we need to watch out for autonomic dysreflexia as it may still occur in the postoperative period, most often related to bladder distension. So there's a lot to consider when providing anesthesia for spinal cord injured patients, but just to highlight, vigilance must be exercised for signs and symptoms of autonomic dysreflexia for SCI lesions above T6. Regarding the use of methylprednisolone steroids, there is limited evidence that glucocorticoid therapy improves neurologic outcomes in patients with acute traumatic spinal cord injury. Rapid sequence intubation with inline spinal immobilization is a preferred method when an airway is urgently required. Mills decreases cervical spine movements more effectively than hard collars. And although I emphasized Mills for airway management, just a caution, in securing the patient's airway with cervical spine injury, allow time for manual inline stabilization techniques, but abandon that if it interferes with your success at intubation. Prolonged intubation ultimately is more harmful for the patient. Spinal cord injury patients have notoriously shortened life expectancy, and their functional neurologic deficits should be ameliorated by appropriate rehabilitation interventions to include psychosocial support. That is the end of my lecture. Thank you very much for listening. If you have any questions, please go ahead and email me at this email address. That's all. Thank you.
Thank you, Dr. Gomez. This last lecture is obviously a topic that is very familiar to us, and it hits close to home because all of us practice anesthesia on a daily basis. So hopefully we can apply these learnings and anesthetic considerations to all of our patients, especially for those who present with spinal cord injuries. Again, thank you, Dr. Gomez, for the updates. Now, before we move to the open forum, allow us to show a short teaser video from the Society for Neuroanesthesia of the Philippines, or SYNAPS, regarding the upcoming 7th Congress of the Asian Society for Neuroanesthesia and Critical Care, or ASNAC, of which we are the proud hosts, coming in February 2023. Okay, thank you for that. At this point, I'd like to call back onto the virtual stage our three speakers for the sign-up session. so that we can have a live open forum with our audience members. So first of all, I'd like to thank Dr. Seng, Dr. Rosales, and Dr. Gomez for their talks this morning. If there are any questions, we'll entertain them right now. Okay, so first question, I have a question for Dr. Seng. We all know that vasodilation below the spinal cord lesion leads to hypothermia into the affected area. Is there a role for warming, or in some cases, just like in emergency neurologic life support or ENLS, targeted temperature management in managing these patients? Dr. Sen, I think you're on mute. Sorry.
Okay, sorry. So thank you for your question, but as I was saying, the core temperature is what's important here. Because of vasodilation, blood tends to pool in the extremities, so patients warm to touch, and then when you check the BP, it's quite low. So we need to maintain basically normal core body temperature in the 37 temperature range. So that's what's most important.
Thank you for that, Dr. Seng. Again, it's always a concern for us anesthesiologists, as any patient under anesthesia tends to adapt to the temperature within the room itself. For Dr. Rosales, I have a question here for you. You mentioned all of these drugs in the management of chronic pain with regards to spinal cord injuries. Ketamine, as most anesthesiologists tend to prefer using it these days because there's a lot of novel studies regarding this drug. As an NMDA receptor antagonist, is there a role for it for the neurologists and for, of course, our anesthesiologist counterparts?
Thank you for the question. Of course, I think in one of my slides, I did show that, but I did not delve on it in detail. But yeah, it is an anti-glutaminergic drug, and being anti-glutaminergic, it is supposed to be a very effective drug. I'm aware of the fact that our anesthesiology friends use that medicine more than us, but I do have no objections if some anesthesiologist friends of mine tell me that they wanted to try ketamine on the patient. The good thing about it is it's quite quick, and because it is anti-glutaminergic, one of the pain neurotransmission networks related to neuropathic pain will be the glutaminergic pathways. Thank you.
Thank you, Dr. Rosales. Of course, for some of our colleagues, ketamine is somewhat of a novel drug, so some are not comfortable to use it. But it's nice to know that it's gaining more popularity in terms of use, not just in anesthesia, but also for our neurology colleagues as well. Thank you, Professor. For Dr. Gomez, hi, good morning, Dr. April. I have a question with regards to the eternal debate on TIVA and inhalational. We know it's always being discussed in any neuroanesthesia conference. So as we all know, TIVA is gaining popularity, particularly with regards to propofol, having anti-apoptotic and anti-inflammatory effects. With regards to spinal cord injuries or management of patients undergoing spinal surgeries, are there any recommendations in the TIVA versus inhalational debate?
With regards to the spinal cord, it behaves very much like brain tissue. So the white and gray matter in the spinal cord are susceptible to the same pharmacologic and physiologic effects that the brain undergoes. And TIVA has already been shown to have greater benefits for brain surgeries. So it applies as well to spinal cord injury and spinal surgeries.
Thank you, Dr. Gomez. A question here raised, it's not in the chat box, but one of our colleagues has a question for Dr. Singh. I know you mentioned it briefly in your lecture with regards to the spinal cord perfusion pressure with a target map of 85 to 90. Is there a recommended spinal cord perfusion pressure in terms of maintaining homeostasis or maintaining normal, or what do you call this, an optimal conditions for the spine?
Like we said in the lecture, it's actually quite difficult to measure the spinal cord perfusion pressure, especially in the area where you have the injury. It's not as easily something that is not as easily measured as, for example, intracranial pressure for traumatic brain injury, where you have basically real-time feedback on how high the pressures are inside the skull. It's a little hard to do that in the spine because of the confined space, because of also the eloquent tissue in that area. So that's why they alluded to using MAP as a guideline in order to, because they found out in preclinical studies, meaning these are animal models, that during these pressures, the spinal cord is adequately perfused despite there being significant injury in that area.
Just a follow-up question to that, Dr. Sen. You mentioned also the choice of vasopressors. You mentioned dopamine and norepinephrine earlier in your lecture. A follow-up question is, will the level of the spinal cord injury matter in the choice of our vasopressors?
I think now what's being actually more commonly used, this was also mentioned in Dr. Gomez's lecture, is norepinephrine, rather than dopamine. So with regards to, because of its alpha and beta adrenergic effects, with regards to the level of injury, I don't think that really plays a factor into what type of drug you will choose.
Okay, that's nice to know, Dr. Sen, because as we all know, not all institutions have access to all these drugs. There's a question in the Q&A box, if you'll allow me to read it. In spinal cord injury patients with abdominal procedures, is there a role of regional anesthesia or peripheral or neuraxial blocks post-operatively? So I think any of our panelists may answer this.
If I may.
Yes, Dr. Gomez.
Yes. Okay, so depending on the level of spinal cord injury, we watch out for onset or signs of autonomic dysreflexia. If the surgical procedure is insensate, a peripheral nerve block or regional anesthesia techniques can be performed. Even monitored anesthesia care can be done for absolutely no sensation at the site of surgery. So yes, regional anesthesia and peripheral nerve blocks, as well as monitored anesthesia care, can be used for spinal cord injury patients.
Thank you, Dr. Gomez. Any of our panelists, your opinion po with regards to performing neuraxial or regional blocks for patients with undergoing abdominal procedures?
I have no objections to regional blocks for that in spinal cord injury patients.
Thank you, Dr. Seng, Dr. Gomez. If there are more questions, you can raise them. I just have one last question for Dr. Rosales. Most of your discussion, Professor, was revolving around, I'm assuming, adult patients. Are there differences in the management of chronic pain patients from spinal cord injury with regards to pediatric versus in the pediatric population?
Yep, it's a good question. I did not delve on that, and I should have actually. So I sort of went through the adult population, so my apologies for that. But I don't have the data on spinal cord injuries, but I'd be happy to learn from our neurosurgery or anesthesia colleagues about the pediatric population.
Thank you, Dr. Rosales. As we all know, medicine keeps on branching on into these subspecialties. So yeah, we're always curious about how we manage all these different populations in our field.
But can I say something about, sorry, can
Yes.
I interpolate? Of course, if you look at the available medications for chronic neuropathic pain in the pediatric population, the tricyclic antidepressants and the SNRIs are challenging medications to use in this population, but the gabapentinoids are known and very effectively used, especially in the pediatric population where we use it even in epilepsies. So it should be a safe medication to use. So, but I'm not aware about ketamine in this population. Thank you.
Thank you, Dr. Rosales. Right now, I don't see any more questions in the Q&A chat box. But please, if for those who have additional questions or are shy to ask them right now, you may stay in this room. Oh, sorry, here, there's a question here. For Dr. Rosales, how long will pharmacologic management of chronic neuropathic pain in spinal cord injuries, and what is the prognosis?
Well, this is a good question, and this is a very clinical question, and for as long as the patient will present with neuropathic pain, the patient will need it. I would assume that they will need it at least 3 months, going through the platter of the first line agents, alpha 2 delta ligands,
just
and
having connect problems.
and
You'll try to a different.
sorry, alpha 2 delta ligands and TCAs and SNRIs, but yeah, we can consider those also.
Thank you, Dr. Rosales. I hope that we were able to address the questions from Metropolitan Davao Medical Society. So if there are no more questions, we'd like to once again extend our sincerest thanks to our speakers, Dr. Seng, Dr. Rosales, and Dr. Gomez. We appreciate you taking time out to help us learn more about the latest updates and standards when it comes to managing patients with spinal cord injuries. It's a complicated topic, I know, but we appreciate that you were able to break it down for us and make it more digestible and easily understandable. It's truly an honor to have the three of you speaking all in one room from different subspecialties. So to end this session presented by the Society for Neuroanesthesia of the Philippines, or SYNAPS, we would like to again reiterate that yes, while neuroanesthesia is a young subspecialty, it is developing at an exponential rate abroad and also here in our country, and it's important to keep updated, especially through the help of our colleagues from neurology, neurosurgery, and other members of the allied medical profession. And we hope that this session sparked further interest in this emerging subspecialty. And for those who would like to continue to appreciate the nuances of this field, we have, again, a short video to cordially invite everyone to the 7th Congress of the Asian Society for Neuroanesthesiology and Critical Care, or ASNAC, a hybrid congress which will be held in February 2023 in Conrad Hotel, Manila, hosted by SYNAPS and the PSA. So there you have it, our cordial invitation to our 2023 ASNAC event here in the Philippines. We are the hosts, so we hope you can join us again. Once again, thank you to our speakers, Dr. Seng, Dr. Rosales, and Dr. Gomez for this morning's session, presented to you by the Society of Neuroanesthesia of the Philippines. Thank you, everyone, and to our participants, thank you also for attending this session. Good morning.
Good day, dear colleagues. Welcome to our 70th anniversary celebration as we enter our septuagenarian years that has marked this virtual annual convention with the most appropriately timed theme, Rewiring the Anesthesiologist's Mind, a collaboration of experts. Let us spend the next 3 days together in this exciting re-engineering of minds, together with our roster of world-renowned speakers from here and abroad. Connect with us and join the panel discussions. We have big goals, and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Rewire your memory to develop a phenomenal recall of these reviews of fundamentals and comprehensive discoveries and updates in our trailblazing field. Rewire your attitude as we evaluate these proven solutions and appreciate the expert guidance as we look forward to promote and maintain a community of responsible anesthesiologists who can practice safe and quality anesthesia care in the pursuit of serving the interests of our members, our patients, and the nation. We are the Philippine Society of Anesthesiologists, and with our strong commitment to quality care, our sincere concern for our members, and our genuine interest for professional growth, we're ready to collaborate with the experts. We begin the countdown now. 3, 2, 1. Rewire!
Good day, dear colleagues, and welcome to the 53rd PSA Annual Convention. In celebration of our 70th anniversary as one society and one family of experts in the specialty, we welcome you to our virtual convention with the theme of Rewiring the Anesthesiologist's Mind, a collaboration of experts. Connect with us and join our planned plenary sessions with esteemed speakers and panel discussions with leaders in the field. We have one on challenges in the management of central airway obstruction, another on translating simulation to evidence-based practices and patient safety, and the last on preoperative assessment clinics. Rewiring our brains is the same as neuroplasticity, that refers to our brain's ability to restructure itself when it recognizes the need for adaptation. Listen to lectures on anesthesia in some of our special populations, from pediatric patients up to the anesthesia for geriatrics. Focus on cases of pregnancy, abdominal surgery, and orthopedic ambulatory procedures. We have big goals, and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Join us as we collaborate with each other as we move forward to the succeeding years and decades of the society.
good day, dear colleagues. Welcome to our 70th anniversary celebration as we enter our septuagenarian years that has marked this virtual annual convention with the most appropriately timed theme, Rewiring the Anesthesiologist Mind, a collaboration of experts. Let us spend the next 3 days together in this exciting re-engineering of minds together with our roster of world-renowned speakers from here and abroad. Connect with us and join the panel discussions. We have big goals and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Rewire your memory to develop a phenomenal recall of these reviews of fundamentals and comprehensive discoveries and updates in our trailblazing field. Rewire your attitude as we evaluate these proven solutions and appreciate the expert guidance as we look forward to promote and maintain a community of responsible anesthesiologists who can practice safe and quality anesthesia care in the pursuit of serving the interests of our members, our patients, and the nation. We are the Philippine Society of Anesthesiologists, and with our strong commitment to quality care, our sincere concern for our members, and our genuine interest for professional growth, we're ready to collaborate with the experts. We begin the countdown now. 3, 2, 1. Rewire!
Good day, dear colleagues, and welcome to the 53rd PSA Annual Convention. In celebration of our 70th anniversary as one society and one family of experts in this specialty, we welcome you to our virtual convention with the theme of Rewiring the Anesthesiologist's Mind, a collaboration of experts. Connect with us and join our planned plenary sessions with esteemed speakers and panel discussions with leaders in the field. We have one on challenges in the management of central airway obstruction, another on translating simulation to evidence-based practices in patient safety, and the last on preoperative assessment clinics. Rewiring our brains is the same as neuroplasticity that refers to our brain's ability to restructure itself when it recognizes the need for adaptation. Listen to lectures on anesthesia in some of our special populations, from pediatric patients up to the anesthesia for geriatrics. Focus on cases of pregnancy, abdominal surgery, and orthopedic ambulatory procedures. We have big goals and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Join us as we collaborate with each other as we move forward to the succeeding years and decades of the society.
Good morning. Welcome to the SIBA panel. I'm Dr. Fidel Payawal and I'll be your moderator for this session. In behalf of the SIBA PIL, I would like to thank the organizing committee and the officers of the Philippine Society of Anesthesiologists for giving us this opportunity. Our first lecturer for this morning is Dr. Celine Saldivar Ancheta. She's a consultant at the Department of Anesthesia at the Medical City. She's a graduate of the University of Santo Tomas, and she's the program director of Enhanced Recovery Program after surgery in the Medical City. She had her fellowship in cardiovascular and thoracic anesthesia and fellowship in surgical intensive care. Let's all welcome Dr. Celine Ancheta.
Thank you for the opportunity to give this talk. My lecture is on TIVA in ERAS, applying TIVA and ERAS in our practice. I am Selina Ancheta. I don't have relevant disclosures for this talk, but have given lectures on the following companies. The objectives for this talk would be, first, giving the benefits of TIVA or total intravenous anesthesia, and how we use TIVA in ERAS in our daily practice. So this is why you should listen to this talk. So let's begin. What is ERAS, or Enhanced Recovery After Surgery? It's a set of multimodal perioperative care pathways designed for early recovery after major surgery by maintaining preoperative organ function and reducing the stress response. The key elements of ERAS are pre-op counseling, nutrition optimization, standardized analgesic and anesthetic regimens, and early mobilization. Now, ERAS is nothing new to us. It used to be called optimized patient care or fast-track surgery. Now, why do we want to do ERAS? Because ERAS promises improved outcomes, reduced complication rates, shorter inpatient stay, and cost savings. ERAS was founded by Professor Henry Kellett in the 1990s. We started with colorectal surgery. And in 2021, there are a lot of protocols. There are also bariatric, gynecology, urology, pancreas, liver, head and neck, and orthopedic surgery. If you go through their website, you will find the ERA Society page. And you will see that the smiling faces of the people in the website. And why is this so? It's because using the protocols of ERAS would reduce care time by more than 30%, and it will reduce complications by up to 50%. So the Filipinos will not be left behind. In 2015, a group of surgeons, anesthesiologists, nutritionists, pain doctors, nurses, and allied medical health workers joined together in order to build the ERA Society Philippines. So the seat of the ERA's Center of Excellence is in the Medical City. In order to become the Center of Excellence, we had to train as well as pay dues to the mother country. After 5 years, we were able to teach the Philippine General Hospital, and they too have enrolled in the ERA Society mother component. Now, this is the ERA Society poster in the Medical City. And what we want to convey is success in the journey of a patient undergoing surgery is not only because of the surgeon, but because of the other people as well, the team that works behind the journey. The mission of the ERA Society is to develop perioperative care and to improve recovery through research, education, audit, and implementation of evidence-based practice. So maybe you will ask, what if we are not enrolled in the ERA Society? Well, because it is actually evidence-based, then we can use the elements which will be appropriate for our patient so that they will recover faster with good outcomes. Now, these are the elements of ERAS. And just like the journey of a patient, it has been divided in the preoperative, intraoperative, and postoperative course. So to mention a few, in the preoperative, there is pre-admission counseling, fluid and carbohydrate loading, no prolonged fasting, thromboprophylaxis, and no premedications. For the intraoperative, we have the short-acting anesthetic agents, the mid-thoracic epidural, which we'll be discussing today, avoidance of salt and water overload, and maintenance of normothermia. In the post-operative care, there is mid-thoracic epidural anesthesia and analgesia, no nasogastric tubes, early removal of catheter, early oral nutrition, non-opioid oral analgesics and NSAIDs, early mobilization, stimulation of gut motility, and of course, audit of compliance and outcomes. Do you believe that the anesthesiologist has a role in the outcome of patients? Well, the answer is yes. These are the anesthesia roles in ERAS, and they're actually big roles. In the preoperative course, we are involved in patient education, evaluation, and optimization. For the intraoperative course, we are manage the patient with goal-directed fluid management, temperature regulation, and post-op nausea and vomiting prophylaxis. For today, we're going to be discussing the anesthesia protocol. In the post-operative course, we are, of course, involved with the pain control. Now, the ERAS elements are best discussed using or involving a case. So for today, we have a 70-year-old female diagnosed with colon cancer, and she was scheduled for an exploratory laparotomy. According to the recommendations of the ERAS protocol, it's inserting a mid-thoracic epidural with a combined general anesthesia. However, we also have considerations for this patient. First, the patient is elderly, and she is prone to have acute kidney injury, and we want to prevent it. We want to prevent post-operative cognitive disorder or delirium, and we want to prevent post-operative nausea and vomiting. There are a few cited journals in this lecture, and if you want to read on it afterwards, and it will really be helpful, or it will impact your practice. So the first one would be the guidelines for perioperative care in elective colorectal surgery, or the Enhanced Recovery After Surgery Society recommendations in 2018. And this is the newest one. For the intraoperative items, the quality of evidence is low. However, the recommendation is high or is strong for standard anesthetic protocol. And why is this so? We use different protocols, or we use different techniques in giving our anesthesia based on our background, our training, or we try to tailor fit our anesthesia to our patient as well as to the comorbidities and as well as the surgery involved. So there are actually different ways on how we give our anesthetics. So a standard anesthetic protocol is quite difficult to achieve. Now, what are in the recommendations? First, we want to avoid benzodiazepines. We want to use short-acting general anesthesia agents. And we want to use opioid-sparing techniques so that you will achieve rapid awakening with minimal residual effects. However, there is no strong evidence or no strong data to support the recommendation for inhaled gases or propofol diva. So you'll ask yourself, why use propofol diva? Is there a seat of propofol diva in cancer surgery? And the answer is yes. There has been a large retrospective study done showing that there is a beneficial effect on cancer outcomes. It is linked with recurrence-free and overall survival. And how does this work? Propofol does not suppress cytotoxic NK cells. However, at this time, there is still no definitive recommendations. Now, why do we use Propofol Tiva? We use Propofol Tiva to reduce post-operative nausea and vomiting. Now, this is another recommendation in the protocol. So if you look at the quality of evidence, it is high, and the recommendations are actually strong in the prevention of nausea and vomiting. Why do we want to reduce post-operative nausea and vomiting? It's because of its serious complications, which include aspiration, dehydration, electrolyte imbalance, and wound dehiscence. And I think it's one of those things that patients remember most because of the discomfort and the dissatisfaction, and the increased direct or indirect cost to the patient and the hospital. Now, if there's the second cited journal, this is the fourth consensus guidelines for the management of post-operative nausea and vomiting, which I recommend that you also read. They have developed an infographics for us to easily remember the adult post-operative nausea and vomiting management. First, we have to find out the risk factors: female sex, younger age, non-smoker, the surgery type, history of post-operative nausea and vomiting or motion sickness, as well as the use of opioid analgesia. Now, with this, we have to do risk mitigation, which include the minimizing the use of nitrous oxide, volatile anesthetics, high-dose neostigmine. We should consider regional anesthesia, and we should use opioid-sparing techniques as well as multimodal analgesia, which are part of the enhanced recovery pathways. So in the strategies to reduce baseline risk, what did they say? We avoid GA by the use of regional anesthesia. We avoid the use of nitrous oxide in surgeries lasting over an hour. And we avoid the use of volatile anesthetics. And checked in red is use of propofol for induction and maintenance of anesthesia. So if you ask us, did we change our practice? Well, from using volatile anesthetics, we have actually shifted to using Propofol Tiva as our main agents. Now, going back to our patient, a 70-year-old female going for exploratory laparotomy. If our 70-year-old is female, then she garners 1 point for the APFL scoring. And if she doesn't smoke, then she has another point. How about history of post-operative nausea and vomiting or motion sickness? Then she will get another point. And if we use post-operative opioids, then there will be another point. So if she scores 4, then her risk of having post-operative nausea and vomiting approximates 80%. And what does the infographics tell us? For greater than 2 risk factors, we give 3 to 4 prophylactic agents. And the prophylactic agents can be in the form of 5-HT3 receptor antagonists, corticosteroids, antihistamines, dopamine antagonists, NK1 receptor antagonists, acupuncture, or anticholinesterases. And this includes in the circle propofol anesthesia. Now, will you ask us, do you use antiemetics and routinely? And the answer is yes. Our goal is for antiemetic multimodal prevention to become an integral part of anesthesia. Now, there was a mention of thoracic epidural anesthesia in the recommendations. Why is this so? The TEA is an adjunct in fast-track surgery. It optimizes pain relief, attenuates the surgical stress response, and allows early mobilization. What are the benefits of the thoracic epidural anesthesia? It's superior perioperative analgesia compared with systemic opioids. It decreases the pulmonary complications. It decreases duration of post-operative ill use after abdominal surgery, and decreases post-operative protein catabolism. However, what is the drawback? The drawback in capital letters is hypotension. And this is not a benign problem because it can cause end organ damage, such as acute kidney injury. Now, in the elderly, it has been mentioned in several studies that we have to at least accept a higher blood pressure or a MAP of greater than 65. So remember, a MAP of greater than 65 is our target for normotensive patients. But for patients who are hypertensive, then we have to even achieve a greater MAP. Now, aside from acute kidney injury, another consideration for a 70-year-old female with colon cancer is to prevent post-operative cognitive disorder or delirium. Now, some of us will say that we don't actually recognize post-operative cognitive disorder or delirium in the immediate post-op course. However, some of the relatives will say that in the 6 months or after, they will say that my grandmother or my parent was never the same after surgery. That's why there is still importance of monitoring the depth of anesthesia. Now, using a process EEG monitor, we are able to know the depth of anesthetic. Giving TIVA is actually a deeper plane of anesthesia. So more than awareness, we're actually scared of getting too deep on the anesthetic. That's why, just like in the BIS, we want to target a 40 to 60 for general anesthesia so that patients are unlikely to respond to noxious stimulus for both consciousness and noxious stimulus. Now, in order for us to make sure that our patients are not really too deep on the anesthetic, especially on the elderly, the burst suppression rate or the characters in red should be always 0. Actually, the target of the BIS scores has now been increased to 45 for elderly patients. Now, if this were a debate, hopefully we have convinced you to use propofol tibia in giving anesthesia for the 70-year-old female with colon cancer. The reasons for which are, first, it is short-acting general anesthetic. It will give rapid awakening with minimal residual effects. It has post-operative nausea and vomiting properties and has a seat in cancer surgery, as well as it is easier to titrate to clinical effect. However, to further convince you, let me share with you the study of Irwin et al. In Anesthesia 2020, giving you the potential benefits of propofol-based anesthesia. For the CNS, there is reduction in ICP or cerebral metabolic rate, and there's reduction of emergence delirium. There's no interference with neurophysiologic monitoring intraoperatively. For the renal system, there's reduced ischemia reperfusion injury, and it has been shown that there is less AKI after cardiac valve surgery. For postoperative pain, there is reduction in 24 hours pain scores and incidence of chronic pain while using propofol-based anesthesia. For the cardio system, there is hemodynamic stability when propofol is infused. And for the immunologic system, propofol has scavenging properties of free radicals, is an antioxidative agent, anti-apoptotic, and anti-inflammatory agent. So with that, we ask ourselves, are we done? When I was doing this lecture, I was thinking, well, maybe we're almost done, but we haven't given you the big or the full picture, because we can't just give anesthesia or just tell you to use propofol anesthesia, because propofol is actually devoid of pain. So we want to share with you the complete anesthesia technique. Now remember that we want to use opioid sparing techniques in our enhanced recovery protocols so that we minimize the side effects of our opioids in the post-operative course. So how do we use decreased amounts of opioids? Remember, we didn't say not to use opioids, but rather we use opioids sparingly. First, we give our fentanyl 50 micrograms 3 to 5 minutes before induction. This will give it time for the optimum work, or for it to work its optimum before we intubate or start our anesthetic. Then we give the rest of our 50 micrograms just before cutting. Now, adjuncts to our propofol would be dexmedetomidine, which is a systemic alpha-2 agonist. We try to give 1 microgram per kilogram before skin incision as a drip or as a slow boluses. This decreases the use of post-operative opioids as well as decreased post-operative nausea and vomiting. This blocks the pain pathway centrally. We also use gabapentinoids and gabapentin or pregabalin. If given oral 1 to 2 hours before surgery, it reduces pain severity and decreases post-operative nausea and vomiting. Now, you will say, how does this work? Remember that we use our gabapentinoids, gabapentin or pregabalin for patients with chronic pain or neuropathic pain. If you look at the Venn diagram of surgical pain, you will realize that there is a connection or intersection of somatic as well as neuropathic pain in a surgical setting. That's why we are able to use our neuropathic medications for surgical pain as well. Now you will say, without an epidural, how will the patient tolerate a wide excision? What we ask our surgeons is to do local infiltration, which simulates a tap block. Now, where will they place the local anesthetic? Not in the subcutaneous tissue, but rather in the muscle, where the pain fibers exit. So remember, we have to ask the surgeons to give the long-acting local anesthetic before they close in the muscle. So that also brings us to the different kinds of anesthetics that we give, or analgesics, which is actually multimodal analgesia. So the combination of local anesthetics, we also use sparingly opioids, NSAIDs, pregabalin, coxibs, and paracetamol to treat our patients. And with that, hopefully we're able to show you how we treat or how we manage our 70-year-old female with colon cancer, with the ERA's goals of improved outcomes, decreased complications rates, decreased inpatient stay, as well as cost savings. And with that, thank you.
Thank you, Celine, for that wonderful lecture. If you have any question, please send them through the chat box and the speakers will try to answer them after the third lecture. The second lecture is about the practical aspects of TIBA during the pandemic. Okay. Our lecturer is a revised neuroanesthesia and neurocritical care at Tan Tock Seng Hospital in Singapore and Masters in Management, Major in Health Administration of the Philippine Christian University, Assistant Chief of the Quezon City Medical Center, Professional Education, Training and Research Office, and a Section Head of Neuroanesthesia Section, Department of Anesthesiology and Perioperative Medicine at Rizal Medical Center. He is the Neuroanesthesia Coordinator of Quirino Memorial Medical Center and a Medical Specialist 3 in the same hospital. And she's a member of the steering committee of the CIBAPIL. Ladies and gentlemen, let's welcome Dr. Maria Sonia Yi Festin.
An awaking neotomy with the patient playing the guitar, colonoscopy, these are just some of the procedures that are done using total intravenous anesthesia or TIVA. But what about an AVY flap surgery of the thumb or insertion of glaucoma drainage device? You ask, can this be done using TIVA? In our current situation, now that COVID-19 is still at the forefront of every healthcare professional's concern, many previously done cases using general endotracheal anesthesia or LMA are being done using TIVA. This morning, I will give you some of the practical aspects of using TIVA in this COVID pandemic. Our learning objectives for this lecture are the following: to have an overview of the history of TIVA and COVID-19, to identify some of the challenges that we face, to know the benefits of using TIVA, to learn some of the practical aspects of using TIVA in COVID times, to discuss some of the issues and correlations between TIVA and COVID-19, to know the limitations of TIVA, to summarize what we have discussed, and lastly, to give you some recommendations on how we can further improve our practice of TIVA. Today's lecture is not going to give you the detailed discussion of dosages, models, or techniques, but this is going to be a discussion on the different articles and researches related to TIVA during this pandemic. It is a compilation of different practices around the world, taking into careful consideration the patient's safety, the surgical team's safety, and rationalization of resources used for the successful operation of a patient. These are by no means very rigid rules, but instead, it is an exhaustive and innovative way that is very dynamic as we gain new knowledge on this novel virus that is currently ravaging the world. First, let's take a brief look at how TIVA was started. Before we go to TIVA, let's take a quick visit on the history of anesthesia itself. In the article written by K.L. Dorrington and W. Poole, published in the British Journal of Anesthesia in January 2013, they said that our specialty commonly traces its origin to a demonstration of the inhalation of ether by the dentist William Thomas Wayne Morton to a patient undergoing surgery in Boston in October 16, 1846. But what about TIVA? Do you know when it was first done and who actually made the first ever experiment of doing an intravenous anesthesia? In the article entitled Historical Perspectives on TIVA by Chong Si Ted, he stated that the earliest administration of IV opium and alcohol into dogs was performed in Oxford University at around 1656. This less well-known demonstration of the IV injection of opium with alcohol into a dog was done by Sir Christopher Wren and Robert Boyle. Most authors, like an anonymous author in 1665, Hardin in 2002, Tinniswood in 2001, and Davis in 2008, all agree that the first experiments on IV injections took place sometime in 1656 in Boyle's quarters on High Street, Oxford, United Kingdom, and all agree in attributing to Wren the idea and execution. A dog was given an intravenous injection via syringe made of animal bladder fixed to a goose quill. Robert Craig, in his article published in 2018, stated that Charles Pravas in France administered coagulant to sheep in 1853. But it seems that Alexander Wood in Edinburgh combined a functional syringe with a hypodermic needle in the same year. He injected morphine into humans and probably should be credited with inventing the technique. The basic design has remained unchanged. Details from the momentous experiment of Sir Christopher Wren and Robert Boyle allow us to compare the technique used with modern management. It is important to consider why there was a failure to translate the results into clinical practice in nearly 200 years of potentially pain-free surgery. Possible factors include lack of equipment for IV access, lack of understanding of dose response effects, and a climate of scientific discovery rather than clinical application. So, why was the possibility of TIVA with opium and alcohol not developed soon after 1656 for use in human surgery? There are 5 main factors. First, there was the challenging problem of venous access. The cut down was invasive and unreliable. The percutaneous cannula for anesthesia that we now take for granted is a relatively recent luxury. Secondly, There is the difficulty of titrating the dose of a drug to effect. No record of surgical anesthesia in a human from that period is known. Thirdly, the primary cause of death from opiate excess, namely ventilatory failure, appears not to have been identified. Fourthly, it is also important to recognize that the search for mechanical and chemical explanations for aspects of human physiology was not in itself a project its practitioners needed immediately. Experimenting on live humans may well have struck even the scientifically active as ethically, even religiously problematic. Finally, we need to consider that at that time, the very concept of anesthesia was removed. We now take for granted a state of surgical anesthesia. Now, let's take a look at COVID-19. On December 31, 2019, WHO was formally notified about a cluster of cases of pneumonia in Wuhan City, home to 11 million people and the cultural and economic hub of central China. The cause of the severe acute respiratory syndrome that became known as COVID-19 was a novel coronavirus named SARS-CoV-2. As of November 30, 2021, there are 262,594,426 cases of COVID-19 worldwide, and the death rate was about 5.2 million. Phylogenetic analysis suggests that SARS-CoV-2 originated in animals, probably bats, and was transmitted to other animals before crossing into humans at the Huanan wet market in Wuhan City. There is some evidence that the intermediate vector may have been a pangolin, a type of nocturnal anteater imported illegally for its flesh. SARS-CoV-2 is not the first coronavirus to cause outbreaks of respiratory infection in humans. 6 others have been identified so far, all believed to have originated in animals. 2 non-endemic coronaviruses have caused serious disease in recent times. These are SARS and MERS-CoV. According to Liu et al. In their Lancet article published in 2020, SARS-CoV-2 more closely resembles the bat wild virus than it does either SARS-CoV or MERS-CoV, strongly suggesting that it is a novel coronavirus in humans. Probable risk factors for severe disease and death include the following. Men in these groups appear to be at higher risk. COPD, cardiovascular disease, and hypertension are strong predictors of admission to intensive care. Some risk factors may be explained by the virus's affinity for the angiotensin converting enzyme 2 receptor, which is expressed by the epithelial cells of the lungs, intestines, kidney, and vasculature. Although there is evidence of ACE2 receptor affinity of SARS-CoV-2, 2 studies from Italy and the US have shown that treatment with an ACE inhibitor or ARB is not associated with an increased risk of contracting COVID-19, severe symptoms, or a fatal outcome. The link, therefore, appears to be simply due to the higher risk associated with cardiovascular disease. Alpha, beta, gamma, delta, and now the newly reported Omicron variants of the SARS-CoV-2 coronavirus are classified as variants of concern. As of November 2021, there are 4 dominant variants of SARS-CoV-2, spreading among global populations. The newest variant of concern, Omicron, which was first reported in South Africa last November 24, 2021, was declared by WHO as a variant of concern last November 26, 2021. It is said to have a very high infectivity rate. Now, let us discuss some of the practical aspects of using TIVA in COVID-19 patients. Let us first define total intravenous anesthesia or TIVA. According to Vaidyanathan Mani and Neil S. Morton in their article published in 2009 and Z. Al-Rifai et al. In their article published in 2015, TIVA describes the maintenance of general anesthesia without inhaled hypnotics. As anesthesiologists, there are many challenges currently facing us, and we will tackle some of them in this morning's lecture. Here are a few of those challenges that we need to address when we handle our cases. Manipulation of the airway aerosolizes the virus. Most of the time, especially if we need to intubate or insert an airway device, there is no choice but to be close to our patients. Some rooms inside the OR and in other areas of the hospital are small and poorly ventilated. We sometimes get patients who don't present with any symptoms but are in fact infectious. And lastly, because of decrease in operations and manpower of many companies, some medications, equipments, and anesthesia paraphernalia are in short supply. In their article, the author, Dr. Martin J. London, stated that the goals for infection control during anesthesia include prevention of transmission of infection to care providers and prevention of contamination of the anesthesia machine and other anesthesia equipment. They reiterated that infection control measures should be the same for patients with suspected or confirmed COVID-19. Just like in the pre-COVID time, pre-procedure patient evaluation consists of the following strategies for reducing sedation-related adverse outcomes: reviewing previous medical records for underlying medical problems, a focused physical examination should be done, pre-procedure lab testing should be requested whenever indicated, and we should also take note of the positioning during surgery because there are a number of positions that will be very difficult for us to manage the airway if respiratory compromise happens. As stated earlier, as much as possible, we should avoid the manipulation of airways of our patients and use other anesthetic techniques. It is highly recommended to use either regional anesthesia or TIVA with spontaneous ventilation. If you are going to use the circuit, make sure to put filters in their correct positions. Just like in this diagram, for those of you who are using sample lines for your ETCO2, remember to put the sample line on the filter and not on the connector. The second figure on the right is a diagram from the Anesthesia Patient Safety Foundation, and they gave this recommendation in their article, which was published last February 2021. If intubation cannot be avoided, do not auscultate post-intubation to avoid putting your face near the face of the patient. You can use other ways of checking, like checking for ETCO2 reading, observing for equal chest rise, and checking the pressure in your peak, or using ear contactless stethoscopes. Extubation is an aerosol-generating procedure, and this should ideally take place in a negative pressure form. All non-essential staff should exit the room before extubation. PPE with airborne precautions is required, and for personnel entering the room for a variable period of time after extubation, remember to limit the need for subsequent staff interactions with prophylactic antiemetics, adequate analgesia, consider regional anesthesia, perform oropharyngeal suction with vigilance as this may generate aerosols. Use antitussive drugs to reduce the risk of coughing and minimize agitation and extubation. Fasting time of our patients is very important. Remember that it is not enough to ask the time of NPO, but we should also ask the specific food or beverage that the patient has taken. Because as you can see, fatty food has a longer recommended NPO time compared to non-fatty food, as well as infant formulas, non-human milk, compared to just clear liquids. Here are some medications that can be given to optimize our patients preoperatively. We should take note that following these guidelines does not guarantee complete gastric emptying. With or without COVID, appropriate emergency equipment should be available whenever sedative or analgesic drugs capable of causing cardiorespiratory depression are administered. This table should be used as a guide, which should be modified upon the individual practice circumstances. There should be intravenous equipment, basic airway management equipment, advanced airway management equipment, pharmacologic antagonists, and emergency medications. Present advisories recommend use of regional anesthesia in COVID-positive patients whenever possible. However, to allay anxiety and fear in such population, TIVA can be combined with regional anesthesia in individualized varying doses. For remote locations, TIVA is very useful where inhalational anesthetics are difficult to administer. Optimum titration of IV agents should be practiced, which minimizes airway obstruction, oxygen desaturation, unplanned airway instrumentation, and aerosol generation. In MRI suites, TCI pumps are not allowed and a long infusion line is required. Alternatively, TCI pumps can be kept inside aluminum case or radiofrequency shield enclosure or Faraday cages. Now, let us take a look at the different benefits of using TIVA. As what Dr. Johan Rader from Oslo University Hospital in his correspondence said, the TIVA concept is simple. An IV line is the only prerequisite and there is no need for sophisticated gas delivery systems or scavenger equipment. There is also no need for time-consuming procedures such as establishing regional blocks or neuraxial blocks, and no risk of block failure and unpredictable duration of residual paralysis. In vitro studies made by Stallings et al. And Cheng et al. In 2015 have revealed immune suppressive effects of volatile anesthetics on mononuclear cells and monocytes. According to Bajwa et al. In their paper published in 2020, these techniques can possibly flare up the pathology in surgical COVID patients where respiratory involvement is commonly seen. It is said that TIVA avoids the deleterious effects of immunosuppression and lacks any respiratory irritation, thus providing an edge in the current situation. Many peripheral surgeries can be done with the patient breathing spontaneously without any airway device, thus avoiding airway instrumentation, leading to droplet and aerosol generation. IV agents can be utilized to provide sedation during regional anesthesia, which can easily be escalated to contain pain due to sparing of blocks or receding neuraxial anesthesia. There is no chance of sudden increase in concentration of any gas or vapor, which can cause sudden hemodynamic changes. There is also no risk of malignant hyperthermia, less chances of emergence delirium, and TIVA also avoids distension of airfield spaces in the body as may be associated with the use of nitrous oxide, thus providing better surgical conditions. Furthermore, as stated by Vary et al. In their research in 2010, utilizing TIVA may lead to a decrease in PONV. Thus, it allows for patients to be discharged faster, to have a direct and positive impact on an ambulatory surgery center's ability to provide safe care while efficiently moving patients through the recovery room. This diminishes the recovery time required, may limit the number of staff members involved in the patient's care, and may limit the number of unnecessary person-to-person interactions. In TIVA, patients are usually not aware of placement of mask over face during induction. There is less operation room pollution and overall greenhouse effect is minimized. Stress response is reduced and there is better cerebral autoregulation. With non-touch or one-touch technique, we can avoid cross-contamination, making TIVA an advantageous option in COVID-19 patients. Majority of drugs are easily available in almost all the ORs across the world. In addition, all these drugs can be given to any subset of population suffering from COVID-19 disease in easily titratable doses. Now, let us go to the issue regarding drug supply shortage. COVID-19 patients in the critical care unit tend to have prolonged hospital stay requiring high doses of sedation and paralysis to treat acute respiratory distress syndrome, resulting in a shortage of these drugs. In one of the hospitals in Singapore, as reported by Au Yong et al., they have instituted strategies to rationalize drug and oxygen usage. This includes prioritizing time-sensitive elective cases, reducing overall elective caseload, favoring opioid reduction strategies, and usage of alternative anesthetic agents not commonly used in ICU. Both intensive care physicians and anesthesiologists have to cooperate on drug conservation, as similar drugs are used in elective operating lists as in the ICU. Patient safety is of utmost importance, and we should keep in mind some pitfalls and ethical concerns of these alternative strategies. Christoph Karl Hofer et al., their paper, said that to actively manage anesthesia drug supply in the context of the current pandemic, it is mandatory to have a detailed understanding of the number and types of anesthesia provided. On this basis, the annual consumption of anesthetics could be projected and the replenishment organized. In the published COVID-19 guidelines, minimizing wastage of critical injectable medicines, we are advised to act immediately to minimize the use of drugs needed in the care of COVID-19 patients in critical care. Anesthesiologists can use some first-line drugs, but departments should consider plans of use of alternative drugs, particularly where the first-line choice falls into the category of being subject to potential demand pressures. Departments of anesthesia and intensive care working with perioperative and critical care pharmacists will need to collaborate to decide on policies and practices to ensure drugs are prioritized appropriately across the two areas. To decrease waste, only draw up what you will use, including emergency drugs. Work with pharmacists to devise safe ways to use all the contents of drug vials and ampoules. Although counter to normal good practice, this may include sharing vials or ampoules between patients to minimize waste. Good governance, strict infection control, and safety are paramount. What are some of the issues that needs to be clarified? Data from researches of Cao et al. In 2012 and Chang et al. In 2018 suggests that propofol could upregulate ACE2 receptors. ACE2 is widely expressed in human cells and tissues and is a target cell receptor for internalization of SARS-CoV-2. Continuous infusion of propofol has the potential to increase tissue concentrations and then upregulate ACE2. It is therefore possible that propofol could enhance internalization of SARS-CoV-2 to precipitate and exacerbate development and persistence of COVID-19. On the other hand, according to the research done by Yamada et al., clinically relevant concentrations of propofol displays the binding of a selective sigma-1 receptor agonist. Propofol may be a sigma-1 receptor antagonist. Another research, which was more recently done by Penghui Wei et al. In February 2021, stated that propofol may exert direct antiviral effects by disturbing GM1 lipid rafts and inhibiting sigma-1 receptors, and by indirect effects including anti-inflammation, antithrombosis, and reduced immunosuppression. Additionally, elevated ACE2 expression induced by propofol treatment may protect pulmonary artery endothelial cells, inhibit apoptosis in vascular endothelial cells, and suppress SARS-CoV-2-induced systemic inflammatory cascade. Now for dexmedetomidine. In correlation with COVID-19, aside from its sedative and analgesic effect, dexmedetomidine has both cytoprotective and anti-inflammatory properties. In fact, its organoprotective effects against acute organ injuries such as brain, lung, and kidney have been well established in preclinical settings. Dexmedetomidine has potent protective effects through upregulation of protective proteins and attenuating cell death and systemic inflammation, and thereby may protect vital organs from multi-organ disease or multi-organ failure in COVID-19 patients. Recent analysis for ketamine and COVID-19 identified neuropsychiatric manifestations related to COVID-19 in 22% of patients, including anxiety, depression, mood disorders, and psychosis. Whether the psychiatric manifestations in these patients are attributed to excessive systemic inflammatory response in the form of viral sepsis, immune-mediated response, or SARS-CoV-2 direct virus-induced damage to brain vasculature warrants further study. Ketamine has been long used in the management of treatment-resistant depression as a non-selective NMDA receptor antagonist, utilizing both its intranasal and intravenous form, even though the latter showing better efficacy. Recent data have come to show that it effectively treats both typical or melancholic and atypical depressive symptoms, even though the exact mechanism underlying its efficacy remains unclear. For the method of administering TIVA during this pandemic, there are joint guidelines from the Association of Anesthetists and Society for Intravenous Anesthesia, which has provided safe practice of TIVA before the start of the pandemic, and these guidelines still stand even today. Apart from taking all the precautions meant for surgical COVID-19 patients, Badjoa et al. In their article published last year recommend that an N95 mask has to be worn by the patient throughout the surgery and post-operatively to prevent contamination. However, this recommendation will be affected by supply. Even with the most advanced technology, the anesthesiologist is still the best monitor for all patients, not only for those infected with the virus. Multi-parameter monitoring is recommended, especially when a neuromuscular blocking drug is used with TIVA. Newer advancements in technology, coupled with advanced vast knowledge about pharmacokinetic and pharmacodynamic properties of drugs, make TIVA a unique and dominating concept in times to come. Do not be discouraged if your hospital does not have a TCI pump. You still can do TIVA, although a little bit more difficult, but it is still doable. In their research entitled Induction and Maintenance of Propofol Anesthesia, a Manual Infusion Scheme, F.L. Roberts et al. Reported this manual infusion scheme of propofol. This is the doses that they have recommended. If there are benefits and advantages of using TIVA, there are also some limitations that can be seen. The major limitation with TIVA include pain on injection, especially true with propofol, though that limitation is reduced with administration of agents such as lidocaines or opioids and using wide-bore cannula. The other challenging situation may arise in cases of difficult cannulation, though this will be equally challenging in cases of providing anesthetic agents via maintenance with inhalational agents. The major limitation is costly equipment used in TIVA, including disposables. Other limitations include the risk of bacterial contamination, especially when there is frequent misconnections in line. Environmental effects of plastic waste remains, though that is also true for regional anesthesia and greenhouse effect for inhalational anesthetics. Caution is advised in prolonged procedures and obese subsets. To summarize, TIVA is a viable and safe alternative with added benefits. Inhalation agents may lead to immunosuppression and can be deleterious during this COVID pandemic. Respiratory irritation and increased secretions may lead to coughing and straining, as is common with volatile anesthetic agents. The newer IV hypnotics and analgesic agents with favorable pharmacokinetic properties have made TIVA feasible in a wide array of varying clinical scenarios and anesthetic demands. Manual controlled infusions using regular syringe pump or Soluset can be used to deliver pre-calculated doses. TCI pumps and depth of anesthesia monitors have made administration of TIVA very easy, safe, and precise technique. In the COVID-19 scenario, TIVA offers anesthesia for NORA and peripheral surgeries with the patient breathing spontaneously without the need for airway instrumentation. In recent times, less aerosolization, concept of rapid discharge, daycare procedures, and green environment have created the re-emergence of TIVA. The following are my recommendations after reading and analyzing all the articles and researches that are available currently. There should be a local guideline for the safe practice of TIVA, and its inclusion in training programs as part of core competency should be maintained. There should also be regular simulations and web clinics to be able to discuss and analyze current techniques, find gaps, and resolve issues. There should be researches on TIVA for adults and pediatric patients to improve and disprove current knowledge. When general anesthesia is to be maintained by propofol infusion, use of a TCI pump is recommended, but absence of one should not discourage us from using TIVA as a preferred technique. Within an anesthetic department, it is preferable to stock only one concentration of propofol and to dilute remifentanil to a single standard concentration, rationalize drug use to maximize available medications, and gain knowledge in using a variety of drugs. I hope that you learned a few things from my lecture this morning. Thank you for listening. A very good morning to everyone.
Thank you also, Sonia, for that wonderful lecture. And thank you for taking us down the memory lane of TIBA and the wonderful tips during this COVID pandemic. The next lecturer actually will talk on TIBA for pediatrics, and she is an associate professor from the Department of Anesthesia and Reanime University of Acıbadem, Istanbul, Turkey, and graduated from the Department of Anesthesia at Reanime University of Marmara, Istanbul, Turkey. Is a member and ex-general secretary of ASPA, a member of the Educational Committee of ASPA, member of the Scientific Committee of Pediatric Anesthesia of Turkey, Turkish Society of Anesthesiology and Reexamination, country representative of Turkey at the WFSA Pediatric Anesthesia Committee, and honorary president of Society of Anesthesia Technicians of Turkey. She has interest in pediatric anesthesia, regional sedation, TIVA, fluid management, focus, standardization of education, geriatric anesthesia, and regional anesthesia. Ladies and gentlemen, let's all welcome Dr. Sarah Serpil Ustalar Ozcan. I hope I pronounced that correctly.
Welcome, dear colleagues. I'm very honored to be with you, even in online situation. But I wished I could be there, but now the circumstances is not okay for it. I'm very honored to be invited to your meeting. I will try to talk about TIVA in pediatrics. I'm working at Istanbul, and this is my university, and maybe you remember Istanbul. I hope next year you will be able to coming to Istanbul for the Asian Society of Pediatric Anesthesiologists meeting, which will be held in October in 2022. And my talk will be about TIVA, and I try to point out why we use TIVA, when we use TIVA, and how is it used, and with what TIVA we are using, and the pitfalls about TIVA will be covered. We use TIVA because of necessities. We use, since it has some benefits, and we use it because we choose to use it. We prefer TIVA since the patients has less postoperative nausea and vomiting, We cause less operating room pollution, and the emergency delirium is reduced with TIVA, and airway reactivity, laryngospasm and bronchospasm are reduced as well. And also TIVA is advocated for neuromuscular diseases, core myopathies, and muscular dystrophies. And TIVA has less interference with evoked potential monitoring. TIVA also associated with overall reduced costs, and it's a reliable delivery in airway procedures where we prefer spontaneous breathing. Why not we choose TIVA in some situations? Since we are familiar with inhalation anesthesia, we are all using it and very convenient, it's easy, and especially in pediatric patients, if you have no IV, inhalation is easy. And inhalation causes good muscle relaxation, and the spontaneous ventilation, the patient self-titrates the spontaneous ventilation, so it's easier and we are familiar with it. Sometimes or usually our IV lines are under the drapes and we are not sure about that. So TIVA will be a little bit more suspicious for us. TIVA is a relatively new technique, and it is difficult to titrate and to learn. It causes slow recovery if you don't follow the patient and the surgery properly. And there's also a possibility of propofol infusion syndrome. The need for venous access and the pain on injection of propofol makes us use inhalation anesthesia mostly, and the risk of bacterial contamination of propofol is an issue. There is no current ability to monitor the blood concentration exactly, and there are some delivery problems that may go unrecognized. We need special equipment, infusion pumps for TIVA, and less training is available for TIVA techniques. Drugs require metabolism for clearance, so this is an issue. Risk of associated metabolic phenomena is an issue. Drugs waste is a problem. There's a potential for disconnection and a risk of awareness if you cannot follow the patients or the IV lines properly. And the depth of anesthesia monitors in children is unrivaled, especially in infants. There are some contraindications that we shouldn't use TIVA, one of which is mitochondrial disease. And the purist is explained as propofol infusion syndrome, and it's encountered when propofol infusion, long propofol infusions are talked about. Propofol infusions should not exceed 4 milligrams per kilogram per hour for periods longer than 48 hours, which may be a problem in intensive care units. If we have to use long duration of propofol infusions, we should monitor arterial blood gases, serum lactate, creatinine kinase, and electrolytes, and renal and liver functions as well. And also, propofol infusion causes arrhythmias like Burkitt-like syndromes in medium chain acyl coenzyme dehydrogenase deficiency patients. Whatever you use during TIVA, mass infusion rates, smart pumps, open loop systems or closed loop systems, or manual infusion pumps or burettes, experience, skill, knowledge is very important. Titration of the infusions are of vital importance in order to avoid awareness, pain, and other adverse effects. When we use TIVA, we should be very careful and very know intensely the pharmacokinetics and dynamics of the drugs we use, which may be different in neonates, in infants, and the pre-reported child. In neonates, as we know, there's a global immaturity and increased sensitivity, and doses are increased, and the targets are lower than the others. In infants, there's a progressive increase in distribution volumes until 1 year of age, and fast maturation will increase in periods after 6 months of age we encounter. In pre-reported child, we have volumes greater than twice as much as the adults, and there is an intercompartmental clearance which is 50% greater than the adults. And also clearance is the major determinant of drug infusion rate at a steady state, as we know. Children, but not the neonates, require higher drug infusion rates than adults to achieve the same target concentration. As we know, some enzymes are mature at birth, one of which is the non-specific blood esterases that metabolize remifentanil, uses such clearance pathway. Clearance of remifentanil, when expressed as per kilogram, is highest in neonates and decreases with age to reach adult rates in adolescents. The loading dose, as we know, is dependent on the distribution volume rather than the clearance. The drug volume of distribution is influenced by both the composition and drug characteristics, which may be different in small premature neonates or the infants. Blood composition changes are dramatic over the first few years of age, such as fat, which may be 3% in a premature neonate, will be doubled in 4 to 5 months of age. Protein mass increases when infants start walking, and in a term neonate results in a larger volume of distribution for both propofol and remifentanil in children. So children requires a larger loading dose expressed per kilogram than healthy adults. And also we have some monitoring problems in children. Pharmacodynamic monitoring using processed electroencephalogram signals is problematic in neonates and infants younger than 1 year of age. This spectral index monitoring and narcotrain have shown a close relationship with the model effect site propofol concentrations and can serve as a measure of anesthetic drug effect in children older than 1 year of age. The narcotrain shows a promise for infants older than 4 months of age. And clinical signs rather than processed electroencephalograms are currently required for depth of anesthesia assessment in infants and neonates. When we come to propofol usage in neonates, PK clearance is reduced due to immature enzyme clearance systems, and which we can use during the first 10 minutes in neonates. 24 milligrams per kilogram per hour is suggested, but should be used cautiously due to the danger of an overdose if the infusion continues. We should be aware of the delayed awakening and also the hypertension and increased incidence of bradycardia in neonates. Please be careful that propofol can cause profound hypotension, which may be very harmful in neonates. McFarland and Stir has many infusion scales like this. From neonates to 3 months of age, 25 milligrams per kilogram and hours is suggested, which is decreased 5 in 15 minutes intervals. And the starting dose and the infusion rates are decreased as the child grows up. These scales are the most used scales. And also for neonates, there's a manual infusion rates, which is suggested by Dr. Brian J. Anderson and his friends. These are lower doses. 2 milligrams per kilogram induction dose is suggested for the 27 to 44 post-menstrual age weeks babies. Every 15 minutes, the doses get decreased. And there are some disadvantages of propofol manual infusion regimes, since there is no clear indication of propofol dose being delivered if administered as a rate infusion. Neither the estimated propofol concentration nor the effect site concentration can be displayed on a pump screen. Frequent changes of drug infusion rate are required to maintain a constant plasma propofol concentration. If you desire an increase in target plasma propofol concentration, this requires a manual bolus to be administered and the infusion rate to be increased. If you want a decrease in target plasma propofol concentration, this requires the infusion to be switched off for a period of time and the rate is reduced. And validation studies for pediatric pharmacokinetic parameter estimated are very few. There are some studies about comparing manual infusions with TCIs. They noted that there's similar depth of anesthesia and similar hemodynamic stability, whereas when propofol administration with manual infusion is guided by clinical assessments like heart rate, respiratory rate, and movements, this is associated with higher risks of over or under dosage. But when guided by this, no major difference was found between the use of different PK parameter sets between manual infusions and TCIs. There are some drugs can be used in conjunction with propofol, which may be remifentanil, arfentanil, or supantamil, or ketamine, or dexmedetomidine, which may allow us to avoid non-depolarizing muscle relaxants, which allows better titration of the drugs to effect, lowers the potential for awareness, and which contributes to early recognition of problems associated with drug delivery. Remifentanil, as we know, the volume of distribution and clearance decrease with increasing age. The smaller the child, the greater the clearance when expressed in milliliters per milligram per minute per kilogram. The younger children require higher infusion rates than the older ones. Children less than 5 years or 20 kilograms will require up to twice the dose of remifentanil to produce the same clinical effect as older children. Remember that there's tolerance in higher infusion rates, and longer acting opioids should be given 40 minutes before the end of surgery in order to compensate the tolerance caused by remifentanil. As we know, remifentanil has a high potency and it has a fast onset, and context-sensitive half-life is 2 to 3 minutes. 25 nanograms per kilogram per minute reduces the concentration of propofol we use in 3 to 10 years of age babies in esophageal gastroduodenoscopies. Usually 0.1 to 0.5 mics per kilogram per minute gives us a sufficient analgesia. Remifentanil has little effect on this. Bonus doses greater than 0.25 mics per kilogram in infants younger than 6 months of age, in whom blood pressure decreases can cause a lowering of the cerebral perfusion, and increase in remifentanil infusion rate is better. There are some suggested target concentrations or infusion rates for propofol with remifentanil for minor surgeries, which allows us spontaneous ventilation, and for minor surgery and major surgery, we can use these as either target controlled infusions or infusion rates. When we come to arfentanil, it's relatively fast onset. We can use it for oral infusion as well, but usually we'll have a residual analgesic effect at the end of surgery. We can use with propofol. Longer context sensitive than remifentanil time has arfentanil, 10 to 45 minutes after 2 hours of infusion, but this may delay recovery. We should remember that when we use arfentanil, respiration needs to be supported. 1 mics per kilogram per minute stays longer in recovery than remifentanil, 0.25 mics per kilogram per minute for 1.5 hours of infusion. Higher instance of postoperative hypoxemia and need for naloxone is encountered by arfentanil infusions. Arfentanil should be stopped 10 to 15 minutes before the end of surgery. Ketamine is an hypnotic and analgesic and has a cardiorespiratory stability, as we know. The onset of anesthesia after IV bolus is 30 seconds. The ketamine infusion can be used 1-to-1 ratio. Manual infusion rates range from 0.1 to 2.5 milligrams per kilogram per hour. Ketamine has less nausea and vomiting, but longer recovery. Midazolam can be used. Co-administration reduces the propofol dose for induction. The infusion rates can be 0.05 to 0.83 mics per kilogram per minute. Improves hemodynamic stability but delays recovery. Dexmedetomidine is a very useful drug during TIVA in children. Immature clearance in the first year of life and higher clearance in small children dictate infusion rates that change with age. Maintenance of respiratory drive, conserved airway patency, and opioid-sparing analgesic effect, and neurophysiologic evoked potential preservation and possible neuroprotective effects are the advantages of dexmedetomidine. For administration with midazolam, fentanyl, ketamine, propofol, and lamivudine is possible without hemodynamic compromise. Fever neuroapoptotic consequences attributed to alpha-2 agonists like dexmedetomidine, so this is an advantage. We can use 2 mics over 10 minutes followed by 1 mic per kilogram over the next 10 minutes for sedation plus caudal, and there is a minimal need for airway intervention during inguinal hernia and repairing terminates. Infusion can be between 0.5 to 1 mics per kilogram per hour. This reduces propofol and opioid requirements, provides moderate hypotension, decreases blood loss, allows monitoring of blood, monitor and somatosensory evoked potentials, and also reduces emergence delirium. However, there is a slightly prolonged waking time. You should wake the child to wake up more than the other infusions. The total intravenous anesthesia with proper agents may allow us spontaneously breathing infants during bronchoscopies. If we do not use remifentanil and dexmedetomidine can be substituted, this can be possible. Substituting fentanyl or arfentanil for remifentanil is also allows us spontaneous breathing children during bronchoscopies. Local anesthetic can be coupled to supplement analgesia. Remifentanil infusion for the children bigger than 3 years up to 0.15 mics per kilogram per minute used with propofol, and for younger children, younger than 3 years of age children, up to 0.3 mics per kilogram per minute may allow spontaneous breathing, but we should monitor respiratory rate, anti carbon dioxide, anti volume. When the child breathes lower than 10 breaths per minute, and or the tidal volume decreases, we should be aware that the apnea is imminent. For clinical anesthesia during drug delivery, we should have a very secure IV access. Infusion lines should be placed as close as possible to the venous columna. One way, non-return valves prevent backflow of IV fluid lines. Combining infusions into a single vein run the risk of inadvertent bolus of companion drug unless proximal dead space is minimized. The infusion site is not always readily accessible in small children, so you should always check the infusion site. CVP is useful during major surgery. IV tubing, dead space, shrink size and types are important. The more diluted solution, the faster the syringe movement with more mesh delivery is possible. Depth of anesthesia processed EGG should be used to monitor the children under TIVA. Despite there are some limitations in infants, this is usually useful in older children, particularly when muscle relaxants are used in conjunction with TIVA. But please keep in mind that they are unreliable, lower than 1 year of age, and also there's a latency of EEG, and also electrical interference is a problem. So consider the indications and contraindications, risks and benefits of TIVA when you use it. Avoid delivery problems. Safe IV is essential. Pain on injection and keeping IV secure and the control at all times are very important. You should be familiar with manual infusion machines. We have to keep an eye to the altered PK of neonates, infants, and children, monitor BIS, vitals, and movements all in one, and be careful in children with lower cardiac reserves. So thank you for inviting me and listening to me, and you are all welcome to Istanbul next year. Thank you.
Thank you, Dr. Ozgen. And in behalf of SIBA Philippines, we would like to express our gratitude to you for accepting the invitation through the courtesy of Dr. Tess Batanes. I hope we can also invite you again in the future and other activities of SIBA Phil. We are now ready for the open forum. We have a few minutes allotted to us. There are several questions. The first one I would like to ask Dr. Ancheta. This is from an anesthesiologist in Aklan Hospital. I'm interested to practice TIBA, but unfortunately we don't have the BIS monitor and dexmedetomidine. How would you perform TIBA in the absence of such medicines? Shalene?
If they don't have dexmedetomidine and
BIS.
And BIS.
Yes.
Okay. So we can give you the distributors of BIS and dexmedetomidine. But actually, at this time we use the Connox monitor, and our strips, or the EEG strips that we use, are not readily available now. So if you've been practicing, you've been using TIVA, then sometimes you don't need to use the BIS. We often use it for elderly patients. So the titration is actually, if you are familiar with it, then titration with TIVA is okay even without the monitor. So, and for the dexmedetomidine, you can do away with it. Actually, you can just you'll be giving higher doses of your propofol and your opioids if you don't have your dexmedetomidine. But otherwise, we can give you the distributors of these two items. Thank you.
Even though BIS is required, no, as a precautionary or a safety precautions for TIBA, as an added testimonial, I don't also use BIS, Celine. There's another question to Dr. Ancheta. In case of intra-op hypovolemia under TIBA, and you don't have BIS, do you suggest shifting to inhalational anesthesia for better titration of the depth of anesthesia?
I don't. This happens to us often, especially in cases where we lose a lot of blood. So management of hypotension is different from managing the anesthetic. So manage your hypotension in terms, if you are scared that the patient's going to wake up. Well, because of the hypotension, you tend to decrease the level of your propofol infusion. So we don't usually go below 1, the infusion of 1 microgram per ml. So about 1 to 1.5 microgram per ml if the patient is hypotensive. Then we continue managing the hypotension. So we don't shift to inhalational anesthetics. Because if you shift to inhalation anesthetics, there's going to be an overlap, and it can also be detrimental, because with the inhalation and the propofol at the same time, then there's going to be an overlap of your anesthetics, and you may have further hypotension. So we don't usually shift.
Okay, thank you. I think this one is for Sonia, Dr. Festin. In making a patient wear an N95 intraoperatively, how would you give your oxygen inhalation, especially if the patient is sedated?
Actually, currently we're just using surgical mask for our patients, right? So basically it's the same method of giving oxygen supplementation to our patients. We give them oxygen supplementation via nasal cannula at the lowest oxygen possible that they can tolerate.
Okay.
Sir, if I can add to what Dr. Ancheta
Go ahead.
answered earlier regarding the deficiency of dexmedetomidine and BIS monitor.
Yes, go ahead, Sonia.
Yes, sir. Because I remember before when I just arrived from my training in neuroanesthesia, our hospital didn't have any alternative medications or any equipments like this monitor or TCI pumps. So what I did was I just used manual infusion pumps for my drips. And then actually if your hospital doesn't have any dexmedetomidine, then you can as what I mentioned earlier in my lecture, you can actually use alternative medication sedatives like propofol, your ketamine, so other medications, other drugs that can be used as sedatives.
Okay, thank you. This one I think is for Dr. Serpril. What pediatric model do you use for your TIVA, Dr. Osjan? What pharmacokinetic model, pharmacokinetic and pharmacodynamic model?
Actually, nice question. Thank you. I also want to add something for the BIS monitoring and the TIVA. Yes, BIS monitoring is excellent if you use TIVA, but if you don't have this, or if you cannot have the possibility of using it because such as rhinoplasties, you cannot place the BIS probe to the face, the surgeon doesn't want. So you have to use the titration, the doses appropriately with experience. So experience is essential. The titration is essential also. In my hospital, we don't have a TCI for pediatrics, but if we do have, we use Kataria. But I usually use with this, though we don't believe the BIS, since it's not accurate for the infants below the age of 1 or 4 months. It guides us by clinical monitors like heart rate or high blood pressure or the movements, but we use blood neuromuscular blockade. We use the titration and the formula of Dr. Farlan.
Okay, thank you.
Manual infusion we use.
Okay. This question is for Dr. Ancheta. Is PRIS a concern in TIBA, especially when it is used in long surgeries?
Okay, as mentioned earlier, you shouldn't be using it at 4 milligram per kilogram, more than 4 milligram per kilogram per hour, and more than 48 hours. So I hope your surgeries are less than 48 hours. So we don't usually have PRIS because I don't have 48 hours. Anyway, we have long surgeries like hepatectomies and transplant surgery, and we don't actually observe PRIS.
How about you, Sonia? When you use it for neurosurgery, what was the longest time that you have used your TIVA?
Sir, definitely not 48 hours. Our neurosurgeons are very good, so they really have very fast surgery, so they finish early. But actually, I think this particular problem will really be a concern in the ICU, more so in the ICU than in the operating room.
Okay, from Ethel Mendoza, Dr. Ancheta, what is your usual preemptive dose of pregabalin?
My usual dose is 75 milligrams, 2 hours before surgery.
And from Nina Manansala, why prefer thoracic epidural over lumbar epidural for your ERAS? Is there any particular reason?
Yes, because the If you put your epidurals in the lumbar area, then our patients won't be able to move post-operatively. And they'll also have, you'll be thinking of urinary retention. That's why they recommend that it be placed in the mid-thoracic. However, if you place it in the mid-thoracic and it's like an exploratory laparotomy or a colorectal surgery, then it's like, why do you put the epidural in the thoracic area when your surgery is below? So definitely the thoracic epidural won't be adequate. You'd have to give general anesthesia as well. So the thoracic, if you put your epidurals in the thoracic area, it won't affect bladder control. I mean, little bladder control, and you won't affect mobilization post-operatively, which are the elements that ERAS is looking after. So plus the sympathetic chain is in the thoracic area. That's why they want to put it in the thoracic area.
Follow-up question from Cecilia Puerta. What alternative medicine can you use if the patient is allergic to pregabalin? Is there any alternative drug?
Then they should also be allergic to gabapentin. Well, then probably you don't have to give it. Then maybe you can use your dexmedetomidine.
Okay. Do we still have time? I'm not getting any response from the coordinator. Well, there are so many other questions. Is the patient on Tiba propofol? Can we give muscle relaxation drugs? I think that's Celine.
If your airway is secured, then definitely you can give your muscle paralysis. We use Tiva in all sorts of surgeries. I mean, in most surgeries, and we paralyze our patients just as long as the airway is secured. So if you're just going to sedate your patient, then of course you cannot paralyze your patient using your Tiva. I'm sure the other speakers will also say something.
Yeah. This is Dr. Asjan. You would like to say something?
If we use muscle relaxants, please be careful about the awareness, because if you use muscle relaxants, the patient will be paralyzed and cannot move. So this is more important in this situation.
Okay, there are two more questions for Dr. Osgen. Can you give us some procedures that you use propofol Tiba in pediatrics? And what Tiba drugs do you usually give for pediatric patients for MRI, NORA procedures, or dental procedures?
Thank you for the questions. We use usually propofol for MRI procedures. If there is pain expected, then we can use low-dose remifentanil. The operations we use Tiva sometimes, especially if the child has an experience before, like emergency delirium, we use Tiva. Or every operation we can use Tiva, but bronchoscopy is especially preferred, since the inhalation anesthetic could not be used properly, and we prefer sometimes spontaneous ventilation in these circumstances. Sometimes for the very difficult babies, we use dexmedetomidine with low-dose ketamine as well for very tiny infants, if we try to keep the spontaneous ventilation. And also I see a question there about the obese patients. It's an important issue. Thank you for the question, because the pharmacokinetic and dynamic studies have not been all complete for the obese patients, obese children as well, especially obese children. You have to use the drug, whatever you use, propofol or remifentanil or dexmedetomidine. You have to know which body weight you will use it, lean body weight, ideal body weight, or total body weight. So calculate titration, the doses appropriately, and begin the infusions likewise. Since obese patients should be monitored with this as well, in order to prevent awareness.
So what will be your favorite drug concentration and brands that you will use for NORA or out of OR procedures?
Usually propofol. Usually we are used to propofol, and 1 milligrams per kilogram is usually enough.
If you are using a TCI pump, usually what will be your target?
No, in the MRI we use burettes. We don't have MR compatible infusion pumps now.
So you just drip it.
Yeah, yes, just no, with the burettes we use.
Okay, thank you, Doctor.
Thank you.
Dr. Ancheta, you have several questions here. How do you give your gabapentinoids for post-op analgesia?
Yes, we give it for about 5 days. How do you give it?
Give it daw.
We give it because gabapentinoids and pregabalin can give you some sedation, so we offer it, or we give it at night. So for patients whose pain is not controlled, we usually give it at night dosing. So just one, like pregabalin, 75 milligrams at bedtime for about 5 days. But for those patients who have low tolerance for pain, or the procedure is really painful, then we give it twice a day. But more often with just one dose at night, patients are good enough, are happy with it.
Okay, thank you. Last two questions. I'll direct this to Dr. Festin. Is allergy to egg equal to allergy to propofol? And the other question is, any comment on the use of propofol in endoscopic procedures in patients who are known to be asthmatic?
For the first question, sir, I'm sure that all of us here know that it is not equal. Allergy to eggs is not equal to allergy to propofol. So there are a lot of our patients who are allergic to eggs, and actually they have other allergies, but they are not allergic to propofol itself. So you can still use propofol even in your patients who have allergies to eggs. And then for the second question, what was the second question, sir?
I forgot. What is the second question? Let me see. Let me check first.
And also, I would like to add, the new propofol preparates, I think they don't have the allergic part
Yes,
of the
that's
egg,
right.
I think.
Okay. Hello? Nag-cut out kayo. Okay.
As far as I know, there is no phone apps used for TIVA. Just you can use Google if you search for the doses.
One last question, Doctora. Is propofol safe for infants? Because it's an off-label use.
All drugs we use in infants are all off-label, actually, except sevoflurane, remifentanil, and rocuronium. But if you use propofol, please give it slowly, since hypertension is more harmful for the infants. If you give it very quickly, the pain as well as the quick vasodilatation causes hypotension, which is detrimental to infants. But as far as I know, we can use it at very low ages as neonates as well. But be careful about hypotension, hypoxia, airway control. These hypoxia and the desaturation or hypocarbia are more important.
Okay. There are many other questions, but I can see already Dr. Valera on the screen for the next session or the next panel. So in behalf of the CIBAPIL, I would like to thank all the participants, most especially our speakers, Dr. Sonia Pistin, Dr. Celine Ancheta, Dr. How do you call this? Serpil Osgen?
Sarpil. Serpil Özgen, thank you for inviting Dr. Tayaba.
And hope we can all meet personally in the future. And
You are all welcome to Istanbul next year.
and we are inviting everybody to watch the lecture of Dr. Michael Irving tomorrow at luncheon. He will be talking about propofol in cancer surgeries. Okay, so thank you everybody, and thank you for spending your morning time with us.
Thank you.
Thank you.
Thank you.
Good day, dear colleagues. Welcome to our 70th anniversary celebration. As we enter our septuagenarian years, let us mark this virtual annual convention with the most appropriately timed theme, Rewiring the Anesthesiologist Mind, a collaboration of experts. Let us spend the next 3 days together in this exciting re-engineering of minds, together with our roster of world-renowned speakers from here and abroad. Connect with us and join the panel discussions. We have big goals, and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Rewire your memory to develop a phenomenal recall of these reviews of fundamentals and comprehensive discoveries and updates in our trailblazing field. Rewire your attitude as we evaluate these proven solutions and appreciate the expert guidance as we look forward to promote and maintain a community of responsible anesthesiologists who can practice safe and quality anesthesia care in the pursuit of serving the interests of our members, our patients, and the nation. We are the Philippine Society of Anesthesiologists, and with our strong commitment to quality care, our sincere concern for our members, and our genuine interest for professional growth, we're ready to collaborate with the experts. We begin the countdown now. 3, 2, 1. Rewire!
Good day, dear colleagues, and welcome to the 53rd PSA Annual Convention. In celebration of our 70th anniversary as one society and one family of experts in the specialty, we welcome you to our virtual convention with the theme of Rewiring the Anesthesiologist's Mind, a collaboration of experts. Connect with us and join our planned plenary sessions with esteemed speakers and panel discussions with leaders in the field. We have one on challenges in the management of central airway obstruction, another on translating simulation to evidence-based practices in patient safety, and the last on preoperative assessment clinics. Rewiring our brains is the same as neuroplasticity, that refers to our brain's ability to restructure itself when it recognizes the need for adaptation. Listen to lectures on anesthesia in some of our special populations, from pediatric patients up to the anesthesia for geriatrics. Focus on cases of pregnancy, abdominal surgery, and orthopedic ambulatory procedures. We have big goals, and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Join us as we collaborate with each other as we move forward to the succeeding years and decades of the society.
today our esteemed anesthesiologists and organizers from the Philippine Society of Anesthesiologists Annual Convention. My name is Therese Hoxon and I am the marketing manager for Baxter Healthcare Philippines, and I am very excited to welcome everyone in today's Baxter Symposium. So today we are fortunate because we are graced by distinguished speaker from Pennsylvania and moderator from Philippines, whom I'll be introducing today. Our moderator for today is the past president of the Philippine Society of Anesthesiologists. Prior to this role, he was also the former vice president, the former board of director, and the former chairman of the Committee on Continuing Medical Education. He was also the chairman of the Board of Examiners from 2014 up to 2016 by the Philippine Board of Anesthesiology. Prior to that, he was also the vice chair of the Board of Trustees, also the former vice chairman of the Board of Examiners, former secretary and member of the Board of Examiners of the same organization. He is also the president and managing partner of the Medical Anesthesia Care Incorporated, consultant and chairman of the Department of Anesthesiology in the Asian Hospital and Medical Center, consultant in the Department of Anesthesiology, St. Luke's Medical Center in Global City, and lastly, attending anesthesiologist from the UPPGH Medical Center. Dear doctors, let us all welcome our moderator for today, Dr. Benjamin Daniel S. Valera.
Thank you very much, Ms. Cha, for the nice introduction. I would like to congratulate the organizers, the officers, Dr. Ed Simon, Dr. Carl Sisu, Alex Odi, and the hardworking members of the working committees for a very nice convention so far. And I would like to thank all of you, the audience, especially for attending, and Baxter Philippines, kudos, especially for inviting me as a moderator for this lunchtime symposium. It is indeed going to be an exciting afternoon. Baxter is going to relaunch Desflurane once again to the Philippine market. The use of Desflurane with its short recovery profile gained a lot of following several years back, as a lot of anesthesiologists found it particularly useful in a lot of situations. In obese patients, patients with difficult airway, outpatient surgeries, and other situations where we want to wake up our patients the soonest possible time. And more importantly, today, we are going to listen to a talk entitled The Future of Anesthesia, Balancing Patient Outcomes and Environmental Sustainability from a very eminent anesthesiologist who stands out as one, a leader, and two, an academician. Having said that, it is my pleasure to introduce a very distinguished speaker. He is a leader and an academician, as I mentioned. He happens to be a leading figure in the field of anesthesiology, especially in the Pennsylvania area in the United States. He has been in practice for the past 20 years and affiliated with multiple hospitals in the area, including the UPMC Harrisburg and the Penn State Health Milton S. Hershey Medical Center. He is a faculty, a professor of the Department of Anesthesiology and Perioperative Medicine of the Penn State University College of Medicine, with research and publications in Desflurane, top block in laparoscopic sleeve gastrectomy, burnout, and resiliency in anesthesiology, among others. As a leader and as an authority, he is presently the board examiner of the American Board of Anesthesiology, and is quite active with the Pennsylvania Society of Anesthesiologists, holding several positions, including at one time the president of the Pennsylvania Society of Anesthesiologists. It is also interesting to note that among his varied interests, he happens to be a martial artist, a holder of a third-degree black belt in Hapkido. So, doctors, it is indeed my honor to present our speaker for today, who will talk on the topic, the future of anesthesia, ladies and gentlemen, may I present to the screen Dr. Professor Joseph Answine.
Hello, my name is Dr. Joseph Answine from the United States. And first of all, I want to thank the Philippine Society of Anesthesiologists, as well as Dr. Benjamin Valera, who is the moderator, for having me this year for the 2021 annual virtual convention. I want to talk about the future of anesthesia and balancing patient outcomes and environmental sustainability, and why desflurane is still the answer for me in my practice. And we're going to cover many aspects of anesthesia care, but we're going to focus it around some patients, as well as enhanced recovery after anesthesia, or enhanced recovery after surgery, or ERAS. So anesthesia goals within ERAS really are four-pronged. We need a faster, more complete recovery with our anesthetics. We need to be able to reduce nausea and vomiting with aggressive prophylactic nausea and vomiting control. And we need pain control in the perioperative period utilizing a multimodal approach, as well as complete recovery of neuromuscular blockade. So to achieve this, to achieve all the goals from the anesthesia standpoint for ERAS, we have to achieve all four of those aspects of the anesthetic care. Some people also include goal-directed fluid therapy as well. So in this cartoon, we're looking at the same thing. So if we want to make sure that our patients are up, walking early and eating and ready for moving through their milestones, and earlier discharge, we have to be able to achieve all those aspects of the anesthetic care, shorter acting anesthetics, prophylactic nausea and vomiting control, multimodal pain management, and reversing our paralytics. If we do that, we'll help our surgeons and our patients achieve the goals of enhanced recovery after surgery. So we're going to talk about a patient using enhanced recovery, and this is a patient with very high comorbidities, aortic valve stenosis and morbid obesity. So this patient, 69-year-old, for a sleeve gastrectomy or bariatric surgery. Now this person eventually needs aortic stenosis repaired using a valve replacement, but the cardiac surgeons felt that his morbid obesity with a BMI of 53 as well as other comorbidities need to be addressed before he can have definitive cardiac surgery. So he was sent to me, as well as the bariatric surgeons, to have sleeve gastrectomy prior to having heart surgery. He did have temporizing valvuloplasty that reduced or increased his valve surface area from 0.6 to 1.1, but he was still very symptomatic. You see his lab values: A1C is 7.3, creatinine of 1.2, good hemoglobin. Vital signs are reasonably stable. His APFAL score for nausea and vomiting was 2, so he was a non-smoker and would need opioids possibly post-operatively. He was calm, so he didn't need any type of anxiolytic in the holding room, but he did talk about the reliance on CPAP with his severe obstructive sleep apnea. Preoperatively, a couple of weeks before, he did start a walking regimen. He did follow very closely with his endocrinologist, cardiologist, and primary care physician to be optimized. The day of surgery, did have a high carbohydrate drink 4 hours prior to surgery, and received a pain cocktail of gabapentin, acetaminophen, and the non-steroidal celecoxib. A scopolamine patch was placed behind his ear for nausea and vomiting control, and again, he didn't receive midazolam because he was calm. When as you see here in this picture, this is a patient with very high comorbidities. So he's at a very high risk for having a major problem from anesthesia and surgery. When he got to the operating room, he had 1.5 milligram per kilograms of propofol based on ideal body weight of 80 kilograms. He received ketamine 0.25 milligrams per kilogram, again based on an ideal body weight of 80 kilograms. He received 100 milligrams of lidocaine as well as rocuronium 100 milligrams. And then he received a magnesium infusion over 30 minutes, all that for pain management. His anesthetic was desflurane, which was titrated at 4 liters till it received an end titer greater than 5%, then titrated to 7%, and then the flows were adjusted down to about 1 to 1.5 liters. We did start dexmedetomidine infusion, and that was stopped at stomach stapling. We many times will start a lidocaine infusion, but this patient received transversus abdominis plane blocks, so we did not start the lidocaine infusion, but in many of our patients we do. Fentanyl, if we would give it, would be 100 micrograms at most in divided doses, but many of our current patients, this is one of our first ones, don't receive any fentanyl now during the intraoperative care. We did give the patient dexamethasone 12 milligrams. Now, if their sugars were out of control, we may reduce that or not give it at all. And he did receive ondansetron 8 milligrams, all this for nausea and vomiting prophylaxis. We use sugammadex on all patients to achieve a qualitative train-of-4 greater than 0.9. or with 4 strong twitches. We extubated him as well as all our patients in the operating room in a sitting position because we want them awake and alert when they get to the recovery room. So multimodal pain management, many medications were given. Gabapentin is a calcium channel deactivator at the dorsal horn. Celecoxib is a cyclooxygenase 2 specific non-steroidal anti-inflammatory drug. Acetaminophen may be a serotonergic drug, but we don't know exactly what it does in the brain. Ketamine is an NMDA receptor blocker, so is magnesium, an NMDA receptor blocker. We know that dexmedetomidine is an alpha-2 agonist that helps potentiate the descending pain modulation pathway. Dexamethasone is a steroid and very significant anti-inflammatory drug. Fentanyl, if we use it, is an opioid. And again, lidocaine, whether you do transversus abdominis plane blocks or lidocaine infusions, blocks sodium channels and reduces the amount of conduction of signals from the pain, from the source of injury to the brain. After postoperatively, we do continue the acetaminophen. Early on, we would start morphine PCAs, but now we don't do that. We actually start PO opioids for breakthrough pain. We continue on ondansetron for nausea and vomiting control, either PO or IV. We give them clear liquids right after discharge from the recovery room in advance on postoperative day 1. We start rehabilitation right as they leave the recovery room. Cardiology is involved, endocrinology is involved, and we maintain tight aggressive glucose control below 150 milligrams per deciliter. Early on, our patients, 70% would be discharged on post-op day 2. Now 70% are discharged on post-op day 1. Even the sicker patients like this gentleman are discharged the morning after surgery now. The use of inhaled anesthetics with enhanced recovery. Why do I feel desflurane is essential? And it's not necessarily because it's blood gas partition coefficient, but what's most important is the solubility in the tissues, in the fat and the muscle. Desflurane is 1/3 as soluble in the fat and the muscle as sevoflurane is. And that's important because all those molecules that collect in the fat and the muscle have to leave the system, have to go back into the bloodstream and then out through the lungs. And many of them will go back to the brain and continue the level of sedation. So that decreased solubility in the fat and the muscle was very important for desflurane. So now let's look at why recovery times vary. Well, we know that individuals vary. Also, our endpoints vary. What are we looking at? Just for them to open eyes, which can happen with a MAC of 0.3 still present, or swallowing water, which takes a reduction down to a MAC of 0.1 or less. So it depends on what our endpoints are. And we know that different anesthetics are removed more quickly from the system based on their kinetics when it comes to solubility in the fat and the muscle, etc. So when we look at this study by Eager, which was using a computer model, we find that whenever we want to achieve MAC awake or 0.3 MAC, even after long exposure times, it really doesn't matter what inhaled agent you use, whether you use desflurane, sevoflurane, or isoflurane. So if all you want them to do is to open their eyes, then you can use any anesthetic. But if we want to get down to a MAC of less than 0.1, where they actually will be able to protect their airway, we find that desflurane still allows for that to occur very quickly after very long exposure times. But when you look at sevoflurane and isoflurane, that's not true. So all the anesthetics can reach MAC awake very quickly, or 0.3 MAC. But if you want to get down to where they can really protect their airway at 0.1 MAC or less, you really want to use desflurane because it will allow them to achieve that goal quicker, even after long anesthetic exposure times. And we see this is now a clinical study where patients were discontinued or their anesthetics were discontinued, and after 2 minutes they tried to see if patients can swallow water without choking. And we find that 100% of the patients after 2 minutes were able to do it when they received desflurane, but it took up to 20 minutes for 100% of the sevoflurane patients to be able to do that. So that solubility in the fat and the muscle of sevoflurane, which is greater than desflurane, is significant when it comes to being able to swallow and protect your airway after anesthesia exposure. We see here that patients were able to normalize their PaCO2s much quicker after receiving desflurane than with sevoflurane. Also, that the pH is normalized much quicker with desflurane as well as sevoflurane, and these are morbidly obese patients in this study. Now, this study is interesting. This is, remember back what I told you about the fact that you need to make sure all of your anesthetic aspects of your anesthetic are taken care of to achieve good patient outcomes. In this study from McKay in 2016, they demonstrated that desflurane patients were able to swallow water quicker with sevoflurane, but even if the desflurane patients did not receive reversal of their neuromuscular blockade, some of those patients did have choking problems. So what that means is even if you use shorter acting anesthetics, you have to make sure the other aspects of the anesthetic care are taken care of, which is reversal of neuromuscular blockade, especially with Sugammadex, which I will demonstrate later, multimodal pain management using reduced opioids, and aggressive nausea and vomiting control. All those things must be done in unison to achieve good patient outcomes. So let's talk about Sugammadex. So we know that neostigmine, which is an acetylcholinesterase inhibitor, has its problems. You cannot reverse a block unless you have 2 twitches. When you use neostigmine or other acetylcholinesterase inhibitors. That's not true with Sugammadex. You can reverse very deep blocks with it. Expert opinion says that acetylcholinesterase inhibitors will take up to 10 to 15 minutes for peak effect when you use intermediate acting agents. With Sugammadex, it usually takes about 1.4 minutes to achieve a complete reversal if you use the appropriate dose for level of neuromuscular blockade. Incomplete reversal is not uncommon after the administration of acetylcholinesterase inhibitors, and we know that when used neostigmine, still about 40% of the patients have a train-to-4 ratio less than 0.9 in the recovery room after extubation. There's also a ceiling effect when you use the acetylcholinesterase inhibitors, where if you give more, you have no greater effect. Neostigmine can cause weakness if you give it, especially at later stages of recovery. So Sugammadex, which basically binds the steroidal neuromuscular blockers, is much more effective, much more complete, and more likely to keep patients from having residual neuromuscular blockade in the recovery room. Does this make a difference? Well, we know that when you take healthy volunteers in these studies that we're looking at here and achieve train-to-4 ratios of maybe 0 or 0.6 up to 0.8, many of those patients still passively aspirate, and these are awake, healthy subjects, and they've demonstrated using upper esophageal sphincter tone, etc., that patients still passively aspirate if the train-to-4 ratio is 0.8 or less. When you look at anesthetized patients from Spain in 2016, we found that residual neuromuscular blockade in recovery room occurred in 26.7% in this study, but many studies have demonstrated that it's up to 40%. And if you use acetylcholinesterase inhibitors, it doesn't necessarily reduce that number. When you use acetylcholinesterase inhibitors such as neostigmine, still many of the patients are still partially paralyzed in the recovery room. And we found that from the study in 2013 that if you do have residual neuromuscular blockade, you're more likely to have critical respiratory events such as airway obstruction and respiratory failure. So it's important to have your train-to-4 ratio greater than 0.9, and that's why we use Sugammadex. We see here that whenever you give Sugammadex, within 2 minutes, 100% of your patients have a train to flow ratio greater than 0.9. But even at 60 minutes when receiving neostigmine, greater than 20% of the patients still have residual neuromuscular blockade. And still about 10% after 80 minutes still have residual neuromuscular blockade with neostigmine. Remember, almost 100% of patients receive complete reversal neuromuscular blockade with a train to flow ratio of greater than 0.9 with Sugammadex after only a couple of minutes. So now let's talk about the environment. Back in 2020 in October, Dr. Meyer wrote a study called Desflurane Should Disappear, global and financial rationale for not using it, basically. He said we need to stop using desflurane as a routine option for general anesthesia. There's no good reason to use desflurane in most patients. There are a few great reasons to avoid desflurane altogether. Foremost, desflurane is a potent greenhouse gas, and this contributes to the climate change. Second, desflurane is more expensive than other anesthetics. I, as somebody that used desflurane routinely, wrote an editorial in the same journal. And I wrote this in 2021 March to basically refute the claims by Dr. Meyer. And I did describe, first of all those studies I described to you where desflurane provided safer anesthesia, more complete recovery of airway reflexes compared to sevoflurane. And patients were able to swallow water quicker, less likely to choke, able to achieve max less than 0.1 much quicker and much more consistently. Patients were able to get their PaCO2s normalized much more quickly, even if they were morbidly obese with desflurane, as well as their pHs, their PCO2s, again, were normalized much more quickly in the recovery room, as I said, with desflurane compared to sevoflurane. So what I said is that you could not marginalize or claim that the benefits of sevoflurane were insignificant for our patients when talking about its use, which Dr. Meyer did claim that there was no benefit of it. And we know based on study after study that there are extreme benefit of using desflurane in our patients, especially those that have high comorbidities, such as morbid obesity, etc. And we talked about the environment. And things that I pointed out was that anesthetics account for about 0.09% of greenhouse gas emissions. So that's very, very small. It's not negligible, but it is very small when we take all greenhouse gases, methane, et cetera, when we look at all of those in the context of our daily lives. So again, we can't just look at anesthetics for causing greenhouse gas emissions. Also, reducing fresh gas flow on induction and emergence, as well as utilizing a closed circuit and near closed circuit anesthetic when using desflurane, reduces the amount of contamination dramatically. Also, if you use gas eliminating devices, which are out there, you can actually capture or destroy the inhaled agents such as desflurane and sevoflurane, so they're all available. Again, even though desflurane is always singled out, sevoflurane has a negative environmental impact. So do the IV drugs. We talk about the amount of propofol that is spilled in our environment. It gets into the ground, it gets into the water, it affects our wildlife and our marine life. We put a lot of propofol into the environment. Also, we can't forget about all the plastic tubing, the needles, the syringes that are utilized for IV anesthetics, and those have to basically be degraded or put into the environment. So we can't just talk about desflurane when we talk about the effects on the environment. We have to talk about sevoflurane. We have to talk about the IV drugs and propofol. And there are ways to reduce the amount of desflurane that is left into the environment by using near closed circuit anesthetics, decreasing our flows on induction and emergence, and using gas capturing devices. This is the contrafluorine anesthetic gas capturing device. So there's one of the many devices out there that will actually capture desflurane and sevoflurane and reduce the amount of exposure to the environment and therefore reduce the amount of greenhouse gas effect. Also, we need to talk about cost because he said that desflurane is more expensive. Well, first of all, total operating room cost is very expensive. In this one study, above $36 per minute, and some people say it's much higher. Anesthetic costs relatively are about $1.80 per minute. So anesthetic cost is a very, very, very small part of the total operating room cost, but it's not negligible. Also, we need to understand that when you use desflurane in the way that I described earlier, whenever and this was demonstrated in this study as well from 2016, if you use low flows and reduce the amount of desflurane on induction emergence and even use gas capturing devices, the difference between the cost of desflurane and sevoflurane is relatively negligible. Also, in the study from 2001, Wenger demonstrated in a single hospital in Canada that $1,802 were wasted over a period of 2 weeks, or $10.86 per case, when it came to IV drugs and all the components necessary. And this was even felt to be underestimated by 40% since all the syringes weren't accounted for. So we need to, when we talk about costs, we need to understand that if you use desflurane appropriately, like in my hands, the cost of using desflurane is relatively small, and it's no different than sevoflurane. And we can't belittle the cost of our IV drugs, such as propofol, etc., as well as all the tubing and the syringes and the needles that are required as well. So the cost of anesthetic is small, and we can reduce it that much more dramatically no matter what anesthetic we use, even if we use desflurane. So let's go for a summary of anesthesia environment. Desflurane does provide a quicker wake up and an earlier return of swallowing reflexes in healthy and sick patients. Inhaled agents do create a negative effect on the environment, and desflurane is commonly singled out, but it's not the only anesthetic that would do that. However, with techniques such as low flow anesthesia, reducing desflurane induction emergence, using gas capturing devices, you will actually decrease dramatically the impact of desflurane and make it relatively negligible. And remember that the quicker wake-ups with desflurane and ways to utilize minimal anesthetic gases reduce the desflurane exposure and reduce the cost of anesthetic time. So again, I'll stress that if you have a patient wake up 5 minutes quicker with desflurane, that's 5 minutes of operating room time that you basically have saved. And the cost of that, as we said in the previous slide, was very high. So desflurane can actually create a much more cost-effective situation with our anesthetic care. Again, we can't forget the negative impact on the environment, as well as the large cost of our intravenous drugs such as propofol. We can't forget that we waste a lot of propofol into the ground and into the water, and propofol isn't degraded that easily, and that does affect our wildlife on the ground as well as in the water. So desflurane should be part of a comprehensive anesthetic plan when you're trying to put together an enhanced recovery after surgery program. It's an important part of it, and it can be used safely and effectively, and it can benefit our patients from a safety standpoint. So let's talk about some other cases. So first I'd like to say, what is this? What are you looking at? It seems like to be a very large object. Well, to be honest with you, this turns out to be a left knee. It's a morbidly obese patient having a left total knee arthroplasty. 60-year-old, BMI of 48, severe obstructive sleep apnea. We used desflurane because we wanted a quick wake up in her. She had obstructive sleep apnea. We wanted an anesthetic that went away quickly, that allowed to have her to have a return of cognitive function very quickly. So we used desflurane. We ran it about 8% throughout the case, and I continued it right when the incision was closed. 3 minutes later, the patient was responding and the LMA was removed. Even somebody with a BMI of 48, that large and severe obstructive sleep apnea, she was awake and talking in the recovery room, and she was able to go, or in the operating room, and she was able to go to the recovery room without any airway problems. Here's another patient, a 65-year-old lady with high blood pressure and a BMI of 32, nowhere near as heavy, but an elderly patient. This was an earlier case that I had done before we started enhanced recovery program, so we used a lot more opioid here, but this does describe the effectiveness of desflurane in these patient populations. Had a left femoral nerve block performed preoperatively after IV midazolam and fentanyl. Propofol 2 milligrams per kilogram was given and LMA was placed, and the desflurane was titrated slowly from 6 to 8 to 10% over 5 minutes. Because if you do titrate it very quickly with an LMA, they could cough with any anesthetic. So you want to titrate it slowly to build an end-tidal CO2 over a few minutes. And then when you get it to where you want, you reduce the flows and they will breathe spontaneously. Or you can put them on the ventilator with low peak pressures. We gave, in this patient, we did give morphine throughout the case. Again, this was before we started our enhanced recovery program. The tourniquet time was 74 minutes. As you see here, it was a pretty stable anesthetic. We titrated the desflurane up and down. Here, where you look at that screen, that was towards the end of the case whenever we were actually removing the desflurane. And you could see that, our end tidal was actually reduced. So you see a blood pressure of 115/73. We see a heart rate of 66, and end tidal's perfectly fine, and she's breathing spontaneously. You know, I take this back. Please apologize to you. This was at the beginning of the case when we were titrating the desflurane up. So we had 6% on the vaporizer with a few liters flow. So I was titrating the desflurane up, and the inspired was about 6%. The expired was still only 3-4%. So this was, I apologize, the beginning of the case. And we see stable hemodynamics, no coughing, etc. Now, at the end of the case, we would do just a reverse. We would turn the desflurane off right at the end, increase the flows, and we would see a dramatic reduction in inspired desflurane, and then a slower but pretty quick reduction in end tidal desflurane. And again, patients tolerate this very, very well. So 4 minutes after stopping the desflurane, increase in the flows, the patient was awake, responding appropriately. You see the clock times in there, which is a 4-minute difference from the time that I stopped the desflurane to the time the LMA was removed. The patient did incredibly well with this, and there were no problems whatsoever. And again, it's important to demonstrate when you have patients with high comorbidities that using desflurane is very beneficial because it allows them to protect their airways quicker. We know that morbidly obese patients and elderly patients, if they're obtunded in the recovery room, are more likely to have respiratory events. So if they're wide awake in the recovery room, they do dramatically better. And so I feel that desflurane is an important part of our anesthetic care, especially in enhanced recovery programs. So remember the 4 components of the anesthetic part of an enhanced recovery program is short-acting anesthetics such as desflurane, multimodal pain management with opioid reduction, aggressive prophylactic nausea and vomiting control, as well as complete reversal neuromuscular blockade, especially with the utilization of Sugammadex. If we can achieve those 4 parts of our anesthetic care, we will help our surgeons and our patients in their enhanced recovery program so they can have early discharge from the hospital, more patient satisfaction, no complications, and less likely to be readmitted to the hospital. I want to thank you for allowing me to be part of the 2021 Philippine Society of Anesthesiologists annual virtual convention. I want to thank the moderator. I want to thank Baxter for inviting me, and I feel very privileged to be a part of this. Again, great thanks from the United States, from Pennsylvania, which is in the northeast aspect of it. You have a wonderful day, and thank you.
Thank you very much, Professor Anspin. It was indeed an enlightening, scholarly lecture on the use of desflurane, and you talk about a lot of things, You talked on ERAS, you talked on morbid obesity, aortic stenosis, the use of multimodal anesthesia. Recovery is faster with your desflurane, and you also talked on Sugamadex vis-a-vis neostigmine as a reversal agent. So it was commonly thought, Dr. Aswin, that one of the more important concerns on desflurane is actually is it really that expensive? The Australians and the New Zealanders in their paper claim that it's much more expensive uh, anesthetic. Can you comment? Uh, I think you are muted, Dr.
I
Ashwin.
think I am muted. Am I back now?
Yes,
Can you hear
yes,
me?
you are. Yes.
Okay, I apologize. So we studied it in our institutions a couple of years back, and we realized when we first started to use desflurane that it was posing a problem when it came to the cost of the inhaled anesthetics. But what we had realized is that we were using the same flows for desflurane that we were using for sevoflurane, which is anywhere from 2 to 3%. In fact, we commonly use 3% fresh gas flows with sevoflurane. Whether you believe the concern of compound A or things like that, we just got into the habit of doing that. But when we started reducing the flows down to a half a liter to one liter with desflurane, as well as keeping our flows down and trying to minimize the amount of exposure on induction as well as emergence, that the cost was relatively the same. And we also did do a study looking at the cost of our IV drugs and the amount of propofol that we were wasting, the amount of syringes utilized for total intravenous anesthetics. And we realized that the relative cost was minimal. So you really have to make an effort. You have to change your practice if you're used to using high fresh gas flows, or if you're used to using total intravenous anesthetics and the number of medications and what you waste post-operatively with those medications. You really have to rethink your process. So when I use desflurane, I start off, I induce my patients. If I'm using an LMA right after induction, I will put the LMA in, and then I will start my fresh gas flow still at about 2 or 3 liters, maybe 4. And then as I titrate up my end-tidal desflurane to about 4% or 5%, then I reduce my fresh gas flow pretty quickly. And I keep my fresh gas flow relatively low throughout the duration of the case, whether I use an LMA or an endotracheal tube. And then at the end of the case, I turn off the desflurane before I increase my fresh gas flow. And at the time, we know they're going to wake up pretty quickly as soon as the desflurane comes off because of the low solubilities in the fat in the blood, so or in the muscle. So it really takes a little bit of practice, but by doing that, we have seen a relatively negligible difference in the utilization and cost of our different anesthetics. To the point that we moved on to something else now. The next concern with our pharmacy was our utilization of Sugamadex, and because we've gotten past desflurane now, and now they're trying to limit the amount of Sugamadex we use, but we've also proven that that's better for our patients, and therefore that agent needs to be used relatively routinely as well.
Thank you very much, Professor. Another question is, How about the manufacturing process in the making of desflurane? Is it as environmentally friendly compared to the manufacturing process of propofol?
That's a good point. I do not know the answer to that. I do not know if there is a difference in the manufacturing process causing the release of toxic chemicals as opposed to that which is done with propofol. But I do want to stress again that we are going to get into a situation. It's felt that we will be getting into a situation in our world where the amount of propofol that is in the actual ground and in the water is going to create a potential problem for not only land wildlife, but marine wildlife. There is a concern about that because it turns out that propofol is not readily degraded whenever it's left into the environment. So I'm not sure about the manufacturing process when it comes to those two agents, but the disposal process may become a bigger deal for propofol than with the inhaled agents, because right now we really don't have a degradation process for our IV drugs. So that is something we need to worry about, then we will worry about in the future, I'm sure.
Professor, how about the issue on carbon monoxide production with the interaction of your absorbents and your anesthetics? Does desflurane offer a advantage over the rest of the other? Yes.
Theoretically, desflurane does compared to sevoflurane. That is why that you can use lower flows with desflurane down to, in Europe, half-liter flows. And, in the United States, we consider low flow anything less than a liter. In Europe, they consider low flow anything less than a half a liter. We are not exactly sure about carbon monoxide production and concerns with that when it comes to sevoflurane at those low flows. So it's really not recommended to use sevoflurane at such low flows. But it appears that with desflurane, that does not currently pose a problem at half-liter flows and 1 liter flows. I haven't seen any data to dispute that, at least currently.
Okay, Professor, there's another question.
How do we lessen environmental pollution if we don't have a closed system? We really, closed circuit anesthesia is very difficult. When I trained back in the 1990s, we did a lot of closed circuit anesthetics, and there's no doubt that it's a very, very difficult process. But what you can achieve is near closed circuit anesthetics, meaning that you don't necessarily have to turn your fresh gas flow down to basal metabolic rate for oxygen, but you still can turn it down to maybe 100 milliliters or so within basal metabolic rate for oxygen. So if you assume that basal metabolic rate for oxygen is say 30 or what am I thinking, 60 or 70 cc's per kilo, or 3 to 4 cc's per kilo per minute, then if you run about 5 or 6 cc's per kilo, you've got a near closed circuit anesthetic, and you're still diminishing dramatically the fresh gas flow waste. And now we don't have them readily available yet, but whenever we do have readily available these gas capturing devices that'll either collect or destroy these molecules, then you reduced it even in that much further down. So yes, I understand doing a closed circuit anesthetic routinely is not something that is is user friendly, but to go near closed circuit is pretty easy, and I do it routinely.
Do you think, Professor, that the use of brain monitors can help lessen the use of, can help in the use of desflurane in anesthesia?
Oh, I think it
Yeah,
can.
yeah, the Connox and everything. Yeah.
Yeah,
Brain
I think it can. To be honest with you, I'll tell you a little bit of history. I was not a big fan of BIS monitors when they first came out. But I'm starting to actually use them more and more from the other end, because one of the biggest concern, we have a very elderly population in the United States, especially Pennsylvania of the 50 United States has the second oldest population in the country. And we are all trying to figure out what is the best for cognitive protection of the elderly population. And we're not really sure, but one of the concerns is that some of our anesthetic depths are too deep. So we're using more and more BIS monitors now, trying to regulate the level of that number, more to keep them from being too deeply anesthetized rather than too lightly anesthetized. But what we're finding out when you use these monitors is that many times we do use too much anesthesia. And I think that by using bispectral index devices, BIS monitors, et cetera, that we are proving that more may be better for most of our patient population. And we are finding that we are using much more anesthesia, whether it's intravenous, inhalational, and so on, than we absolutely need for the majority of patients. So I agree that using those type of devices will probably help reduce the amount of anesthetic exposure, not only to the environment, but to the patients lying in front of us, because they're most important.
Thank you. Any more questions from the screen or floor? Okay, there's a question. Can you describe to us how do you induce patients using desflurane, whether for general endotracheal or the use of a supraglottic device, just like an LMA?
Yeah, so
how would you
it's
induce your patients using desfluranes?
So it's slightly different for both, but I'll explain it. So what I do is 99% of our patients get intravenous induction agents, whether it's propofol at 0.5 milligram per kilogram or ketamine or etomidate. I use mostly propofol. After the patients are asleep, many times we assess an ability to do a mask airway. And then, so what I'll do at that point is I get them deep enough with the IV drugs so that I either can put in the endotracheal tube or even the laryngeal mask airway without necessarily breathing them down with an inhalational agent using a mask. I sometimes you have to, but I believe that if you want to decrease the amount of gas exposure in an operating room, you do that by decreasing the amount of inhaled agent that you administer through masked ventilation. Sometimes you have to, but many times you don't. So then I secure the airway. And if it's an LMA, it's very, very important to titrate your desflurane relatively slowly, meaning you start at about 1 or 2% at 2 or 3 liters. And you want to watch that end tidal CO2 build or end tidal desflurane build up. So you go to about 2%, 3%, and you want that end tidal to build up to about that level. Then you gradually increase it. The reason you want to do the gradual increase with an LMA is because if you overpressurize with desflurane, especially with an LMA, there is a chance they'll cough. I mean, if you overpressurize with any agent, they could cough, but they're more likely to cough with desflurane if you try to overpressurize and go straight to 6%, 7%. So what I do is I titrate it slowly, start it at 2% inspired until I get an expired level close to that, then 3%, then 4%. And then basically once I get to 5 to 6% or 1 MAC, then I can titrate it to whatever I want. And then I make sure I reduce my flows down to about a 0.5 to 1 liter. When you're using an endotracheal tube, I mean, obviously you can overpressurize it much quicker and go to 6, 7%, but what you're going to get there is probably some sort of a hemodynamic effect, because you do have a little bit of sympathetic effect with isoflurane, especially with desflurane, that if you overpressurize very quickly with an endotracheal tube, they will get tachycardic and a little bit hypertensive. So even with an LMA, I will titrate it, or an endotracheal tube, I'll titrate it slowly. So what I may do with an endotracheal tube, I may do 1 of 2 things. I may drop the flows immediately to 0.5 to 1 liter and then turn it to 6, 7% and let the machine slowly build up the level. Or I may put the endotracheal tube in, turn the flows up to 5% or so, go to about 4%, 5%, and let it titrate up to get the end tidal to about that level. And then I'll titrate it up slowly to about whatever I need from a hemodynamic standpoint. 6%, 7% end tidal desflurane, and then turn the flows down. But again, I stress, if you're using an LMA, you want to titrate it very slowly to build that end tidal up, and then you can back your flows down when you get to the level you want. With an endotracheal tube, you can either start very low and put higher percent gas flows, 6%, whatever, or you can just titrate up the same way with an LMA. Either way, it's a slow titration, because with an LMA, you'll avoid coughing. With an endotracheal tube, you'll avoid any type of sympathetic response from the desflurane.
Professor, are there any issues on chronic toxicity for desflurane? Maybe a patient who is repeatedly anesthetized, is it really that bad? Maybe.
Have not seen any studies, or have had no. So my personal experience with desflurane is obviously thousands of cases. It is my preferred inhaled anesthetic because I do believe that they wake up clearer. They're more likely to protect their airway. I have not seen any type of data, and I haven't seen anything specific with desflurane after multiple exposure times. I haven't necessarily seen any type of data on any of the inhaled agents, except for there were some studies in the past looking at neonates after multiple exposures of anesthetics. But that wasn't necessarily desflurane. That was just anesthesia in general. But no, nothing that I have seen from multiple exposures of desflurane, because it is a relatively inert molecule. If you think about it, it's a much more inert molecule than sevoflurane with less metabolism. I think the metabolism rate of desflurane is about 0.2%, and the metabolism rate of sevoflurane may be in the order of 5% or more. So it's a pretty inert molecule, thankfully, and there doesn't appear to be any type of negative long-term effects like we've seen with nitrous oxide exposures over time. So far, nothing that I know of.
You know, in anesthesia, there is no such thing as black and white. Even the choices of your agents, you can differ without any discernible differences in outcome. Can you think of a situation wherein desflurane will be the best anesthetic to use for a particular patient?
Well, my area of expertise has been very, very high-risk bariatric patients or obese patients. That has been something that I've been dealing with now for the last 5 years. And the reason that I've bought into, and the reason that I've become a huge desflurane fan, is what we found in that patient population is that if they are left obtunded in the recovery room or in the operating room and on their way to the recovery room, the likelihood that they're going to have an early post-operative respiratory complication is very high. And when I started using this regimen, using desflurane as my primary anesthetic, and using multimodal pain management with minimal opioid and regional blocks and Sugamidex. Almost 100% of my patients now are sitting up, awake, and talking in the recovery room. And that, I think that what I'm trying to get at is if you do everything the way you're supposed to. Now, can I contribute it all to just desflurane? No, because as I said, I can do a great inhaled anesthetic, and if my neuromuscular blocker isn't completely off, or I've given too much opioid, or my patient is throwing up, then I'm still going to have some major problems. But if I do all of those aspects, if I do buy into the fact that my airway is much more protected with desflurane very quickly, and I do buy into the fact that Sugamidex is going to reverse my neuromuscular blockade more quickly, and I do buy into the fact that not using a large amount of opioid is going to allow them to be less obtunded and able to breathe postoperatively. And if I do buy into the fact that they're not going to be throwing up, so they're going to do much better, I am going to have a more awake patient. So yes, I do believe in the sicker the patients are, the more likely that any type of postoperative anesthesia compromise could create great morbidity in these patients. These are the patient populations that are going to benefit from an agent like desflurane and benefit from complete reversal neuromuscular blockade and benefit from low opioids and regional blocks, et cetera. So yeah, the sicker patients are the ones that will really benefit from these type of practices.
Okay, thank you, Professor. Very enlightening indeed. Any more questions? So actually, Professor is an advocate for the use of desflurane. He uses a lot of desflurane in his practice, actually, the way I understood it. And desflurane has a role in the ERAS protocol, early recovery after surgery. Especially, there's a role for morbid obesity patients. And he actually debunked a lot of misconceptions that it is not really that expensive. The greenhouse, it's not really as bad as they claim to be, the greenhouse effect, because it desperately contributes a small contribution to the greenhouse gas. And any more? With that, I would thank you very much, Professor. It was a very good lecture. Yeah, maybe we can invite you to a face-to-face sessions, maybe next year, if you will allow us. We would like
I would
to
love
have,
to.
the speakers from Baxter, like you, Professor Einstein, and Professor Goshi. They're very good. So
Yeah, I'm tired of doing. I'm tired of giving all my speeches
Yeah.
from my basement of my house.
So thank you very much. I will give you a round of applause.
Thank you.
Thank you very much for gracing our convention. Okay. So before we end the session, do we have a video presentation from Baxter, as they would like to relaunch the use of desflurane again in the Philippine market?
When making a decision about inhaled anesthesia, you may want to ask a simple question. Why Baxter? You aren't just picking an aluminum bottle and a chemical compound. You're choosing a manufacturer, a distributor, and a partner. You're choosing everything around the bottle. And Baxter has a long-term, consistent commitment to anesthesiology. Did you know that Baxter invented all 3 modern inhaled anesthetics? Or that Baxter's award-winning manufacturing plant supports over 65 markets? With automated distribution controls and a robust supply chain system that's committed to environmentally sustainable best practices, supported by a quality assurance program that tests and qualifies vaporizers for reliable performance with Baxter IA products. Did you also know that over 350 million patients have been treated with Baxter's inhaled anesthetic agents? And that Baxter has educated thousands of clinical partners all over the world. So what does this tell us? That Baxter is the reliable partner, the consistent and valued partner, the inventor and manufacturer of all three modern inhaled anesthetics. So, why Baxter? Because you're not just choosing an aluminum bottle, you're choosing a trusted partner. Baxter.
and had views that were not consistent with university just in the last year and a half. And they had positions at the time. While they have freedom of speech, they were censured by our faculty staff, and so that's and there are others who
Si Dr. Delphine po will not be able to ano, no? Nandiyan na rin po, no? Oo.
social media policy, ethics for social media, especially in our design that is a condition. Yeah, litigation is something totally separate. I think and I particularly live in a litigious society, and so I think I would have to just stand behind, say, justice. And when I'm designing a lecture or writing an article, I want to make sure that I have to check my sources. I make sure before I post anything that might be taken as advice, that I have sources to back up.
Yung mamaya po, kailangan lang namin ibaba yung house. So parang ganyan lang yung
afternoon.
Good afternoon, everybody, and welcome to this year's PSA Research Contest. I'd like to thank all the participants who are attending now and to support their different hospitals. To start the program, let's have the Philippine National Anthem.
Mga kababayan, ang pambansang awit ng Pilipinas. Kayang magiliw, helas ng sinangalan, alam ng puso, sa titik mo'y buhay. Lupang hinirang, tuyang ka ng magiting, sa mandulupin, di ka pasisiw, sa nagagang puto sa simoy at sa langit mong pagkaw, ay ginagang tulad, awit sa paglayang minamahal, ang islang ng matawad mo'y nagumpay na naghihiling, ang bituin at araw niya kailan pang ay di maghihiling, lumad ang araw ng walhagit pagsikta, buhay langit sa piling mo, ang hindi kaya ng pagkay mga aking, ang mamatay ng dahil sa'yo.
Okay, thank you very much. Once again, thank you very much, everybody, for attending this afternoon's affair. I am Dr. Michael Madarang. I shall be your MC for this afternoon. To start off, may I call for to give an opening remarks. May call on the chair of the research subcommittee, chair of the subcommittee on research contest of the PSA. She took her medicine in UST Faculty of Medicine Surgery, residency training in Chonghua Hospital, where she was the chief resident. She served under the Cebu Central Visayas chapter as treasurer, secretary, vice president, and she became the president. And in Chonghua Hospital, she was the secretary from 2016 to 2018, and she's the chairwoman from 2019 up to the present. She was the PSA Regional Director of Visayas from 2019 to 2020, and she is now a PSA Board of Director from 2020 to the present. And May now call on Dr. Jennifer Frances Rosello to give us the opening remarks. May hapon po, Dr.
Thank you, Dr. Michael Madarang. Good afternoon, consultants and residents. Research is an arena of learning where inquisitiveness and a thirst for knowledge propels one to seek further truths. As men and women of science, there is an insatiable need to analyze, delve into the burgeoning theories that pique our interests, and even challenge widely practiced long-held beliefs. Because of this, the PSA Research Committee annually encourages the youngest of our lot to come up with quality investigative work relevant to the present needs of our specialty. This year is no different, with 5 exceptional papers making the cut. To all the entries, congratulations. Know that you are all considered winners to have even reached this point. We are very proud of you. Through this, we hope more in our community will begin actively pursuing different avenues for research, thus making our society a rich repository of contributors to the further improvement in anesthesia care. Let us listen to the entries and learn together from this worthy exercise. Good luck and God bless us all.
Thank you very much, Dr. Rosello. That's very inspirational, and hope the contestants will learn more. Now, to give us the around of the rules and regulations and the mechanics of the contest proper, as well as to introduce the Board of Judges, may call on, well, she graduated Doctor of Medicine from UST Faculty of Medicine Surgery. She took up residency at the Philippine General Hospital. She finished her MBA, Hospital Management at Telsa University. She held several positions in the past. She was the past president of the PSA Southern Tagalog chapter. She was the chairman of the Perpetual Health Medical Center of Las Piñas. At present, she is the chair of the Department of Anesthesia of St. Dominic Medical Center in Bacoor, Cavite. She is the assistant chair of the Department of Anesthesia in San Juan de Dios Hospital in Manila. And she is a board member of Medical Center Parañaque. And at present, she is the PSA Regional Director for Luzon. So once again, for a rundown of mechanics and as well as to introduce our Board of Judges, may I call on Dr. Carmelita Sandique Lunas.
Thank you, Dr. Madarang. For the mechanics of this oral research presentation, they are the following. Number 1, the finalists of this virtual oral presentation were prejudged on the merits of the research paper based on content and methodology. This made up 80% of the total score, while the remaining 20% will account for the outcome of this oral presentation. Second, the sequence of presentation determined by the committee will be in the order as indicated on the invitation. Third, each finalist will have 8 minutes to deliver their presentation with 6 minutes for question and answer. Fourth, each judge is allowed 2 minutes to ask questions per contestant. A warning signal will be given at the 6th minute. Fifth, points will be deducted for every minute or fraction of a minute over time or as penalty for non-compliance to rules. And 6, the decision of the Board of Judges is final. And for our prizes, the winner of the first prize will get 25,000 pesos, while the second prize winner will get 20,000 pesos, and the third prize winner will get 15,000 pesos. There will also be consolation prize of 5,000 for the non-winners. We have 3 judges for this contest, and they are Dr. Jose G. Beltran Jr. He is the founding president of Metropolitan Davao Medical Society Incorporated, president of Davao Cancer Society Incorporated, president, Philippine Society of Anesthesiologists, Southern Mindanao Chapter, a member of the Board of Directors of SOAP Incorporated, and a member of the Board of Trustees, Pain Society of the Philippines. For our second judge, we have Dr. Serafin L. Bernardo V. He is a member of the faculty and Associate Professor 3, UP College of Medicine. He is a member of the Philippine Board of Accreditation of Anesthesiology from 2018 up to present. Likewise, Chairman, Department of Anesthesiology, St. Luke's Medical Center, Global City, from 2018 up to the present. He is also Chief, Section of Cardiothoracic Vascular and Organ Transplant Anesthesia of UPPGH since 2008 up to the present, and former Head, Section of Thoracic and Cardiovascular Anesthesia, Asian Hospital and Medical Center from 2006 up to 2018. And lastly, we have Dr. Emmanuel S. Prudente. He is the chairman of the Board of Judges. He is an associate editor of the Philippine Journal of Anesthesiology. He is a member of the Board of Accreditation of the Philippine Board of Anesthesiology, President, PSA Negros Occidental Chapter. He is a medical specialist for Department of Anesthesiology at Corazon Locsin Montelibano Memorial Regional Hospital. Likewise, Chair of the Regional Hospital Research Ethics Review Committee at the same institution, Corazon Locsin Montelibano Memorial Hospital. Doctors, thank you for accepting the invitation to be the judges in this contest. And good luck to all the contestants. Thank you. Back to you, Dr. Madarang.
Thank you very much, Dr. Alunas. Well, I guess we should go right to the meat of the matter, so to speak. So, as Dr. Rosello and Dr. Alunas has mentioned, we have 5 physicists to present to us today. And without further ado, and for the benefit of our almost 200 participants this afternoon, may I call on to present to us a prospective study on perioperative patient satisfaction of patients undergoing elective surgery from March to June of 2021 using the ASA patient satisfaction questionnaire. Sorry. May I call on Dr. Roland Cajoles. Dr. Cajoles, take the floor, please.
I will just share my slide po, doctors. Patient satisfaction is and has always been an important subject for healthcare managers and has been widely used metric for measuring the quality of healthcare. Good afternoon, I'm Dr. Roland Cajoles, and I'll be presenting my research entitled A Prospective Study on Perioperative Patient Satisfaction of Patients Undergoing Elective Surgery from March to June 2021 using American Society of Anesthesiology's Patient Satisfaction Questionnaire. The general objective of this study is to determine the level of patient satisfaction undergoing elective surgery in a tertiary hospital from March to June 2021, with a specific objective of determining the factors that affect patient satisfaction in the perioperative period of elective surgical patients as follows. Analytical cross-sectional study design was utilized that would identify the different factors affecting the levels of patient satisfaction. A written informed consent was taken from the respondents. Survey questions from the questionnaire formulated by the American Society of Anesthesiologists and its Committee on Performance and Outcome Measurements was used for the survey. The questionnaire adapted was translated into Filipino by an expert in the Filipino language from the Centro ng Wikang Pilipino, University of the Philippines, Manila. Upon professional statistical advice, pilot testing was not done as adapted questionnaire was already validated. And this is the actual survey form used. The minimum sample size required to determine the proportion of patients satisfied with anesthesia care was computed using the equation below. The minimum sample size requirement for the study was estimated to be 285 patients. The study employed a convenient sampling design to select study participants. All patients who satisfied the inclusion and exclusion criteria were invited to participate in the study. And these are the inclusion criteria and the exclusion criteria. Data were encoded in Microsoft Excel, and Stata NP version 16 software was used for the data processing and analysis. Independent t-test was used to compare continuous variables, while chi-square test was used to compare categorical variables. In order to determine the factors associated with satisfaction, multiple logistic regression analysis was performed with backward elimination technique. P-values of less than or equal to 0.05 were considered to be statistically significant. And this is my study flowchart. A total of 392 patients underwent elective procedures under anesthesia during the study period. Among these, a total of 294 patients were included in this study. Breakdown of age group is shown in this diagram, and majority of the sample population were noted to be of 25 to 34 years of age. 20% were college graduates, 7% were able to finish vocational studies, 51% were only able to finish high school, and 22% were high school undergraduates, elementary graduates, or undergraduates. 45.5% were operated upon regional anesthesia, and 36% were operated under general anesthesia. The rest were anesthetized with different needs. 95% of the participants perceived their health condition as very well. These are preoperative satisfaction ratings to specific satisfaction questions compared to one another, showing that patients were satisfied with the anesthesiologist's care prior to operation and after the operation. This table presents a demographic and clinical profile of patients. Since the data collected was not normally distributed, median was used. Median age was 39 years old. Most were from the 25 to 34-year-old group, and majority of the participants were females. About half of the patients attained a high school level of education. Spinal anesthesia and general anesthesia were the predominant anesthesia type used. Most patients reported very good, and excellent overall health, and 178 or 61% experienced pain during or after surgery, in which majority of them, or 84%, only had a mild level of pain. Except for 5 patients, almost all patients were aware that the anesthesiologist administered the anesthesia during surgery, as seen on this table. All patients mentioned that their anesthesiologist encouraged them to ask questions. However, only 66% did ask questions to the anesthesiologist, which all reported that the anesthesiologist answered the questions clearly. All patients reported that the anesthesiologist visited them before their surgery, and talking with the anesthesiologist during the visit definitely made 83% of patients feel more calm and relaxed. Median rating given by the patient to the anesthesiologist was 10. A perfect rating of 10 was given by 55% of participants, and a total of median satisfaction rating of 87.22% was concluded, with 36 or 12% of patients actually had a 100% satisfaction rating. Factors associated with perfect satisfaction rating was explored in this table. Of the demographic and clinical characteristics tested, only the following factors were found to be associated with 100% satisfaction. Patients with vocational level of education had 6 times higher odds of 100% satisfaction rating compared to patients with primary level of education. Patients who received spinal anesthesia alone or in combination have 10 times higher odds of 100% satisfaction rating compared to patients who did not receive spinal anesthesia. And patients with mild and moderate level of pain during or after operation have 6 times higher odds of 100% satisfaction rating compared to patients without pain, which is probably due to prompt and effective management of their symptoms. In conclusion, the result of this study suggests that the factors that explain patient satisfaction most significantly was the resolution of post-operative symptoms and or absence of it. A good pre-operative visit and successful management of post-operative complications were enough to provide favorable patient satisfaction in doing a post-operative visit. And lastly, aspects mentioned in the study that could affect patient satisfaction includes patient anesthesiologist rapport or understanding, proper perioperative planning, good pain control, and management of anesthetic side effects. With that, thank you for listening and have a good day. Thank you.
Thank you very much, Dr. Cajolas. And now may I call on the to start our Q&A. May I call on the chairman of the Board of Judges to start questions.
Okay, thank you and congratulations, Dr. Cajoles, for your paper. No? First of all, a comment lang. No? I have to disagree with the advice given to you by your statistician. No? I think you should still do some validation study with regards to the use of your tool, because it was developed using American subjects in consideration. And our Filipino, you're from a government hospital, right?
Yes, sir.
Your patients might have a different view on what constitute good patient satisfaction. No? So, and if you pre-tested your paper, you might have catch on that you used as a question regarding race, and you asked if they were Black, Latino, Hawaiian, or Alaskan, which is actually inappropriate for your patients. No? So my first question is, you mentioned in your methodology that you use a summary score of 95 being the highest, correct? So you assigned scores per item, 5 or 6, according to the Likert scale, and you had a summary score of 95.
Yes.
I guess you use it because one of your goals was 100% satisfaction, and you reported a median rating of 80 something. No? So my question is, did the original ASA patient satisfaction tool use a summary score? And if they did, what was the cutoff for saying that the patient has patient satisfaction?
I actually, sir, I really don't know if there is a universal rating as for example, in our hospital, we are the ones who set the percentage of level of satisfaction. Like in our institution, we set it to 85%. And the goal this is the goal in making a strategy in performance governance system. So we are the ones who set the level of satisfaction to
That's okay, no?
be favorable at 85%, sir.
That's okay, but you have to consider that when you're adapting a tool, you have to use it the way they intended it to be used. No? So if they did not set a summary score, don't use a summary score. No? Kasi, for example, you said you based your 95 score based on 19 items, but your survey questionnaire actually comprised of 30 to 33 questions and not 19. So I don't know how you get the score of 95. Okay, last second question is, based on your results, what are the dimensions or domains of your questionnaire that contributed most in the patient satisfaction of your patients?
The domain, sir, that actually contributed to that was the preoperative visits, the uh, the how the anesthesiologist provided relief to their agony, and also um, for those who experience pain and post-operative symptoms like nausea and vomiting, on how it was managed. So those two, sir, contributed the most to the satisfaction ratings.
You mentioned pain management and the provider-patient relationship. No, those if you look at your original ASA tool, they identified the dimension as decision making, involvement in decision making, pain management, attention, provider-patient relationship, and anesthesia-related sequelae. No, so I encourage you to read the actual ASA tool. Thank you.
Thank you, sir.
Thank you very much, Dr. Prudente. For our next judge to ask questions, may I call on Dr. Jose Beltran.
Good afternoon, Dr. Cajoles.
Good afternoon.
Based on the result of
your study, it seems that there is a difference on the educational on the satisfaction rate on the education based on the educational attainment of the subjects. No, you mentioned that those in primary has apparently higher satisfaction than those on college or vocational. Can you cite the reason behind?
With that matter, sir, I pointed it out as a statistical result based on the data that I was able to gather. But with specific reasons on how did that come up, um, I think I really cannot say on behalf of the participants because they were not provided with comments, sir, that they can actually write on. But if I'm gonna make an assumption on why would that be, because probably yeah, in the province, we can say that the level of satisfaction in patients has kind of selective bias. Like if we have attained a higher level of education, we tend to be um, very particular on what kind of healthcare that we are getting. But for the population that actually were not able to have higher education, probably because of their status in life, they are easily they can easily be feel contentment even on how little healthcare you have provided them.
I have a next question pero 2 minutes na kasi. Sorry, sir. Next na lang.
Thank you very much, Dr. Beltran. Next na pwede kong tanungin kung may time pa po mamaya. Nasa may call ang Dr. Serafin Bernardo for his set of questions.
Hi, good afternoon, Dr. Cajoles. No, actually, my first question was related to the question of the first judge. No, with regards validation of questionnaires. No, normally when we conduct questionnaires like this, we test pilot it or test run it before we. It's not enough that a professor will just validate it. No, we usually run it and test how valid are the questions are. Okay. My question is, how did you conduct the survey again? Is there a particular person who conducted the survey or just different residents conducted this? And this was on a face-to-face or a paper questionnaire?
The residents, doctor, performed them as they served as my research assistants. We conducted it using paper survey, sir, because initially this research was proposed using a electronic device or a tablet and will be using a Google form. But then upon reassessment of our technical and ethics committee, at that time they discouraged it due to health reasons, sir. So we thought that the paper questionnaire would be safer for everybody. Sir.
Okay. So do you think there will be a bias if you do it on a face-to-face compared to a hard copy survey form evaluation of your patient satisfaction?
To be honest, sir, I think that there will be even a little, yeah, there will be a bias with them as the patient is directly facing the one that is conducting the survey. So
yeah,
there might be a little bias there.
Yeah, because based on experience, you know naman how patients who are admitted in government hospitals are more kind and more nurturing to their doctors compared to the patients who are admitted in private hospitals. Okay, thank you very much, Dr. Cajoles.
Thank you very much, Dr. Bernardo, for your questions. The fans of Dr. Cajoles can now rest on your lap. We can now go to our next presenter, who will be presenting to us her paper, on left head rotation as an alternative to difficult tracheal intubation. So may I now call on Dr. Danya P. Chan.
Tracheal intubation is a life-saving intervention. Optimizing the patient's head and neck position for the best glottic view is a crucial step that facilitates a quick intubation. Difficult intubations may present for experienced and inexperienced physicians, which may result in aspiration, esophageal intubation, and prolonged hypoxia. There are several positions used for intubation. The sniffing position has been preferred and is the current gold standard to visualize the glottis with a successful first attempt at intubation. Studies claim that the sniffing position did not improve glottic visualization nor success rate on intubation. This led to various maneuvers challenging the sniffing position. The left head rotation maneuver, or LHR, is a simple novel approach for difficult airway introduced in 2019. Using LHR has been proven successful after more than a single attempt at intubation using various methods. When the patient's head is turned to the left, the esophagus will be compressed by the trachea, making the intubation easier. This non-invasive maneuver can be the best alternative before proceeding to a surgical airway. This study assessed the success rate of intubation of patients in the LHR versus sniffing position. Specifically, it aims to answer the following questions. Cormack-Lehane is a grading system commonly used to describe the glottic view during direct laryngoscopy. Intubation difficulty scale is an objective and comprehensive assessment of the difficulty of intubation based on the number of attempts, number of operators, number of alternative techniques used, the glottic exposure, lifting force, the use of cricoid pressure, and vocal cord mobility. A score greater than 5 represents intubation with moderate to major difficulty. In this study, successful intubation is defined as presence of capnographic waveform and less than or equal to 2 attempts at intubation. This is a randomized open-label clinical trial. Enrolled participants were scheduled for elective surgeries requiring intubation. A standard airway evaluation was performed. Once the patient meets the inclusion criteria, consent was secured during the preoperative assessment. Randomization was done via draw lots. There were 26 allocated participants for each group. Group A were intubated using LHR, while Group B were intubated using the sniffing position. Cormack-Lehane grade and the intubation difficulty scale, or IDS, were graded after intubation. And if the intubation is unsuccessful after 2 attempts, an alternative position was performed and the same scoring applied. The study ends after a successful intubation and the intended surgical procedure will proceed. So for the results and discussion, most participants were 54 to 65 years old. Sex distribution favored males. And 50% of the subjects had normal BMI. The analysis did not show any significant statistical difference between the two groups in terms of age, sex, and BMI. This graph depicts the relationship of Cormack-Lehane and the 2 positions. Majority were Cormack-Lehane grade 1. The relationship between Cormack-Lehane and the 2 positions was statistically not significant. It is worth noting that while my study included patients who have Mallampati 3, which is an established predictor of a difficult intubation, only 8 out of 52 patients had a Cormack-Lehane grade of equal or more than 3. This graph breaks down the intubation difficulty scoring. When the patients were intubated in the LHR position, the anesthesiologist had more than 1 attempt at intubation, more than 1 operator, and they used a stylet as alternative technique. Even if the results are not statistically significant, there was an increased lifting force and increased use of cricoid pressure when the patients were intubated in the sniffing position. This graph describes the relationship between the IDS and the two positions. Most patients were intubated with slight difficulty. There is no statistical significance between the IDS and the two positions. So there was a study comparing the ease of intubation between 200 obese and lean patients. Among 9 patients who had a Malampati 3, only 2 had an IDS score of more than 5. So our findings also conclude that Malampati test, when used alone, is a poor predictor of difficult intubation. There was a 100% success rate of intubation with sniffing position. On the other hand, only 24 out of 26 were successfully intubated in liver. This is an analysis of the 2 failed intubations with liver. Had a Cormac-Lehane 3 and an IDS of 7, despite the use of a after 2 attempts. After shifting to the sniffing position, Cormac-Lehane improved from 3 to 2 and IDS from 7 to 3. The second patient had a Cormac-Lehane 4 and an IDS of 8. Despite the use of stylet, cricoid pressure, change of operator, and additional lifting force, the patient's airway was not secured. After shifting to the sniffing position, the Cormac-Lehane improved from 4 to 1 and IDS improved from 8 to 2. The difference here is big, and it's possible that this is an incidental outcome. The study size is small, and this is not enough to make a conclusion that LIHR is not effective. The clinical experience may have played a role in the assessment of intubation. So senior residents and consultants were oriented with the research, and both had limited experience with LIHR. During the first attempts, some awkwardness was noted as they performed LIHR. In conclusion, this study revealed that sniffing position provide a higher intubation success rate since there is better laryngeal exposure and intubation ease compared to the left head rotation. However, the generalizability of our study's outcomes needs to have a larger number of participants to provide a credible comparison. Since the sniffing position is almost always the default approach, we recommend doing simulation training of LIHR among practitioners to provide greater familiarization. Lastly, LIHR can be performed continuously and challenges can be documented to improve intubation conditions. Thank you very much and good afternoon.
Thank you very much, Dr. Chan, for that presentation. Now, may we call on, at this time, we'll call on Dr. Jose Beltran to start our question and answer.
Good afternoon.
Good afternoon, sir.
I believe you use a video laryngoscope for intubation.
No, sir. We used a standard laryngoscope. So we used a direct laryngoscope during the data collection.
Okay. What would just in case the laryngoscope, direct laryngoscope, will fail, what other options do you have?
During the data collection, sir, we already, our institution already acquired a video laryngoscope. So in the case that the intubation fails despite the shifting of the positions, the standard treatment of a difficult intubation based on the ASA difficult airway algorithm will still be applied, sir.
Okay. That's my only question. Thank you.
Thank you, sir.
Thank you, Dr. Beltran. May I now call on Dr. Bernardo for his questions? Dr. Bernardo.
My question is, since you are comparing two techniques, why are you using different operators, which will provide more variable in terms of testing the efficacy or effectiveness of a technique? Why not doing the intubation on different patient by a single operator?
I guess, sir, that was one limitation of my study since there were obvious reasons for inter-observer variability. So I guess we could propose another study using only one operator.
Yes, because we try to, if you are comparing a technique, it's better to standardize or make your variables as few as possible. The training of the anesthesiologists and the level of expertise will play a role in terms of performing a technique in anesthesia. Okay, thank you.
Thank you, sir.
Thank you very much, Dr. Bernardo. Now, we call on Dr. Prudente for his set of questions.
Good afternoon and congratulations, Dr. Chan, no? Especially for picking up a research idea from a case report. No? But to be fair, no, this case report was reported in BMJ case report. My question is related to Dr. Bernardo's question. You have, in any technique, you have some learning curve. So, did you train or your operators with regards to Leher before you started your study?
During the before we made the data collection, sir, uh, we failed to simulate the leher on on a model. So that was part of the limitations of my study also. Um, since the since the instruction or the process of doing we only tried to rotate ahead to the left at using 45 degrees. We assume that we can perform it very easily. So one limitation of my study was, yes, the clinical experience should have been that we tried to simulate numerous times before doing the research, sir.
So, yes, I agree with you, Judo. The point here is that it's unfair for the Leher group, no, if your operators are not yet proficient with the technique. So you have to train them first and be proficient with the technique before you compare it with the standard intubation. No? Do you think that I'm in favor of doing simulation first for in terms of patient safety. But do you think using an airway mannequin will simulate the anatomic changes that a rotation of the head will produce in an actual human?
It will be hard, sir, but I think with continuous practice, I think we can perfect the maneuver if we try to continuously apply leher with our mannequin, and also we can also try her with our simple patients, those patients who can be easily intubated also, sir.
Yeah, I agree with that now because my reservations with the mannequin is usually 'di ba stiff yung tissues niya, no? So it will not fall based on gravity. And what you can simulate actually is the angle of the rotation because some of the papers that describe this technique proposes that you rotate the head more than 45 degrees, correct? And some will say that with less than 40 degrees rotation, it will not help. No? So, yung masanay lang ang operator to get the optimum angle of rotation can be helpful. Thank you.
Thank you po, sir.
Thank you very much, Presidente. Thank you very much, Dr. Chan, for your presentation. Now, our next presenter, I'm sure, is excited to present her paper. So, without further ado, to present to us the performance on Minicog screening test as a predictor for postoperative complications in older orthopedic surgical patients admitted in a tertiary hospital, February to October of 2020. May I call on Dr. Cheryl Joyce Tan. Dr. Tan, your floor, please.
Just hold it, Dr. Chan, ha?
No presentation will be complete without a little bit of technical difficulties.
Thank you, Doc. Both in terms of incidence and associated adverse outcomes, perioperative brain dysfunction is as serious as the other varieties of organ system dysfunction for which we routinely screen and evaluate surgical patients. Why then don't we routinely assess cognition preoperatively? Good afternoon. I'm Dr. Cheryl Tan, and I'm here to present my research entitled Performance on Mini-Cog Screening Tests as a Predictor for Post-Operative Complications in Older Orthopedic Surgical Patients Admitted in a Tertiary Hospital from February 2020 to October 2020. Cognitive impairment is common perioperatively. This is a particular problem in elderly with 30 to 80% developing delirium after major surgery and 30 to 40% and 10 to 15% having early and late post-op cognitive dysfunction, respectively. This is associated with adverse surgical outcomes, longer hospitalization, higher resource utilization, and higher mortality. The American College of Surgeons and the American Geriatric Society have suggested that pre-op cognitive screening should be performed in elderly surgical patients. However, formal and routine pre-op cognitive evaluation is not yet implemented in most medical centers. The study will benefit health professionals by guiding management decisions and development of hospital protocols on perioperative geriatric care, and ultimately, the patients. Comprehensive geriatric care can then be targeted to those identified as at higher risk and hopefully improve surgical outcomes. Here are the general and specific objectives and the multiple limitations of the study. Hip and knee replacement are among the most common procedures performed on patients more than 65 years old. There is intense interest in identifying predictors of adverse outcomes in this age group, as they have a high complication rate and often do poorly post-operatively. As a result, geriatric management protocols now increasingly incorporate pre-op cognitive screening. Cognitive deficits are often subtle and missed by casual observation. In a US study, the prevalence of dementia increases from 5 to 40% with older age, even higher if milder forms of cognitive impairment are included. On patients for elective hip replacement, 20% have cognitive impairment. Previous studies reported that poor pre-op cognition is associated with greater post-op complications and that a low pre-op mini-cog score predicts adverse outcomes in older surgical patients requiring post-op ICU care. Unresolved is whether pre-op cognitive screening can help identify those at risk for an adverse outcome when the procedure is common and elective. There are yet no evidences to support that targeting these poor cognitive performers for multi-component intervention improves surgical outcomes. But recent literature suggests that interdisciplinary communication, rehabilitation, specialized units, and comprehensive geriatric care may enhance outcomes of surgical patients. As illustrated in this framework, preoperatively, mini-cog test performance, demographics, and clinical profile of eligible patients were looked at. Then, post-op complications were observed with the aim of determining the relationship of mini-cog performance to these outcomes. This is a prospective cross-sectional study conducted at a tertiary hospital on patients more than or equal to 65 years old who were scheduled for hip or knee replacement between February and October 2020. This group is selected because lower extremity joint replacements are relatively homogeneous, do not share a risk factor with cognitive impairment beyond age, and do not affect the CNS directly. Those with prior diagnosis of dementia, planned outpatient surgery and ICU admission, known CNS pathology, limited vision, hearing, or ability to draw, and those who can't understand English, Filipino, or the local dialect were excluded. It is important to distinguish that delirium is an acute reversible condition with a fluctuating course, while dementia is a combination of cognitive deficits that are chronic and non-fluctuating in nature. Demographic, medical, and functional data were gathered using the existing institutional pre-anesthesia assessment form. Outcomes investigated included delirium, hospital length of stay, mortality, and non-cognitive complications. Patients were cognitively screened using the mini-cog. This involves a 3-item recall test for memory and a clock drawing test. The mini-cog is validated in community-based populations, has minimal bias, high sensitivity and specificity, and good inter-rater reliability. 5 is considered a perfect score, and less than or equal to 2 is considered probably impaired. Accordingly, this was used as a cutoff score. Delirium was identified both by chart review and by direct independent assessment using the confusion assessment method. A diagnosis of delirium requires the presence of an acute onset of mental status changes and inattention, and either disorganized thinking or altered level of consciousness. Qualitative and quantitative data were summarized as rates and proportions and arithmetic mean with standard deviations, respectively. Poor pre-op cognitive score is low educational attainment. Advanced age, sex, BMI, ASA status, ADL, operative diagnosis, and type of joint replacement procedure were not associated with adverse outcomes. 18.2% of elderly patients for hip and knee replacement have probable pre-op cognitive impairment. 27% develop post-op delirium. The results show a notable percentage of elderly patients electing to undergo hip and knee replacement procedure have baseline probable cognitive impairment that are previously unnoticed or unrecorded but may be severe enough to affect post-op management. Those with low mini-cog score were thrice more likely to be positive for post-op delirium. These figures are comparable to the results of recent literatures. However, unlike studies done in specialized units, the relationship of cognitive impairment with non-cognitive adverse events for this demographic cannot be confirmed. As a conclusion, pre-op mini-cog screening can predict post-op cognitive complication in older orthopedic surgical patients. Lower educational attainment is associated with a poor pre-op mini-cog score. Among elderly patients for hip and knee replacement, a notable percentage had pre-op probable cognitive dysfunction and post-op delirium. Those with poor pre-op cognitive performance were three times more likely to be positive for post-op delirium. Highlighting one of these recommendations, cognitive screening such as the minicog can be a valuable adjunct to traditional preoperative risk assessment practices. Why then don't we routinely assess cognition preoperatively? By now, we should. Thank you.
Thank you very much, Dr. Cheryl Joyce. I now call on Dr. Bernardo for his set of questions for you.
Congratulations, Dr. Tan, no, for initiating this study. But my only concern here is your sample size.
Yes, Doc.
I know for a fact that you have very limited subjects in this study. And my worry is how can you validly extrapolate your study and based on a very small sample size?
Tan, did you get Dr. Bernardo's question?
No, Doc, sorry.
Yeah, I'll repeat your question. Dr. Tan, thank you for this study. My worry
Yes, Doc.
here, my only comment here is the small sample size of your subjects.
Yes, Doc.
And then how can you validly extrapolate your conclusion based on a very small study group?
Well, as much as we wanted to collect about at least 30 samples, Doc. So before the pandemic, our estimate was we were able to get at least 60 samples that would clarify the inclusion criteria. But because pandemic happened, fewer patients were admitted for elective surgery, and also for among those who fit the inclusion criteria. So that limitation, Doc, was stated in our paper also.
Thank you, Doctor.
Okay, thank you, Dr. Bernardo, for that question. Now, I call on Dr. Prudente for your questions to Dr. Tan.
Again, congratulations, Dr. Tan. I think your paper is one of the better written manuscripts. My first question is, you had two patients who had minicog score of less than or equal to 2. Did you consider them as mentally competent or were they incompetent?
Doc, they were mentally competent. They had subtle findings of cognitive impairment that were only seen upon doing the minicog exam.
Okay. So the minicog...
So they were classified as those having as probable cognitive impairment.
Okay. So minicog is a simple test, no? Maybe next time if you want to increase the sample size, you want to consider also using other tests like the mini mental exam, no? Because patients who are at risk of dementia and mental incompetence will have an implication on getting the consent, right? If they cannot decide on if they're mentally incompetent, they cannot sign the informed consent for you. Okay. Also,
yes.
Yeah.
Those that were already diagnosed with dementia, Doc, were excluded from the study.
I understand that, no, but sometimes patients will not come in for will not consult for diagnosis of dementia. So the next question actually is, were you able to test these two patients who had less than 2 score in minicog if they already had dementia or not delirium, no, kasi it's chronic dementia pre-operatively? Because if that was present pre-operatively and then you saw it post-operatively, baka it's not the operation that that's affected them.
We did not do other tests, Doc, aside from the mini-cog. We only did chart review and interview with the patient and the SO. So to rule out possible strong factors associated with dementia, we ruled out patients with strong history of Alzheimer's or stroke or previous histories of mga cerebrovascular disease.
No, kasi the use of minicog is not for prediction. No? It correlates well with other tests. No? Last is you were the outcome assessor. You assessed for post-op dementia using the confusion assessment method scale. Correct. So were you blinded as to the minicog scores of your patients? Sorry, nakamute kaya.
I was not blinded, Doc.
Okay, so that's a possible source of bias. No? So if you want to increase your size, maybe you consider other observers. You can do multiple observers and just settle your difference by a decision tree, your inter-rater variability. Okay, thank you.
Okay, thank you very much, judges, for your questions to Dr. Tan. The fans of Dr. Tan can breathe a sigh of relief. Our next presenter, who I'm sure would like to present already, will be presenting on clinical outcome of confirmed COVID-19 patients who underwent an operation under general anesthesia, admitted in a tertiary hospital on March 2020 to March 2021. So may I call on Dr. Gabriel Angelo Vista to present to us this case. Dr. Vista.
Good day, everyone. I am Gabriel Angelo Vista, and I will be presenting my research paper entitled Clinical Outcomes of Confirmed COVID-19 Patients who underwent an operation under general anesthesia admitted in a tertiary hospital on March 2020 to March 2021. In December 2019, a disease outbreak occurred in Wuhan, China, caused by the severe acute respiratory syndrome coronavirus 2 or SARS-CoV-2 and has rapidly spread all over the world. One of the Southeast Asian countries has been the pandemic with approximately 444,164 confirmed cases with 8,677 deaths. Elective surgical cases were initially put on hold, but life-threatening cases requiring surgical interventions were still catered, in which some requires general anesthesia, which also carries certain risk on the respiratory function of the patient. Changes to the respiratory system can occur immediately, even at the induction of general anesthesia. Respiratory drive and muscle function are altered, lung volumes reduced, and atelectasis develops in more than 75% of patients receiving a neuromuscular blocking drug. The purpose of this study is to provide local data on the socio-demographic characteristics, clinical profile, ICU admissions, complications, mechanical ventilation requirements, and mortality rate among these patients. This study would help in better scheduling of the proposed operations, guide us in determining appropriate recommendations for a favorable outcome of the patient, implement better preventive measures by awareness and education, and better utilization of health resources. The study aims to determine the clinical outcomes of confirmed COVID-19 patients after surgery under general anesthesia with the following specific objectives. This paper employed a descriptive cross-sectional study design conducted at the tertiary hospital from March 2020 to March 2021. The target population or the patients with their medical records were confirmed positive for COVID-19 and underwent surgery under GA, and involved total enumeration of all these patients. After approval from the Technical Review Committee and Ethics Review Committee, the data collection was started, which involved searching scan charts of the concerned patients using the patient's record database for a chart review and collated the necessary data from each chart using a data extraction tool. Data obtained was encoded and tabulated in Microsoft Excel. 71 charts were included in this investigation. Pertinent data are then tabulated, analyzed, and discussed accordingly. The mean age of patients affected is about 38.53 years old, mean BMI of 23.3 kilograms per meter squared, and predominantly males. For the classification, more patients was noted to be under class 3, with the most common preoperative comorbidity is hypertension. The most common symptoms at COVID-19 onset were fatigue or malaise, followed by cough, then myalgia or arthralgia. These manifestations are non-specific, and anyone presenting such symptoms should be carefully screened due to a high index of suspicion. About 78.57% of patients with chest X-ray and 12.86% with CT scan had radiologic evidence of COVID-19. The routine use of imaging modalities, especially chest CT scan, together with RT-PCR testing, can help screen COVID-19. Patients who will undergo surgery can be highly contagious, with asymptomatic positive patients still having a transmission potential. Neurosurgery was responsible for treating the largest percentages of these patients, followed closely by general surgery. Majority of these patients under neurosurgery require more emergent operations even during these COVID times. Almost all who had surgery under general anesthesia had endotracheal tube insertion as their airway management. This is understandable as it is the best option to do during the time of pandemic by securing the airway for a safe operation. The mean duration of the surgeries while on general anesthesia is 181.9 minutes, which is more than 2 hours, thus increases the risk of exposure. During the disease progression, 4.29% of patients received ICU care with a mean postoperative ICU length of stay of 3.33 days. This may be due to the limited number of days of beds in the ICU versus staggering amount of patients admitted in the institution that require ICU admission. After the operation, 76.05% were extubated, 16.9% of which remained intubated postoperatively, and 7.05% reintubated sometime postoperatively. The postoperative intubation rate in this study is 23.95%. This study had a complication rate of 26.76%, with shock requiring vasopressors ranked as the highest at 9.85%. The mortality of patients with COVID-19 was at 11.3%. All of these patients have one or more comorbidities. These patients were further stratified to belong to ASA class 3 and 4. The mean length of hospital stay is 28 days, and this can be helpful in estimating the average cost of each patient contracted with COVID-19 for operation under GA. In conclusion, the ICU admission is low, while the mortality rate, mechanical ventilation requirement, and complications are high. This may entail a connection of general anesthesia in patients undergoing surgical procedures, which necessitate strategies to decrease perioperative mortality and morbidity, infection transmission to healthcare workers, and provide less risky anesthetic techniques such as spinal anesthesia and peripheral blockade. Due to the limited data and knowledge of this disease, this paper was only able to perform a descriptive analysis. Recommendations for further research are the following, and here are my resources. Thank you.
Dr. Vista, thank you very much for that presentation. So now may I call on once again Dr. Prudente for his set of questions.
Congratulations, Dr. Vista, no, for a very timely topic. No? But I think I'll just give my time to Dr. Beltran and maybe ask questions if there's still time.
Dr. Beltran, your questions, please.
Yes, good afternoon. Would like to verify the reason for reintubation of how many patients was that?
For these patients, doc, who are reintubated postoperatively, they had a these patients were already in a poor condition due to their preoperative medical complication or disease, and postoperatively they had a difficulty in respiration, doc, or in ventilation. Thus, they were intubated after, doc, or sometime postoperatively, doc. So they were intubated at the ward na, doc.
At the ward or at the ICU?
Sorry, Doc. Some of these patients were in the ward, Doc.
Was the intubation immediately post-op or how
No,
many
Doc.
days?
No, Doc. A few days after, Doc. The operation, Doc.
Okay. That's all. Thank you.
Thank you, Doc.
Okay, thank you, Dr. Beltran. Uh, Dr. Prudente, do you have your questions ready, or can we proceed to Dr. Bernardo?
No, I'm just worried that I'm taking
Just one
time.
comment lang. Just one comment lang. Thank you, Dr. Vista. No? Did you try to, I know this is a descriptive study, no? Did you try to make a comparative study with another institution or from other countries comparing your observation?
Thank you, Doc, for the suggestion, Doc. So, for my study, Doc, I was really thinking of making a comparative study, but because of the limitation of the data, Doc, I was only able to do a descriptive study, Doc, because this topic or this disease entity is still in its early, as we say, early phase, Doc, or only a few months or a year, Doc. So I also researched about a part of my related literature, Doc. There were some studies wherein there were comparative studies between doing general anesthesia in patients who are COVID positive and patients who were not COVID positive, Doc. So I was planning to do that, Doc, but due to the limitation of the data, Doc, as well as for the limitation here in our institution, Doc, I was only able to perform a descriptive analysis, Doc.
Thank you, Dr. Vista.
Thank you, Doc.
Okay.
Thank you,
Can I
Dr. Bernardo. Dr. Prudente, your questions, please.
So that's good, Dr. Vista, that you mentioned that you want to compare it with non-COVID patients. No, also if you can compare it with non-general anesthesia patients, meaning other patients who underwent regional anesthesia. No, so you can compare the effect of surgery versus just the effect of the anesthesia and probably intubation. No? So, and I agree with Dr. Bernardo that this is a perfect protocol to share with other institutions that you can do multi-center studies. No? But you want to have more information since this is just a cross-sectional study. It doesn't really tell us so much unless you specifically look for such factors like because your results said most of those who went to ICU were neurosurgical patients. No, it might not be COVID related. No, it might be
Yes.
just patient factor, the surgery itself. No, so you want to look at pre-op COVID status of your patients. What are they? Oxygen support or airway support at that time. No, and you want to look at outcomes that are specific um, to general anesthesia and intubation, such as atelectasis, barotrauma. I've seen some patients who had subcutaneous emphysema. No, those yung parang you have to look at factors that will affect your outcome rather than just uh, collect data and parang walang masyadong conclusion that you can get. No? Thank you.
Thank you, Doc. For my one of my recommendations, Doc, was to have a multi-centered approach on this research, Doc. So thank you, Doc.
Thank you very much, Dr. Vista. Thank you very much, judges. I can see our next presenter is excited, preparing herself already. So our next presenter will be presenting an RCT, a randomized controlled trial on the efficacy of prophylactic intravenous ondansetron on the prevention of shivering during spinal anesthesia. Interesting. So may I call on Dr. Sarah Angelica Yambao to present to us her paper. Dr. Yambao.
Good afternoon po, doctors. I'm Dr. Sarah Angelica Siyambao, and my research is entitled A Randomized Controlled Trial on the Efficacy of Prophylactic Intravenous Ondansetron on the Prevention of Shivering During Spinal Anesthesia. My general objective is to determine the efficacy of ondansetron 8 mg IV in preventing shivering during elective lower abdominal and lower extremity surgical procedure under spinal anesthesia. And my specific objectives are as follows. First is to compare the core temperature changes of ondansetron and control group after induction of spinal anesthesia and for the whole duration of surgery. Second is to compare the incidence and rate of shivering in ondansetron and control group. And third is to record skin and core temperatures intraoperatively and relate them to shivering incidence. So shivering is an involuntary oscillatory muscular activity that can increase metabolic heat production up to 600% of the basal level. And shivering occurs following general or neuraxial anesthesia with rates as high as 55%. So as we know and see, patients report that shivering is remarkably uncomfortable, and some even find the accompanying cold sensation worse than the surgical pain. Moreover, shivering per se may aggravate post-operative pain simply by stretching the surgical incisions. Shivering occurs primarily in response to core hypothermia, and the normal response to hypothermia involves thermoregulatory vasoconstriction to decrease cutaneous heat loss and maintain heat within the core. Maximal vasoconstriction occurs before thermoregulatory shivering occurs. Now, the interthreshold range describes the lower and upper limits of core body temperature between which no autonomic thermoregulatory effects are triggered. At a core temperature above this range, the body will initiate cooling measures such as sweating and vasodilatation. And at a core temperature below this, vasoconstriction and shivering will commence. Intraoperative hypothermia develops in nearly all unwarmed surgical patients and results from the combination of anesthesia-induced thermoregulatory impairment, cool operating room ambient temperature, and exposure of open body cavities during surgical procedures. But the most important of these factors is the thermoregulatory impairment, since anesthetized adults would otherwise resist surgical heat loss via vasoconstriction and shivering. Now, this table shows the number of dermatomes blocked versus reduction of the shivering threshold. So the shivering threshold was reduced more by extensive spinal blocks than by less extensive ones. Now, the mechanisms of ondansetron on shivering may be related to a central mechanism of the inhibition of 5-HT reuptake on the preoptic anterior hypothalamic region. Ondansetron and meperidine have similar effects on the prevention of shivering without significant association of ondansetron with bradycardia. I chose a single-blind, randomized placebo-controlled study, and for the review of related studies, all publications were searched online, and I used PubMed with the following terms: ondansetron, shivering, spinal anesthesia, and prevention. I preferred randomized controlled trials and systematic reviews, and I also used the book Hadzik's textbook for regional anesthesia and acute pain management for reference. For the critical appraisal of related literature, I reviewed primarily preventive interventions, and I read about post-anesthetic shivering, pharmacological and non-pharmacological interventions for shivering during neuraxial anesthesia. We included 60 eligible patients in this study, and participants were allocated randomly into two groups. Group O received 8 mg ondansetron, and Group C received 0.9% saline in total volume of 4 ml. These are my inclusion criteria, and these are my exclusion criteria. For the methodology, we use a fishbowl technique for the randomization of the participants to group O and C, and then the study drug was administered by the anesthesiologist 30 minutes prior to induction of anesthesia. Spinal anesthesia was done using a gauge 27 spinal needle at the L3 to L4 interspace, wherein 20 milligram of hyperbaric 0.5% bupivacaine was given intrathecally. The patient was then positioned in the Trendelenburg position, and the block was allowed to reach a height of until the T6 dermatome. The shivering was assessed after the completion of subarachnoid drug injection, and the core temperatures were recorded before the induction intervals for the whole duration of surgery using a tympanic thermometer. Shivering was evaluated during the intraoperative and postoperative period by observation of the pectoralis major muscles for more than 10 seconds duration. Outcome is to have a less than 10-20% incidence of shivering in the ondansetron group. And we use the software SPSS for Macintosh version 23 for the calculation and the statistical inferences. The results of the study, Table 1 shows patients' age and gender in all groups. I found no significant difference between age and sex in the two groups. The Table 2 shows the temperature changes of participants included in the study. It could be seen that from this table that the preoperative temperature was a little bit higher among those who were in the ondansetron group compared with the control group, but the tympanic temperature decreased after spinal anesthesia in all groups with respect to their preoperative values. The Table 3 shows the incidence of shivering in both groups. Among these patients, a total of there were 51 patients who had no shivering, and this comprised 85% of the population. In this group, 31 or 51.7% were from the ondansetron group, while 20 or 33.3% were under the control group. On the other hand, there were 11 patients who had shivering. In this group, those who shivered comprised 18% of the population. Among these patients, 8 or 13% of patients were under the control group, while 3 or 5% of patients were under the ondansetron group. The researcher noted significant difference between the incidence of shivering and treatment groups of patients. Rescue doses were not given on both control group and ondansetron group. So for the discussion, the incidence of shivering was 13% in the control group and 5% in the ondansetron group. So we found that the core temperature was preserved in the ondansetron group with respect to the control group during the intraoperative period of spinal anesthesia. So for my conclusion, prophylactic intravenous ondansetron can lower the incidence of shivering in patients undergoing spinal anesthesia. Thank you very much po.
Thank you very much, Dr. Now may I call once again our chair of our board of directors for these questions.
Okay. Good afternoon, Dr. Yambao. Congratulations for conducting an RCT. No, it's really hard to do RCTs. However, some comments. No, the strength of RCTs lies on its design and minimizing bias, such as selection bias. No, where it utilized blinding, allocation concealment, and randomization. So I noticed that in your method, you said that the attending anesthesiologists administering the test drugs were not blinded to the allocation. Okay, so why is that?
Look, during the approval of the study in the ethics committee, at the beginning po of the research proposal, sir, this was a pharmacological intervention. So during this time, the ethics committee in our institution instructed us that this study should, this ongoing study or the study that I am going to start, I must inform all the attending anesthesiologists and even the surgeons who are the attending surgeons of the patient. So we were required by the ethics committee, sir, to.
So I'm supposing because you give ondansetron as a PONV prophylaxis. and
Yes,
it's
Doc.
unethical if you don't give it if it's already standard of care. So what you can do actually is you can give another set of syringe intra-op, not pre-op, no. So if you gave pre-op ang ondansetron, you give placebo on the intra-op. And next is your sample was you had 26, I think, in the ondansetron group, and then 34 in the placebo, or the other way around, no? Why is it unequal ang randomization?
Um, I think I have overlooked that part, sir. I know that I have chosen doc the 60 patients and randomly allocated them in that two groups, sir. I'm so
Oo. Maybe when you did the draw lot sa fishbowl, no, you had unequal. So lastly, with regards to your results, no, I mentioned you had a 26-34 group, but in your results you had a 28 and 34 division. So what is the correct number? Is it 60 sample size or 62?
Uh, in the 28 and 32, doc. So the correct
30.
number would be 28 and 32.
Anyway, it will matter, no, because the you reported positive shivering in in one group as 8, and the other one 3, no, sa on Dancetron, no. So if ang correct sample size is 26, meaning 6 lang ang shivering and not 8, it will make your result actually not statistically significant. So you just check your numbers. Thank you.
Thank you very much, Dr. Proben. Dr. Beltran, your questions, please.
Just would like to verify the conduct of giving ondansetron. How fast or how slow was it administered prior to anesthesia?
During during that time we administered it slow IV push, doc, 1 to 2 minutes, doc, the 4 ml.
Okay. And in your discussion, you mentioned about meperidine and ondansetron. Do they have the same mechanism of action?
No, doc. Actually, doc, no, doc. But apparently, doc, in the papers that I have been reading, meperidine also has actions in the inhibition of the 5-HT3 receptor. But really, sir, the purpose of this study, really, it was conceptualized because of my perceived dilemma when I was a resident. Kasi during that time, shivering is really rampant during spinal anesthesia. During spinal anesthesia, and at this time, sir, we had no supply anymore of meperidine in our institution. And I think not only in our institution, but parang na out of stock talaga siya, doc, even in other institutions. So I'm trying to find a solution or an alternative to meperidine at this time. But that's why po I was comparing it to meperidine, because up until now, meperidine is considered the gold standard in treating shivering, sir, during spinal anesthesia.
Okay, thank you.
Thank you very much, Dr. Beltran, and not least, Dr. Bernardo, your questions, please.
Just one comment lang na. So the ondansetron was given as prophylaxis?
Yes, sir. Yes, doctor.
Have you thought of giving this once the patient had shivering?
Yes, doctor. My research advisor was saying that we can either, one of the ethics committee was saying that ano ba, can it be used as a treatment or as a prophylaxis? But in this research, doc, I really chose for it to be a prophylactic one based also on my mother paper, doc.
Yeah, the reason why I'm asking this is because I was worried also if you give this prophylaxis, what other drugs are being given to the patient. For example, if you're giving this patient analgesics, if you're giving this patient paracetamol, if you're giving all these drugs also may contribute in your findings of having post-op shivering. Okay, that's it. Thank you.
Thank you, doc. Thank you, doc.
Thank you very much, Dr. Bernardo, and thank you very much, Dr. Sara Angelica. Para ko the colors of your screen medyo nakaka-distract, sir. Parang
Sorry.
That's okay. So we're done with all our 5 presentations. I'd just like to echo the sentiments of Dr. Rosello, Dr. Lunas, and our judges, and congratulate all 5 of you for coming this far. No? At the onset, there were more than 10 who submitted papers, and then it was winnowed down to 8. And finally, the both of you. So congratulations, all of you. Hindi mahirap, hindi madaling gumawa ng research papers, especially this time of pandemic. And yet, 5 of you guys, wow, you did well. You did very well. Congratulations. So the Board of Judges will now do their computations, and while they do that, I'd like to present the certificates to our 5 finalists. Okay, so the certificate reads. Okay, so the certificate reads, pwede palakihin yung screen para mabasa natin yung certificate. Ma'am 83 Tech, ma'am, pwede lagyan po ng screen, ma'am, para mabasa po ng lahat yung nakasulat certificate. The Philippine Society of Anesthesiologists Incorporated presents this certificate of appreciation as finalists in the research paper presentation for the annual postgraduate course of the Philippine Society of Anesthesiology. This certificate is presented first to Dr. Roland Cajoles. Congratulations, Dr. Cajoles.
Thank you po.
To Dr. Danya P. Chan. Congratulations, Dr. Danya.
Thank you, sir.
To Dr. Cheryl Joyce Tan. Dr. Tan, congratulations.
Thank
to
you,
Dr. Gabriel Angelo Vista. Dr. Vista, congratulations. And lastly, to Dr. Sara Angelica Yambao.
Thank you.
Yambao, congratulations. And of course, this would not have been the success that it is without the efforts, without the graciousness of our board judges. So thank you very much to our judges for accepting the invitation of the committee for you to participate in such a way in this endeavor. Thank you very much. So these certificates of appreciation will be given to our judges. Right. But the Philippine Society of Anesthesiologists Incorporated presents this certificate of appreciation to the following for having served as judges in the annual residence research contest during the annual convention of the Philippine Society of Anesthesiologists. first for the chair of the Board of Judges, Dr. Emmanuel S. Prudente. Dr. Prudente, thank you very much, Doctor. Dr. Jose G. Beltran Jr. Dr. Beltran, thank you very much. And last but not least, Dr. Serafin L. Bernardo V. Dr. Bernardo, thank you very much. Thank you po talaga sa inyong tatlo. Okay, so now we'll wait for the computations of the judges. So we'll wait for the announcements. Once the results are tallied and we already have the final tally results, we can announce the winners. So while waiting, I'd like to acknowledge the virtual presence of our immediate past president of the PSA, Dr. Benjamin Valera. Dr. Valera, good afternoon po. Thank you for gracing our event. We have 166 participants. Thank you very much to our participants. Thank you for joining us this afternoon and for supporting all our presenters, mga fans ni Dr. Chan, ni fans ni Dr. Yambao, ni Dr. Vista, Dr. Tan, Dr. Cajoles. I'm sure you're all excited to know what the results are.
Dr. Madarang, while waiting, no, may I?
Yes.
On behalf of my fellow judges, Dr. Pai Bernardo and Dr. Jose Beltran Jr., first I'd like to again congratulate everybody, all the finalists for planning, conducting, and writing your manuscripts. Especially this, as mentioned before, no, this time of pandemic, it's really an achievement. Secondly, I'd just like to remind everyone that the audience and the participants that the judging for today is 20% for the oral presentation. So most of the scores actually came from the prejudging of the manuscript. And lastly, I hope you will not take offense on the questioning and comments of especially from me, no? Ganito lang talaga ako magsalita. But hope you take it as constructive criticisms to improve your paper. Okay. So I think we already have the Dr. Madarang. Okay. Is it okay?
Yes, Doctor. Yes. So Dr. Prudente will now present to us the results of their tally and to announce the winners of our contest.
Okay. Okay. So for the third prize, we have the paper on, let me double check. The scores are very close actually. For the third place, we have the performance on mini-cog screening test as a predictor for post-operative complications in older orthopedic surgical patients admitted in a tertiary hospital February 2020 to October 2020. That's the presenter, Dr. Cheryl Joy Stan. Congratulations. Okay. So for the second place, yes, virtual applause, please. The second place, no, with a difference of just 0.3% from the first place, we have the first presenter, a prospective study on perioperative patient satisfaction of patients undergoing elective surgery from March to June using an ASA patient satisfaction questionnaire, Dr. Roland Cajoles. Congratulations. Okay. For the first place, we have with a score of 115.6. We have left head rotation as an alternative to difficult tracheal intubation, Dr. Danya Pichan. Congratulations, and congratulations also to Dr. Gabriel Vista and Dr. Sarah Yambao. You will also receive consolation prizes. Okay, I'll turn it back to you, Dr. Madarang.
Thank you very much, Doctor, and congratulations to all three, to all five of you. But special congratulations to the top three, and congrats, Dr. Danya Chan. Well deserved, well deserved. Thank you very much. And once again, with that, I'd like to, I'm supposed to introduce for closing remarks, but nagkaroon yata ng problema with the presentation. So I would just like to once again thank every one of you for attending. Thank you very much to all our presenters. Thank you very much to all our finalists. Thank you very much to our board of judges for the event. And hopefully, we'll see you again next year for yet another annual research contest. And congratulations to the organizers of the event, and congratulations to the subcommittee on the annual research contest. Thank you very much, and let's enjoy the rest of the convention. Maraming pang events na gagawin. Ang galing naman if I may just say, ang galing ng platform ulit ngayon. It's same as last year. This like may magandang lobby, tapos pwede kang pumunta sa loob. It's an enjoy. Please, everyone, please enjoy convention this year. So with that, thank you very much, and we'll see you.
Good day, dear colleagues. Welcome to our 70th anniversary celebration as we enter our septuagenarian years. Let us mark this virtual annual convention with the most appropriately timed theme, Rewiring the Anesthesiologist Mind, a collaboration of experts. Let us spend the next 3 days together in this exciting re-engineering of minds, together with our roster of world-renowned speakers from here and abroad. Connect with us and join the panel discussions. We have big goals, and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Rewire your memory to develop a phenomenal recall of these reviews of fundamentals and comprehensive discoveries and updates in our trailblazing field. Rewire your attitude as we evaluate these proven solutions and appreciate the expert guidance as we look forward to promote and maintain a community of responsible anesthesiologists who can practice safe and quality anesthesia care in the pursuit of serving the interests of our members, our patients, and the nation. We are the Philippine Society of Anesthesiologists, and with our strong commitment to quality care, our sincere concern for our members, and our genuine interest for professional growth, we're ready to collaborate with the experts. We begin the countdown now. 3, 2, 1. Rewire!
Good day, dear colleagues, and welcome to the 53rd PSA Annual Convention. In celebration of our 70th anniversary as one society and one family of experts in the specialty, we welcome you to our virtual convention with the theme of Rewiring the Anesthesiologist's Mind, a collaboration of experts. Connect with us and join our planned plenary sessions with esteemed speakers and panel discussions with leaders in the field. We have one on challenges in the management of central airway obstruction, another on translating simulation to evidence-based practices in patient safety, and the last on preoperative assessment clinics. Rewiring our brains is the same as neuroplasticity, that refers to our brain's ability to restructure itself when it recognizes the need for adaptation. Listen to lectures on anesthesia in some of our special populations, from pediatric patients up to the anesthesia for geriatrics. Focus on cases of pregnancy, abdominal surgery, and orthopedic ambulatory procedures. We have big goals, and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Join us as we collaborate with each other as we move forward to the succeeding years and decades of the society.
Good day, dear colleagues. Welcome to our 70th anniversary celebration as we enter our septuagenarian years. Let us mark this virtual annual convention with the most appropriately timed theme, Rewiring the Anesthesiologist Mind, a collaboration of experts. Let us spend the next 3 days together in this exciting re-engineering of minds, together with our roster of world-renowned speakers from here and abroad. Connect with us and join the panel discussions. We have big goals, and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Rewire your memory to develop a phenomenal recall of these reviews of fundamentals and comprehensive discoveries and updates in our trailblazing field. Rewire your attitude as we evaluate these proven solutions and appreciate the expert guidance as we look forward to promote and maintain a community of responsible anesthesiologists who can practice safe and quality anesthesia care in the pursuit of serving the interests of our members, our patients, and the nation. We are the Philippine Society of Anesthesiologists, and with our strong commitment to quality care, our sincere concern for our members, and our genuine interest for professional growth, we're ready to collaborate with the experts. We begin the countdown now. 3, 2, 1. Rewire!
Good day, dear colleagues, and welcome to the 53rd PSA Annual Convention. In celebration of our 70th anniversary as one society and one family of experts in the specialty, we welcome you to our virtual convention with the theme of Rewiring the Anesthesiologist's Mind, a collaboration of experts. Connect with us and join our planned plenary sessions with esteemed speakers and panel discussions with leaders in the field. We have one on challenges in the management of central airway obstruction, another on translating simulation to evidence-based practices in patient safety, and the last on preoperative assessment clinics. Rewiring our brains is the same as neuroplasticity, that refers to our brain's ability to restructure itself when it recognizes the need for adaptation. Listen to lectures on anesthesia in some of our special populations, from pediatric patients up to the anesthesia for geriatrics. Focus on cases of pregnancy, abdominal surgery, and orthopedic ambulatory procedures. We have big goals, and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Join us as we collaborate with each other as we move forward to the succeeding years and decades of the society.
Good day, dear colleagues. Welcome to our 70th anniversary celebration as we enter our septuagenarian years. Let us mark this virtual annual convention with the most appropriately timed theme, Rewiring the Anesthesiologist Mind, a collaboration of experts. Let us spend the next 3 days together in this exciting re-engineering of minds, together with our roster of world-renowned speakers from here and abroad. Connect with us and join the panel discussions. We have big goals, and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Rewire your memory to develop a phenomenal recall of these reviews of fundamentals and comprehensive discoveries and updates in our trailblazing field. Rewire your attitude as we evaluate these proven solutions and appreciate the expert guidance as we look forward to promote and maintain a community of responsible anesthesiologists who can practice safe and quality anesthesia care in the pursuit of serving the interests of our members, our patients, and the nation. We are the Philippine Society of Anesthesiologists, and with our strong commitment to quality care, our sincere concern for our members, and our genuine interest for professional growth, we're ready to collaborate with the experts. We begin the countdown now. 3, 2, 1. Rewire!
Good day, dear colleagues, and welcome to the 53rd PSA Annual Convention. In celebration of our 70th anniversary as one society and one family of experts in the specialty, we welcome you to our virtual convention with the theme of Rewiring the Anesthesiologist's Mind, a collaboration of experts. Connect with us and join our planned plenary sessions with esteemed speakers and panel discussions with leaders in the field. We have one on challenges in the management of central airway obstruction, another on translating simulation to evidence-based practices in patient safety, and the last on preoperative assessment clinics. Rewiring our brains is the same as neuroplasticity, that refers to our brain's ability to restructure itself when it recognizes the need for adaptation. Listen to lectures on anesthesia in some of our special populations, from pediatric patients up to the anesthesia for geriatrics. Focus on cases of pregnancy, abdominal surgery, and orthopedic ambulatory procedures. We have big goals, and we aim to figuratively rewire your brains to achieve success in our field of practice. Let us rewire our brains, our memory, and our attitude. Join us as we collaborate with each other as we move forward to the succeeding years and decades of the society.
Good afternoon. My name is Dr. Joseph Abueg. I'm the medical lead for MSD in the region, and I'm proudly a graduate of the residency program of UPPGH Anesthesia in 2005. I will be moderating today's session, and I have the pleasure and the honor of introducing one of my uh, teachers in anesthesia. So I have the pleasure of introducing Dr. Merle de la Cruz Odi, who is a retired professor of anesthesiology. And after 40 years on the academe, she attained the rank of full professor 12 of the College of Medicine, University of the Philippines, Manila. For 50 years, her unwavering interest in the pharmacology of neuromuscular blocking agents, monitoring, and reversal of block has been there. And in 1980, Dr. Odi became the youngest chair of the Board of Examiners of the Philippine Board of Anesthesiology. And for 21 years until 2019, she was the chair of the Board of Trustees. Dr. Odi was the president of the Philippine Society of Anesthesiologists in 1989 and 1990, and then president of the Asian Oceanic Society of Regional Anesthesia in 1995. And in 1999, Dr. Odi became the 14th Quintin Gomez awardee, the highest award ever given to anesthesiologists by the PSA. She subsequently received the award of recognition for service par excellence from the Philippine Medical Association. Again, it is my pleasure to introduce a mentor, a distinguished educator and researcher who knows more about anesthesiology, who has forgotten more than I will ever know. So with this, I hand over the floor to Dr. Merlodi. Doctora?
Thank you, Dr. Abueg, for the very kind introduction. You're Joseph to me. I've known you for a long time. And I would like to thank first the Philippine Society of Anesthesiologists and of course MSD for inviting me to deliver this lecture this afternoon. It took a lot of courage for me to present this title to you, but I thought I would choose a title that is going to be attractive and will call your attention to what I would like to present this afternoon. So with all due respect to the great writer Shakespeare, I actually took this title from one of the soliloquies of Hamlet, to be or not to be. These are my disclaimers. And these are my disclosures. Over the years, because of their frequency and non-life-threatening nature, we have come to consider certain post-operative events as the run of things. And for the longest time, we have accepted them as the norm. These are PONV, POUR, and POGIM. Post-operative nausea and vomiting, post-operative urinary retention, and post-operative effect on gastrointestinal motility. If we are the patient, I wonder how we would feel if this is going to be allowed to be done to us, or if this is going to be allowed not to be corrected. Although we tend to ignore these problems, patients' quality of recovery from surgery and anesthesia become less optimal. In more instances, they're even perceived as worse than pain and can lead to more serious adverse effects to patients. We discussed PONV at length during the mid-year convention. I will just very quickly cite 3 studies here, lest we forget. Then we shall concentrate on the 2 Shakespearean complications, to pee or not to pee, and to poo or not to poo. So let's discuss PONV first, just very shortly. This is the study of Ristovska, which actually was used in turning around, not turning around, but in the inclusion in the guidelines, the fourth guidelines on PONV that came out just recently, on the inclusion of the use of Sagamadex to prevent or to reduce the occurrence or incidence of PONV. And essentially, the objective was to compare the efficacy and safety of Sogamadex against neostigmine in reversing non-depolarizing neuromuscular block in adults. And the methods was actually a 1-year survey of databases between 2 May 2016 and 10 May 2017, 41 studies, 12 eligible for meta-analysis of primary outcome, and 28 eligible for meta-analysis of secondary outcomes. The results were for the primary outcome, Sogamadex 2 milligrams per kilogram reversed T2 block 6.6 times faster than the neostigmine. And again, Sogamadex 4 milligrams per kilogram reversed post-tetanic count of 1 to 5, meaning very intense block 16.8 times faster than the neostigmine. And for the secondary outcome, there are significantly fewer composite adverse events with Sogamadex compared with the neostigmine group. And the specific events, there is significantly less bradycardia and less PONV. For PONV, there were 6 studies that were actually used for the meta-analysis. The second study that I would like to review with you is that of Hereford. This one was published after the fourth consensus guidelines came out on PONV, which this one was actually published 2020 and was not included in the references of the fourth consensus guideline. And here, the primary outcome was the time to recovery of the train of 4 ratio to greater than 0.9. Total anesthesia time as well, time from admission until patient was ready for discharge from the post-anesthesia recovery unit or PACU, the occurrence of bradycardia, and of course, the occurrence of post-operative nausea and vomiting. And from 111 clinical trials, meta-analysis was done on 32 studies. And here is the forest plot, which shows that most of the studies that were included in the meta-analysis and systematic review tended to favor the use of Sogamadex in terms of reducing the incidence of post-operative nausea and vomiting. And the third study is from Korea, and this was again in 2020 and also was not included in the references of the consensus guidelines. And here, there were actually adults who received general anesthesia from January 2014 to December 2019 in 5 hospitals. And they were matched patient groups. 7,793 received neostigmine. This was matched with 7,793 Sogamadex. This is actually retrospective, okay? And there were 10,197 patients who received pyridostigmine, and this was matched with 10,197 who received Sogamadex. And then 19,377 patients received pyridostigmine, and this was compared with 19,377 patients who received neostigmine. And the results were the odds of PONV was low in the Sogamadex group, and this was significant compared to the neostigmine group. The odds ratio was also low in the pyridostigmine group compared to the neostigmine group. And there was no difference between the Sogamadex and the pyridostigmine group. And therefore, Sogamadex and pyridostigmine actually lower the incidence of PONV compared to neostigmine in patients undergoing general anesthesia. So let's go to our first Shakespearean problem, to pee or not to pee, or postoperative urinary retention. I will show you several studies, and this is the only way that I can maybe bring to the fore what I really, the message that I would like to tell you, to cite evidences. And this is the study that was actually a review article that was written by Baldini in 2009. And she actually said that the incidence of postoperative urinary retention is between 5 to 70%. So it's a wide incidence. The age the patient's age, gender, presence of comorbidities, and the type of surgery affect the development of postoperative urinary retention. However, of importance is that anesthesia and drugs such as anticholinergic agents, for example, atropine, and opiates increase the incidence of postoperative urinary retention. As well, they also have started using ultrasound to assess urinary bladder volume to guide the management of POUR. And inappropriate management of POUR leads to bladder overdistension, urinary tract infection, and catheter-related complications, one of which is also infection. So let me just go and walk you, maybe remind you on the mechanism of micturition. The urinary bladder is composed of a body, the detrusor muscle, and a funnel-shaped neck. The internal meatus of the bladder is surrounded by a layer of smooth muscle. So it's smooth muscle, so it's not voluntarily controlled. And this is known as the internal urethral sphincter. There is the external urethral sphincter, which can be voluntarily controlled because they are striated muscles in the pelvic floor. So the bladder is innervated by two opposing groups of nerves. The first one, the efferent, is somatic, sympathetic, and parasympathetic fibers. The afferent are visceral fibers, which are carried by the A, delta, and C, which arise from the bladder wall, and then these are stretch receptors. Okay. So when I said two sets of nerves, the bladder is actually innervated by the parasympathetic fibers, and it is opposed by the sympathetic fibers, okay? The parasympathetic fibers cause contraction of the detrusor and subsequent relaxation of the neck, permitting micturition. The sympathetic fibers, however, influence the relaxation of the detrusor muscle and therefore closes the internal urethral sphincter. So these two systems are governed by spinal reflexes and regulated by two centers, the pontine storage center and the pontine micturition center. So during micturition, there are two phases, the storage and the emptying phase. The high compliant bladder allows for storage of a large volume of urine without an increase in the intravesical pressure. The first urge to void is felt at a bladder volume of 150 mL. However, because the bladder is compliant, the tension receptors in the bladder wall are activated only at a volume of approximately 300 milliliters, creating a sense of fullness. And then the capacity of the urinary bladder is much larger than that. It is from 400 to 600 mL. So activation of the tension receptors propagates signals through the A, delta, and C fiber of the spinal cord. This activates parasympathetic neurons and stimulates efferent pelvic nerves that lead to the contraction of the detrusor muscle. This is parasympathetic, okay? The detrusor contraction substantially raises the intravesical pressure from the resting pressure of 40 millimeters water to a few hundred millimeters water pressure. At voiding threshold of intravesical pressure, the detrusor contractions increase and create a complete and synchronous contraction, allowing the bladder to empty quickly and efficiently. Needless to say, during the contraction of the detrusor muscle, the internal urethral sphincters actually relax. Now, if micturition is not desired or is inconvenient, what happens? The afferent stimuli from the stretch receptors of the bladder, along now with the proprioceptive afferents of the urethra, the penis, the vagina, the rectum, the perineum, and the anal sphincters activate the sympathetic system and the external urethral sphincter motor neurons. So what happens? Simultaneous inhibition of the parasympathetic system occurs, and micturition is prevented through the contraction of the sphincters and the relaxation of the detrusor muscle. So the frontal cortex and the pontine centers are also involved in this process, and so micturition does not occur because of this. So let's first look at the well, at this study that was done in the Netherlands way back. Well, this is an interesting study in that the basis for this study, which was published in 2021, was another study. It's a randomized controlled trial that was done in 2015 that actually just measured the relationship between the maximal bladder volume that the patient can tolerate at home, which was measured preoperatively, and the amount of urine that that bladder can hold postoperatively. So that was the initial study. And they used the information from the 2015 study to actually come up with this study, which was published in 2021. So the aim of this study was to determine the risk factors for POUR in general surgical patients, and then to calculate bladder filling rate and to assess the time to spontaneous voiding or catheterization. So the methods included patients from a previous 2015 study, which I said, which determined individual maximum bladder capacity as threshold for urinary catheterization. And this was prospective, 936 patients, 18 years old or greater, who received general anesthesia or spinal anesthesia. And the patients measured maximum bladder capacity pre-op by voiding in a calibrated bowl. And then post-op bladder volume were assessed hourly by ultrasound. When patients reached their maximum bladder capacity and were unable to void, they were catheterized. And the bladder filling rate and time of catheterization were both determined. So the results were spinal anesthesia was the main independent modifiable risk factor for urinary catheterization, and unmodifiable risk factors were maximum bladder capacity of less than 500 milliliters, duration of surgery, first scan bladder volume, the PACU, and age of greater than 60 years. Catheterization or spontaneous voiding took place approximately 4 hours postoperatively. So the conclusion was, well, spinal anesthesia, longer surgery time, and older age group are the main risk factors. And there's something that I would like to show you before this. See, this is after this. This is actually the relative risk with 95% confidence interval of factors that were actually affecting the occurrence of postoperative urinary retention. And as you will know, there are a lot of factors here, but the only factor that involved drugs are two. Here, the pre-OR antidepressive drugs and the perioperative use of diazepam. There are no other drugs that were mentioned in this study, not even morphine. So it actually excluded atropine, which actually I'm interested in. Well, what I actually would like us to concentrate on, being a person who's very interested in muscle relaxant and its reversal, is actually the effect of the use of atropine in relation to requirements during the anesthesia delivery, as well as requirements to prevent the side effect that occurs in association with reversal of muscle relaxant and the use of neostigmine. So let's look at this. This is a study. This is a Korean study that was actually came out in the journal in 2021. And what did it say? Postoperative patient satisfaction comparing the quality of recovery, the high score of 15 after the reversal of neuromuscular block with Sogamadex and neostigmine in patients who actually had laparoscopic cholecystectomy under general anesthesia, aged 20 to 70 years. So Sogamadex was given at the train of 4 count of 1 or greater, 2 milligrams per kilogram, and then Sogamadex 4 milligrams per kilogram was given at post-tetanus count of greater than 1. And neostigmine was given in comparison 50 micrograms per kilogram plus glycopyrrolate of 0.4. When the train of 4 count was greater than 2, the patient has recovered more. And then as well, when the train of 4 ratio was less than 0.4. Then neostigmine, the lower dose, was given when the train of 4 ratio was 0.4 to 0.9. And they were reversing rocuronium-induced neuromuscular block. The primary endpoint of the study was a global quality of recovery score at post-operative day 1. And the secondary outcomes were QOR at post-operative day 2, the Aldrete score, the length of post-anesthetic care unit stay, post-op pain, administration of antiemetics, urinary retention, and the length of hospital stay. And then post-operative urinary retention was diagnosed using bladder ultrasonography. And the results were there was no significant difference noted with the primary outcome in terms of quality of recovery in post-operative day 1. But in the secondary outcomes, they were all comparable except for urinary retention, where Sugamadex group had a significantly lower incidence of POUR compared to the ustigmin, and this was significant. The second study here was conducted by Cha, and this was another Korean study, but in an earlier study in 2017. This was now retrospective cohort in a university-affiliated hospital. 571 patients for total knee replacement or total knee arthroplasty between 2015 to 2016. And this was ASA risk of less than 3. And they were looking at the reversal of neuromuscular block, where Sugamadex was given in 208 patients, and Pyridostigmine with glycopyrrolate was given in 363 patients. The primary outcome was the incidence of POUR with urinary retention of greater than 400 mils, and the secondary outcome was hospital length of stay and daily residual urine drained. So what did they find out? That POUR was significantly lower with the Sugamadex group. Urine volume was significantly lower with the Sugamadex group. There was no significant difference in length of stay for both groups. And the conclusion was the use of Sugamadex was associated with a lower incidence of POUR by avoiding glycopyrrolate, which is an atropine-like substance that prevents the side effect that occurs with ustigmin. And this was in patients who underwent total knee replacement. Now, the third study, actually a fourth here, was done in the United States again in 2021. And this was retrospective again from January 2013 to September 2020. They had 181 patients who underwent unilateral herniorrhaphy, open or laparoscopic, and all received general anesthesia plus an aminosteroidal neuromuscular blocker. I think this one they preferred to use vecuronium. 75 of these patients, received Sugamadex, and 108 patients received ustigmin and glycopyrrolate. The primary outcome that they looked for was the occurrence of POUR, which was defined as postoperative inability to urinate and the need for urinary catheterization. So the conclusion was postoperative urinary retention was observed only in 2 of the patients who received Sugamadex and 16 in those patients who received ustigmin and glycopyrrolate. And this was significant. The difference was significant. The next study is from the United Kingdom. And again, retrospective for VATS. This is video-assisted thoracostomy surgery, which is under general anesthesia and 1 lung ventilation. The patient selection was from January 1 to June 30, 2016, which was before Sugamadex, and from January 1 to May 4, 2018, after the introduction of Sugamadex. And the use of reversal technique for vecuronium was discretionary to the anesthesiologist. So it can be either Sugamadex or ustigmin and glycopyrrolate. The reversal with ustigmin and glycopyrrolate was on 168 patients, and for Sugamadex, 108 patients. Again, these other parameters: surgical duration, opioid dose, intraoperative fluids, use of intraoperative urinary catheter, neuromuscular block reversal technique, hospital length of stay, and need for hospital readmission were all recorded. And the primary outcome was the occurrence of POUR defined as the need for urinary catheterization due to urinary retention, very similar to the other studies. And the results were the incidence of POUR with neostigmine glycopyrrolate compared to Sugamadex was significantly higher. And it was between POUR incidence on 24 patients for neostigmine and glycopyrrolate and only 4 for Sugamadex. Now there's a Danish study, and the conclusion is that the risk of developing POUR is approximately 5% in general surgical population studied, and coexisting diabetes mellitus and administration of atropine, whether as part of the anesthetic technique or as part of the reversal with neostigmine, actually was one of the predisposing factor for the development of POUR. Now, this one is, I think, another UK study, if I remember right. And the aim was to evaluate the factors for the development of POUR. This was now prospective, but observational study, consecutive, elective day case surgery. I would like just to add here that it becomes even more important, the incidence of POUR, now that there are more patients who are day case surgery patients, meaning they go home on the same day as their surgery. And it becomes more important in that if they actually develop POUR, they cannot go home. And sometimes these are unplanned, there are unplanned admissions due to this. And this is actually how they recruited the patients. So the data on urinary symptoms, comorbidities, drug history, perioperative drug were collected. And the primary outcome was the incidence of postoperative urinary retention, defined as impairment of voiding, requiring urethral catheterization, and unplanned overnight admission, or both. So the results were, they actually looked at 458 patients, and they collected data from 282. And from here, 16 patients experienced POUR. And on the multivariate analysis combining type of surgery, age, and glycopyrrolate use revealed that only age, meaning greater than 56 years old, and the use of glycopyrrolate administration were independently associated with POUR. So it's fairly consistent. The use of atropine-like substances during anesthesia were independently associated with postoperative nausea and postoperative urinary retention. Conclusion is, patients aged at least 56 years old and requiring glycopyrrolate are at increased risk of POUR following ambulatory general surgery. Now let's look at ill use. This is very interesting because this is a slide that we borrowed from Dr. Manuel Rojas. This is not yet published, but this is in the dashboard of the ERAS program in the Philippine General Hospital. And they looked at complications. And if you will look here at the left side of the slide, you're going to see here post-operative paralytic ill use, which occurred in 16% of their patients. Then here down here, postoperative nausea and vomiting occurred in 2% of their patients, and urinary retention in 1% of their patients. And these are the post-operative complications that we are interested in this lecture this afternoon. So you will note that post-operative ill use has a very high incidence in this ERAS program of PGH. And this is actually the same data. It's just in a different bar graph. And you will see here the 16% of paralytic ill use, which is actually rather high among the postoperative complications associated with ERAS and colorectal surgery. And here you have nausea and vomiting 2% and urinary retention 1%. So let's go back to the studies now, which are done abroad, and this one is Korean study in 2020. This was prospective. Lap Cole, 102 patients allocated, sorry. Oops, let's go back to the former slide. Allocated to Sugammadex group and pyridostigmine glycopyrrolate group. The primary outcome that was looked at, patients recorded the time on their first passage of flatus, which is called gas out time, and defecation. And of course, they added secondary outcome, which were the stool types. Maybe that's not very interesting. So Sugammadex after laparoscopic cholecystectomy under general anesthesia resulted in an earlier first postoperative passage of flatus compared with the use of the mixture of pyridostigmine and glycopyrrolate. This finding suggests that the use of Sugammadex has positive effects on the recovery of GI motility, meaning GI motility recovers faster, even with laparoscopic cholecystectomy surgeries when Sugammadex is used for reversal of neuromuscular block. This time, a US study done in 2019 in the Mayo Clinic, and they wanted to determine if first postoperative bowel movement after intraperitoneal surgery differs among neuromuscular block reversal with either anticholinesterase, anticholinergic combination, or Sugammadex. And the study cohorts were actually from January 1 to June 30, 2016, reversed with neostigmine and glycopyrrolate. There were several. Against patients from January 1 to June 30, 2017, who were given Sugammadex, with some of them were also given glycopyrrolate and neostigmine. The reason for these differences in years is because in 2016, like Sugammadex was still not approved for use in the United States. It was only after 2000, later on in 2016 that it was approved, because the approval came out from the FDA in 2015 in December. And patients on intraperitoneal surgery given aminosteroid neuromuscular blocking agents reversed with Sugammadex had earlier first post of bowel movement than patients reversed with neostigmine and glycopyrrolate. And here, a graph shows you the bowel movement and percent of patients in relation to the time from end of surgery. And you will note that with the Sugammadex group, the return of bowel movement was actually significantly much faster. Another US study, this time in 2020, and the objective was to determine if Sugammadex reversal with neuromuscular block is associated with decreased time to first bowel movement following laparoscopic colorectal surgery now. These are actually the patients who are given ERAS, or who are actually included in the ERAS program of most hospitals now. And the method was retrospective cohort analysis of 224 patients for lap colorectal surgeries. And they were divided into Sugammadex and a combination of neostigmine and glycopyrrolate for reversal of neuromuscular block. The primary outcome was the time in hours from neuromuscular block reversal until the first BM. And the secondary outcome was the presence of postoperative ileus, postoperative nausea and vomiting, and the prevalence of residual neuromuscular block and length of hospital stay. So the results were 128 patients received a combination of neostigmine and glycopyrrolate, 96 received Sugammadex. The time from first BM was faster in the Sugammadex group compared to the neostigmine group, and it was 11.7 hours earlier. So it is actually very significant. And Sugammadex maintained the effect in the multiple regression model, as well as the Cox proportional hazards regression model. So they were actually significant with these regression models. There was no adverse effects that were noted. And so conclusion and relevance. The first report demonstrating faster return of BM following colorectal surgery with Sugammadex when compared to neostigmine and glycopyrrolate is this study. And application of this data may add another tool to the ERAS program after colorectal surgery. Now we have the two Turkish studies that did not show any changes in the, well, there was no difference in the onset of BM in patients who received Sugamadex compared to patients who received the conventional reversal with neostigmine and anticholinergic drug. So here, the objective was to compare Sugamadex with conventional reversal of neuromuscular block. It was double-blinded, which was good, randomized, controlled clinical trial. However, there were only 72 patients, and it's ASA 1 to 2 for thyroid surgery. The measurement was time to first flatus and feces, and the incidence of PONV, diarrhea, and constipation were also collected. And this is how they recruited the patients. And the results were the median time to first flatus was 24 hours for the neostigmine group and also 24 hours for the Sugamadex group. So there was no difference. The median IQR time of first feces was 24 hours in the neostigmine group and 32 hours in the Sugamadex group. And there was no occurrence of PONV, diarrhea, or constipation in both groups. So the conclusion was Sugamadex may be safely used in cases where postoperative ileus is expected, as well as neostigmine with glycopyrrolate. Another Turkish study a little later in 2018, where the objective was to investigate the effect of Sugamadex and neostigmine on post-op return of bowel movements. Again, a small group, 60 patients, aged 18 to 65, for total abdominal hysterectomy, bilateral salpingo or bilateral salpingo oophorectomy, myomectomy under general anesthesia. It was randomized Sugamadex, Group S Sugamadex, and Group N neostigmine. Group S received Sugamadex following spontaneous respiratory effort, and Group neostigmine received neostigmine with atropine, 0.15 milligrams per kilogram, and neostigmine 0.3 milligrams per kilogram. And on follow-up, independent physician at 1, 4, 8, 12, 24 hours were observing for bowel sounds, and the time for gas release and defecation were noted. So their conclusion was, first, the results. There was no statistically significant difference in demographics between the two groups. The total anesthesia time was significantly shorter in the group for Sugamadex. There was no difference between the groups in terms of the first gas extraction time, defecation time, and patient discharge time. And the conclusion was there was no difference between Sugamadex and neostigmine in terms of the return of post-operative bowel movements. So my take-home message to you this afternoon is actually this, that when you are reversing with anticholinesterases, you will in fact need an antimuscarinic agent or anticholinergic agent to prevent the occurrence of side effects associated with the anticholinesterase, which are actually muscarinic type of stimulation type of side effects. So essentially, this is called autonomic dysregulation, all right? So let's look here first. You have here anticholinesterase, which is indirectly increasing because of its binding and removal of the anticholinesterase, the removal of cholinesterases in the neuromuscular junction. The breakdown of acetylcholine is prevented, and acetylcholine rises, all right, in the neuromuscular junction. So the effect is indirect. Because of the increase of the acetylcholine in the neuromuscular junction, there is reversal of neuromuscular block. So it's an indirect effect. So you cannot shy away from the effect of acetylcholine on other receptors, other muscarinic receptors all over the body. So this will include the gastrointestinal tract, the urinary bladder, as well as the heart. Okay, so let's go through this slowly. Here, if you have here the use of anticholinesterases and the combination of a muscarinic or an anticholinergic agent, what happens is the first here on the left, you have first the activation of acetylcholine receptors at the area postrema. I discussed that with you during the media refresher course, which is in charge of, actually you call this the, not the vomiting center, it is actually it is the one that actually is stimulated when there are drugs that are that has crossed the blood-brain barrier and can actually result in occurrence of PONV. Then there's blockade of the M3 muscarinic receptors at the GI tract. Okay, smooth muscles of the GI tract. So these are actually you cannot control this. These are smooth muscles, and it cannot be controlled volitionally. So what happens is there's activation of the vomiting center in the area postrema. This was the term I was looking for, the vomiting center in the brainstem. There is reduction of the smooth muscle peristalsis. There is reduction of lower esophageal sphincteric tone. There is reduction of the gastroesophageal barrier pressure. So what happens? There is postoperative nausea and vomiting. There is impaired return of bowel function. So you have actually the muscles in the esophagus allowing active vomiting. At the same time, there are central effects which initiates vomiting from the brainstem. Now, there's also blockade of the M3 muscarinic receptors at the urinary bladder. So there is reduced contractility of the detrusor muscle, which I discussed with you, and increased contractility of the trigone and the internal urethral sphincter, which actually results in the reduction of micturition speed. So what happens? There is post-operative urinary retention. At the same time, this is something we are more concerned with, so we are actually very aware of this. There can be blockade or activation of the M2 muscarinic receptors in the electric conduction cardiac system. So there is dysregulation of cholinergic neurotransmission at the heart. And there's dysregulation of heart rate and suppression of cardiac baroreflex sensitivity and heart rate variability. So what happens? You get cardiac arrhythmias. You can prevent all this if you will avoid using the triggers. So these are the triggers: the use of anticholinesterase with the combination of a muscarinic antagonist or an anticholinergic. And if you prevent use of this, you can have improved patient outcomes or journey, and there's an impact on healthcare resource utilization. This next slide is just something that that was actually made to make understanding of what are associated with autonomic dysregulations are. The one is the postoperative nausea and vomiting, the impaired return of bowel function, postoperative urinary retention, and of course, the problematic cardiac arrhythmias. With this, I would like to thank you for listening.
Thank you very much, Dr. Audi, for that very nice lecture. It's very nice how you were able to connect the dots na sometimes yung choices natin for neuromuscular blockade management, the reversal. Minsan, hindi natin nako-connect that the antimuscarinic, the atropine that we give to counteract yung bradycardia ng neostigmine has wide implications in terms of autonomic dysregulation. So thank you very much for that very interesting and very informative lecture. And ang galing rin how you were able to identify na actually may populations at risk. Yung kala natin diabetes lang, pero pwedeng may impaired micturition na dahil merong nerve damage. Nagsisimula na. Meron ka ng neuropathy. Tapos if patients are older than 56, then that risk for poor goes even more.
Increases also. That's right. That's right.
I guess, ma'am, on reflection, I guess, okay, I just like to remind everyone that you can type questions in the Q&A tab if you have questions, and we can address Dr. Raoni for that. So I guess the very first question I have, ma'am, naisip ko, there was something you taught me during residency na, for example, nasa pa ako after spinal, in a patient na hindi previously hypertensive, gising, tapos may hypertension siya, nagtachycardia siya, dapat kasama sa differential diagnosis ang urinary retention. Pero naisip ko, wala namang nurse na nag-refer sa akin na na doc, hindi makaihi. Do you think it's an awareness thing na hindi ko siya nakita during residency, despite the literature clearly saying that it's there? It could be anywhere from 5 to 70%. Pero I was just thinking, bakit sometimes in the real world pwedeng ma-miss?
I think siguro kasi we are not really looking for it. If you're looking for it, you'll start palpating the abdomen, something like this. Because if you have a patient, I think kung nagre-recover lang yung patient from anesthesia, usually hindi yan nagko-complain masyado, hindi ba? Hindi na nga makahinga, hindi pa magko-complain, hindi ba? Kasi they are just recovering from anesthesia. So unless you look for it, you probably will not find it. Or maybe unless you ask the patient for it. And then it is also, as the Turkish study showed, if you have a small number of patients, even if you have a prospective randomized trial, and then if you have a complication that is not very frequent, you don't find it, diba? You have to have a larger number of patients to be able to find it, and you have to look for it to be able to see if it's occurring, something like that. You are not looking for it. Pero when I was studying this subject, I was thinking, if you were in the receiving end of it, diba? Kunyari ikaw yung pasyente, tapos naiihi ka na, tapos hindi ka makaihi. Tapos nandun ka sa recovery room, and the nurse is over there in the station, and hindi pa siya lumalapit sa iyo, hindi ba? You can imagine how much your suffering is. I always like to reverse the table, kasi tayo mga doktor tayo. Okay tayo, we see the patients, they're not complaining. But then what about the patient, di ba? I was a patient once. Did I tell you that story? I was a patient. I had, I don't know, I think it was my total hip replacement. And they placed, the anesthesiologist placed fentanyl epidurally to me. And I was vomiting and vomiting and vomiting and vomiting. And so I called the nurse, and before the nurse can get there, I have vomited. So I said, you better leave the plastic here beside me. I will take care of myself. You leave the plastic, I'll just vomit and then seal it up and give it back to you when you come here and get from me, something like this. But then again, it's something that you balance. Because I knew as an anesthesiologist that the fentanyl was given to me so I will not have any pain. So I was balancing it between having the pain and vomiting, not having the pain with the fentanyl and vomiting, or not vomiting but have the pain, parang something like this, di ba? So it's a balance between that. Sa akin, mas importante sa akin na wala akong pain kaysa ako suka ng suka. But then there are patients who think that it is more unpleasant to be vomiting all the time than suffering the pain. Something like this. So it's something that is actually individual, but at the same time extremely unpleasant either way. Pain is unpleasant, but vomiting is also extremely unpleasant.
So I think that one of the takeaway messages there, ma'am, is during the pre-anesthetic visit, dapat ma-inform yung pasyente that these kinds of things can happen. They would expect the pain, pero there's a pretty good chance they may not expect post-op nausea and vomiting, which can actually make them feel worse.
Yeah, they should be told about it, and that at saka post-operative urinary retention. Ikaw ba na-operahan ka na ba?
Ay,
hindi pa. I had not a surgeon, a colleague, a very, very good friend and a colleague who was a patient of mine. And then I bata pa ako noon so I made a mistake. I wanted him not to have any pain at all. So I placed a small dose of fentanyl in the intrathecal space for a hernia. 5 hours later, I got a very urgent call kasi he cannot urinate. This was with fentanyl. This is spinal anesthesia.
So imagine
Oo.
kahit rare, pero kung ikaw 'yon,
Kung ikaw yun,
hindi mo makakalimutan.
hindi na niya nakalimutan yon. And for the longest time, I couldn't hear the end of it.
And actually, ma'am, napaisip rin ako rin eh. Let's say, for example, colorectal procedures, gynae procedures, pwede mong isipin na, kasi may ginawa sila dun sa anatomy, dun sa area na yon, kaya hindi makaihi. And something that you pointed out is one of the risk factors is spinal anesthesia. Tapos, kung total knee or tapos biglang hindi makaihi, mag-iisip yung pasyente, di ba? Na, teka, tuhod kayo ninopera, ba't hindi ako
naman ako
makaihi?
inoperahan dito sa akin tiyan, di ba?
Oo, yes,
Ba't ako
ma'am.
din makaihi? Oo. And another thing, Joseph, most of us now, parang ang tendency ng surgery ngayon is minimally invasive, di ba? Minimally invasive surgery na sila ngayon. So, you'd expect na kukonti, hindi ba? Pero yung mga pasyente nung you saw in one of the study, it was laparoscopic cholecystectomy, mataas pa rin yung incidence nila ng with if you use neostigmine glycopyrrolate as reversal. And for minimally invasive, because they have to put carbon dioxide inside the abdomen, kung abdominal
Yes,
yung
mas
surgery
stretch.
nila. Oo. Talagang hindi ba?
It's a cold dry gas. So, hindi siya
Yeah,
totally walang ginagawa
walang
sa
ginagawa sa
abdominal organs. Yes, ma'am. There's a comment by Dr. Herbosa. Being able to urinate freely is part of the discharge criteria from PACU,
That's
unless it is
true.
not expected to happen. And nurses inform us if the patient is unable to urinate.
Yes, ganun talaga yun, di ba? Especially sa day case. Day case surgery, you cannot send them home unless they have feed.
There's another comment. Hi, ma'am. Do we have a known dose for centrally placed opioids? I think tinatanong kay ma'am regarding the balancing. So is there a known dose for centrally placed opioids where urinary retention is to be expected? If yes, can we avoid using that dose? And dagdagan ko lang ng konti, ma'am. Does, let's say, using fentanyl instead of morphine, that the kind of opioid you use, do you think it will make a
I don't know,
practical difference?
might make a difference. Sabi ko na, ito si Sherwin tao yan, papahirapan ako eh. Hindi ko naaral, Sherwin. I do not know if there's a dose. If I would think that if you use a small dose, that there's going to be less occurrence of POUR as you had suggested. I would think na pwedeng ganon. Pero it's all individual, hindi ba? Kung minsan you have a patient, you have kunyari 2 patients like like the patient I had who had urinary retention, pareho sila ng age, pareho silang heniorrhapy, pareho mong bigyan ng fentanyl. Fentanyl isa magre-retain, isa hindi ba? Ganun yun eh. So let me search if I can find the answer to your question. Siguro ikaw na lang ang mag-search, Sherwin, and then tell me.
Assignment.
Assignment mo yan. Ayan. Kasi si Sherwin is also one of the residents under me.
And ma'am, I have a question now that you bring up in the importance sa ambulatory and day case. Given na important siya sa day case, balik na rin natin yung question. Tignan natin dun sa admitted. Iisipin nila, ano naman nga kung mag-urinary retention, admitted naman eh. It's something we can wait out or ill-use. Nag-i-ill-use naman talaga tapos admitted naman. How do you react to admitted naman? So, yes, ma'am.
Ito na, i-reverse ko na naman yung table eh. Kasi I have a lot of experience with surgery in 2013, one after the other yung surgery ko. Nasubukan nyo na ba ang manual extraction of feces? Ikaw yung pasyente?
Hindi, ma'am. Ako yung intern.
Ikaw yung intern.
Ako yung nagtatanong.
Kung ikaw yung intern, hirap ka, di ba?
Yes, ma'am.
Kung ikaw yung pasyente, it's terrible because it is actually, parang your, privacy is actually so violated. Kailangan kung minsan, kasi kung minsan yung ileus mo, ako, hindi arthroplasty, um, basta surgery siya, pero hindi siya intra-abdominal. Ganon. And kailangan i-extract. Kasi, constipated. Ano yun? Admitted patient yun.
And at the same time, ma'am, isipin nila, admitted naman, kung di makaihi, di catheterize.
Catheterize.
Napaka-cavalier ng attitude towards catheterization.
Yes, and sabi ko nga, in males, the urethra is long. I do not know kung meron sa audience natin na anesthesiologist na naoperahan na ikinatheterize. It's very unpleasant. Sa women, hindi masyado kasi maiksi lang ang urethra ng female. Pero yung male, mahaba ang urethra nila. So it's unpleasant for them. Then repeated catheterization if the patient does not volitionally micturate. Kung hindi siya iihi volitionally, catheterization siya ng repeatedly, then that's going to bring in infection, di ba?
Yes, ma'am. So hindi porket hindi mo nakikita, or hindi porket rare, hindi siya lang, 'di ba? Hindi siya urinary infection. Urinary retention lang or ileus lang.
Hindi lang.
There are serious considerations in terms of patient comfort, patient satisfaction.
Oo. Sige, tapos ka na ba, Joseph?
Yes, ma'am.
Muntik kitang
No, go ahead, ma'am.
I would like to add here, for the longest time, we have been actually taking for granted pain, di ba? Kaya yun ang pinakamalaking criticism sa mga pain managers, that post-operative pain has not been actually addressed completely even up to now. Pero kasi generally, if you're going to ask patients, you're going to determine kung ano yung nila, patient satisfaction nila, at saka ano yung degree nila ng pain nila. Mataas ang degree, ang intensity ng pain nila, pero ang satisfaction nila mataas, hindi magkapareho, hindi magkasabay. Ibig sabihin, kunyari 50% ang satisfaction, ang pain nila is mga 75, mas mataas, parang something like that. The reason for that is it is expected. Yung parang if you have surgery, you expect to have an unpleasant time. You expect to have pain. That's why you do not complain. But it's something that we have parang taken for granted na, di ba? Kaya for the longest time, it has not been addressed. We're starting to address it. Now, actually, we have tried to address it. Kaya lang parang pahaba yung problema. As you solve one problem, you have another problem in front of you, parang something like that with pain management. But then, yun ang reason. Kasi things are taken for granted as norm. Like pain is norm, urinary retention is norm, hindi ka matae is norm. It's not nice, diba? It's not norm. It's not norm.
If it can be avoided,
if it can be avoided, that's going to make a lot of difference to the quality of recovery of the patient.
Ma'am, we have time for, I guess, just one more question. And I think for us with any medical education event, maganda if there's something you hear today and then Monday magagamit mo. Now, it's good that you presented yung mga centers na may ERAS katulad ng PGH na they have a very structured way of doing things pre-op, intra-op, and post-op, specifically to avoid these things, to avoid PONV, avoid urinary retention, avoid ileus. Ngayon, something na relatively popular, let's say for example sa Australia, in term na ginagamit nila is care bundles. So if you can have a top 3 recommendations na 3 simple interventions na kayang gawin sa lahat to reduce, let's say for example, urinary retention and ileus, what would your top 3 recommendations be? Yung kumbaga dekahon na, pag ginawa mo to, very likely bababayin urinary retention mo. Pag ginawa mo to, bababayin yung
yung first one, you cannot do anything with age, no? Kasi talagang you have
modifiable.
But then you will expect it. Kunyari you have an elderly patient, you will expect na so you are going to be more alert in trying to avoid the things that can initiate it, di ba? One would be syempre one would be ito muna sasabihin ko. You have to reduce the try to be very, ano ito, lucid or very rational in the giving of fluids. Okay, that's one. Second, be very rational and very matipid in the choices and very careful in the choices of the drugs that you will use. Kagaya niyan, you try to avoid as much as possible opiates, and as Sherwin said, you lower the opiate dose, chances are you do not get these problems, or you might have less of these problems. And of course, the use of atropine-like substances. Kasi this is going to reduce the, not only urinary retention, but also paralytic ill use. Di ba?
Yes, ma'am.
And then the third one, ano pa ang third one? Ikaw magbigay ng third. What do you think is the third one?
Akong naisip ko, pain control. Kasi
yes.
may bladder spasm eh. Kung nagsaspasm, hindi makakaihi. Yun lang yun off the cuff na naiisip ko, ma'am.
Pero true, hindi ko lang in-include yung pain control kasi I just assume na natapos na tayo dun sa pain control eh. And that we're just going to look at ano. Pero yeah, you're right. You're right.
Ma'am, there was a comment, a compliment to you. Thank you very much, Dr. Odi, for this humane and compassionate lecture.
Oh, thank you, Dr. Chua, Nicole.
So I guess, thank you. I would like to thank you po ulit for this very informative lecture, very entertaining lecture as well. So thank you very much. And
thank you for making it entertaining too, Joseph.
Yes, ma'am.
I'm so relaxed with you.
Looking
And
forward to
Sherwin,
seeing you
yung
po again.
assignment mo ha, Sherwin, saan ka? Yan.
Pa-email na lang.
Email mo sa akin ha.
So again, we'd like to thank the audience. We'd like to thank Dr. Odi. And before you sign off, there's an evaluation tab, I think. And please fill it up so that we can take your feedback so we can improve the sessions even more. So again, thank you very much, Dr. Odi.
Thank you very much. Thank you very much, everybody, for listening. It's late in the afternoon. Thank you.
Okay. Thank you.